Good morning. Yes, okay. Good morning, everyone. My name is Lim, came from Korea. So welcome to the Casmiss Central Asia and the Spine, the Minimum Invasive Spine Surgery Society. The first door, let's give a big loud of applause to Dr. Shomansuru. Thank you for preparing well the organized conference this time. So we have a long history, the endoscopic spine surgery in Uzbekistan. 8 years ago, when I visited for first time here, I had a doubt about whether it would work. But now, endoscopic spine surgery in Uzbekistan is a major operation. And for patient, the spine patient suffered from spine patient, no longer need to visit the other country to get the operation. Now, the patient from the other country visit the Tashkent to get the endoscopic spine surgery has increased. It's amazing, incredible, the change. I think it's the power of the endoscopic spine surgery, right? That's a big change. Anyway, it was, I think, one of the successful social experiment of endoscopic spine surgery, the test bed. Right? This is because we have an excellent endoscopic spine surgeon here, like Dr. Akor and Dr. Shomansuru, and because of active support to us, the Professor Shurov. Thank you so much. And we have the big dream is to establish the Casmiss will becoming the best endoscopic spine society and the qualified endoscopic spine society in the world. It's my dream. We will try to do my best for this. And the conference is, I think, a good time and good place to exchange the academic information and teach, learning each other like this at the Casmiss. Please go with us, Casmiss, forever, and enjoy beautiful the capital city Uzbekistan, Tashkent. And then, so we have a plan to some workshop in the world with our teams. Please join us. Enjoy Tashkent. Thank you. And then, your part. Yeah. Yeah.
tarjimoni sinxron kirib ketdi.
Kichkina quloqda yo'qmi?
Yo'q, taqib o'tishibdi, taqib o'tib kimga kerak bo'lsa
o'zbekcha gapiraman.
Gapirdinglar. Hozir bizada travmatologiya va ortopediya markazini ilmiy ishlar bo'yicha zam direktori Murod Muhammedovich so'z beriladi.
Assalomu alaykum. Hurmatli qadrdon do'stlar, hurmatli hamkasblar. Afsuski, markazimiz boshlig'i direktori professor Irsmetov hozir xizmat safariga ketganlari uchun ushbu anjumanni tabriklarini, o'zlarining tabriklarini o'qib berishni mendan so'radilar. Shuni o'qib beraman. Hurmatli hamkasblar, bugungi anjumanimizning ishtirokchilari va mehmonlari, xonimlar va janoblar, faqat xonimlar ko'rim bor ekan, xonimlar, janoblar. Respublika Travmatologiya ortopediya ilmiy markazi, O'zbekiston Travmatolog ortopedlar assotsiatsiyasi nomidan barchangizni muborakbod etishga ruxsat bergaysiz. Ushbu anjumanni tashkil etgan tashkiliy qo'mita raisi professor Limga va boshqa qo'mita a'zolariga alohida minnatdorchiligimizni bildiramiz. Bugungi konferensiya mamlakatimiz travmatolog ortopedlari va neyroxirurglari hayotida muhim voqea hisoblanadi. O'zbekistonda vertebrologiya sohasi ko'p yillik tarixga ega, lekin aynan so'nggi 10 yil ichida kam invaziv umurtqa xirurgiyasiga alohida e'tibor berilishi tufayli kichik hajmdagi operatsiyalar ulushi keskin oshib ketdi. Ayniqsa, endoskopik texnologiyalarning tibbiyotimizda keng qo'llanib kelayotganligi faqat poytaxt klinikalaridagina emas, viloyatlarimiz kesimida ham o'z o'rnini topib borayotganligi biz uchun juda quvonarli hol. Bu borada professor Shotursunov boshchiligidagi o'zbekistonlik mutaxassislarimizning xalqaro darajada erishayotgan muvaffaqiyatlarini alohida qayd etishimiz lozim. Bugungi anjuman bu jarayonga yanada rang-barang tus beradi. Yanada ko'proq davolash usullari o'zlashtirilishiga, mutaxassislarimiz bilim va amaliy malakasining ko'tarilishiga va oxir-oqibat aholiga ko'rsatiladigan tibbiy yordam sifatining oshirilishiga xizmat qiladi deb ishonamiz. Anjumanning barcha ishtirokchilariga sog'lik, salomatlik, tinchlik va xalq salomati yo'ldagi xizmatlarida ulkan muvaffaqiyatlar tilaymiz va bugungi konferensiyamiz, bugun ertangi bo'ladigan konferensiyamiz ishini muvaffaqiyatli tugallashlariga ishonamiz. E'tiboringiz uchun rahmat.
Keyingi so'z Respublikamiz travmatologiya va ortopediyasi vertebrologiya bo'lim professori Shotursunov Shohaydar Sholiyevichga beriladi.
You will show here your presentation.
Да. Куда? Нажимать? Вперед. Сюда? Переводить.
Ты включил?
А здесь плохой? Не проходит же?
Не проходит. Вытащи и включи заново. Он должен загореться зеленым.
Вот это, да, сюда? Вперед-назад. Assalomu alaykum, hurmatli konferensiyamiz qatnashchilari. Ruxsat bersanglar, O'zbekiston vertebral xirurgiya doktorlari nomidan konferensiya qatnashchilarini men muborakbod etmoqchiman. Bugun biz uchun juda mas'uliyatli va xursandlik kunimiz, chunki mana 3-chi marta, я немножко на русский буду переводить. Мы проводим 3-й конгресс, конференцию по спинальной хирургии под эгидой УЗМИС. Это значит малоинвазивная спинальная хирургия общества Узбекистана. Нам удалось создать 5 лет назад, и сегодня нам удается проводить 3-й конгресс, но мы именовали этот конгресс среднеазиатский минимальной инвазивной хирургии, потому что сегодня, на сегодняшний день в Узбекистане и вообще центральные азиатские страны объединились вместе, хотим организовать такое общество спинальной эндоскопической хирургии центральноазиатских стран. Я приветствую всех участников, и особенно я хочу отметить, что сегодня президент нашей конференции вообще отдельная благодарность доктору Лиму, отдельная благодарность, потому что основу спинальной хирургии Узбекистана нам удалось создать совместно с нашей работой доктором Лимом. Также я хочу приветствовать других наших участников. Сегодня около 100 участников нашей конференции. И в основном это страны Юго-Восточной Азии, страны Ближнего Востока, страны Центральной Азии, наши страны, европейские, большая делегация из Индии, большая делегация из Турции, наши друзья, турецкие наши коллеги. Давно мы сотрудничаем с ИСМИС. И наше общество, Центральноазиатский минеральный суджи, организовано на основе, конечно, организации ИСМИС. Организации ИСМИС нам 15 лет назад, в той конференции я говорил, нам удалось стать членом организации ИСМИС в Цюрихе, профессор Хансурой, президентом, и постепенно мы начали развивать спинальную эндоскопическую хирургию в Узбекистане. И с 2017 года нам удалось тесно сотрудничать с профессором доктором Лимом, Корейское общество спинальной инвазивной хирургии, и на сегодняшний день проводятся многочисленные спинальные эндоскопические операции в Узбекистане. Ну, то, что здесь показано, какие операции у нас проводятся, это значит, трансфораминальные, трансфлавальные, и в шейном отделе, грудном отделе, поясничном отделе. И основа заслуги, я еще раз повторяю, это профессор доктор Антаклим, с которым мы 10 лет назад организовали, создали меморандум, и совместно этого меморандума нам на сегодняшний день вышли на такой уровень работы. Многие наши специалисты проходили обучение, в основном 90% в Корее, в школе доктора Лима. Какие операции проводятся, как проводятся, об этом я много не буду говорить, но основная методика PCLD, поменяет Кибай доктор Лим, и эта операция по результатам, по конечной клинической эффективности этой операции, разработанный доктор Лим, является на сегодняшний день, по нашему мнению, одним из самых эффективных операций. Но кроме трансфораминальных и трансфлавальных операций, мы широко начали применять в последнее время с нашими турецкими коллегами бипортальные оперативные вмешательства, бипортальные спинальные операции. Ну, оборудование, вот сегодня наши спонсоры многие, какие оборудования у нас проводятся, это, значит, Reospine, Maxmore, Sraker, и Карл Штос, Джой Макс, основные хорошие, в смысле качественные зарубежные аппаратуры нами на сегодняшний день широко применяется в спинальной эндоскопической хирургии. Значит, статистика какая? Значит, здесь немножко не попало. Значит, как я говорил, основная операция наша – это PCLD по методике, где-то около 80% операций, и около 10% операций по трансфораминальной и по бипортальной методике. И большинство операций мы проводим в поясничном отделе, конечно, и в шейном отделе около 10% и около 5% в грудном отделе позвоночника. Нам удалось развить спинальные эндоскопические операции по всей республике. Кроме Республиканского центра травматологии и ортопедии, эти операции широко применяются в других частных клиниках нашими коллегами, учениками, специалистами. Это, впервые мы начали эти операции проводить в клинике Профмедсервис, частная клиника, ну, потом Шахмедцентр, клиника Джексов, на сегодняшний день М-клиник и другие клиники также в Ташкенте владеют эти аппаратурой, современной хорошей аппаратурой, с которыми проводим эти операции. Кроме того, нам удалось по республике создать сеть в областных клинических центрах, где проводятся эти операции. Это Андижанской области, многие наши специалисты здесь они участвуют, в Ферганской области, Хорезмской области, Самаркандской области, Бухарской области, Кашкадаринской области. И нам хотим до конца года проводить во всех областных центрах, широко применять спинальные эндоскопические операции. Если посмотреть на статистику вообще, историю я хочу посмотреть, показать, впервые начали в 2018 году, но в 2019 году проведено 54 эндоскопических операций на позвоночнике. В 2020 году уже в связи с COVID меньше было, в 2021 году 300 операций, в 2022 году уже было проведено 2000 операций, в 2023 году уже 3500 операций спинальных эндоскопических, в 2024 году уже мы проводили около 5000 операций в шейном, грудном, поясничном отделе по спинальной эндоскопической хирургии. Я считаю, это очень большая цифра. И дальше мы будем развивать, готовим специалистов. И около 80% этих операций проводится в поясничном отделе, 15% в шейном и 5% в грудном отделе позвоночника. А кадровый потенциал, если посмотреть, вот за 10 лет нам удалось подготовить более 30 специалистов, молодых, креативных специалистов, владеющих эндоскопическими спинальными операциями, и основные из них проходили обучение в Корее, доктора Лима также проходили обучение в Турции, в Индии и юго-восточных других странах. И каждым годом отрадно, что растет количество молодых специалистов, владеющих этой методикой. И в ближайшем будущем вот мы хотим распространить эти операции. Вот в последние годы мы широко начали работать с нашими киргизскими коллегами. В Ошской области также налажена эта операция. В Казахстане налаживается эта операция, город Астана, город Алмата, наши специалисты и коллегами, совместные операции, оборудование. И уже в Казахстане уже будут доклады. Там также начали широко применять эти операции совместно с нами. И не зря мы хотим создать Центральноазиатский минимальный спинальный суд. Совместная наша работа, надеемся, приведет к развитию этой отрасли высокотехнологичной спинальной операции по всем странам Центральной Азии. В Таджикистане уже вот намечается, скоро будет тоже Душанбе и Ленаваде. Эти операции тоже будут проводиться под эгидой Casmiss, и на 2-3 года наши планы все широко внедрять эти операции в наших республиках. Еще раз поздравляю наших участников. Мы надеемся, спинальные хирурги Узбекистана надеются, что наша конференция, третья конференция, даст нам новый стимул для развития этой отрасли. И молодых специалистов будут стимул в дальнейшем обучаться этой методике. Новые технологии, вот выставка новой технологии по применению эндоскопических спинальных операций и будут широко применяться в республиках центральноазиатских стран. Еще раз благодарю всех участников и надеемся на успешную работу в нашей конференции. Спасибо за внимание.
Следующее слово дается главному нейрохирургу страны Кариеву Гайрат Маратовичу. Пожалуйста.
Ассаламу алейкум. Доброе утро, господа участники данной конференции. Действительно, сегодня большое событие, большой праздник у наших коллег, травматологов, вертебрологов и нейрохирургов. Если посмотреть, вертебрология действительно сейчас занимаются ее лечением и нейрохирурги, и травматологи. И эта проблема еще далека от решения своего. То, что внедряются эндоскопические технологии, это очень хорошо. И я рад, и сейчас цифры увидел, что количество эндоскопических спинальных хирургов уже увеличивается. И сейчас, если посмотреть по карте Узбекистана, она не только в Ташкенте. Лидеры это Андижан, Бухара, Хорезм, все уже начали заниматься, и результаты отрадные, хорошие. Но не надо забывать, что лечение позвоночника – это не только одна операция, это и реабилитация, это и правильная диагностика в первую очередь, то есть выбор. И я думаю, что на этой конференции как раз эти вопросы и будут обсуждаться – диагностики, лечения и дальнейшей реабилитации. Хочу пожелать участникам сегодняшнего форума, самое главное, чтобы вы здесь обменялись опытом, поняли, какие вас ждут и проблемы, и как их решать. И вам всем удачи. Спасибо.
Thank you, everyone. This was opening and welcome words. Thank you for coming. Now we will start the scientific part. I will invite Dr. Lim and Dr. Silam Pontpari to moderate the session, please. And Dr. Lim, you will be the first who will give the speech, the topic.
Good morning. My name is Dr. Pornpawit Sipirom from Thailand. In this morning, I'm very proud to introduce Dr. Lim Kang Tek, who will be the first honorary speaker, and he will talk about the full endoscopic lumbar fusion, anatomy, and workflow. Dr. Lim Kang Tek, please.
It's not working.
Can you use our laptop?
No, no. No, I need to use this. Yeah.
This?
Yeah.
I have some problems.
Okay.
Start. Duplicate, no? Maybe. We have your presentation on our PC.
Why?
Maybe I'll try editing next.
Okay. Yeah, HTML.
Он не хочет. It's not working. Not.
Okay. So. Okay. So. Good morning, everyone. I will talk about endoscopic fusion. Today, the decompression for the spine disease pathology is very popular everywhere in the world. But now that we have a second stage is endoscopic fusion, like a lumbar fusion, trip, and then cervical also. Cervical, the HDF, we can do that using endoscope spine surgery. So some of audience like the Mati, will you? They'll talk about the cervical, right? HDF. So every case, every pathology, the spine, we can do solve the problem with endoscope spine surgery. One of them is the fusion surgery for lumbar. I'll talk about this. So it's my disclose as we are the homo endoscopicus, right? We like, performing the endoscope spine surgery, right? Without endoscope spine surgery, it's impossible to survive as a spine surgeon in Korea. It's same like in everywhere in the world. That's why we are here to teach the learning each other again. So 2016, so we had introduction of endoscope spine surgery in spine field. After that, what happened? What changed in spine field, in human life? So with the endoscope, we can do, as I told, we can do everything. Lumbar discectomy, fusion, and every approach, foraminal approach, posterior approach. and fusion surgery also, right? Yeah, so, and for the patient, will guarantee the faster return to their normal life. And the change in, it's remarkable, the change in the indication of a method of spinal surgery. And the total case of fusion surgery has been decreased. Why? We can do direct decompression without fusion surgery. It's very useful for patient because we can guarantee the just 1 day hospitalization, and the patient can return to their normal life after the finish operation next the day. Just 1 day hospitalization is enough, right? In spine surgery in Korea, so most of the spine doctor, I think more than 70% spine doctor will performing endoscopic spine surgery. It's a major operation, but some the doctor trying to the microscope, very rare case. And then some doctor trying to deformity. And the patient knows what is they know. There's very the formula searching the internet, what is a unipolar, bipolar microscope, they know. That's why the patient want to get endoscopic surgery in Korea now. So for the indication of change of indication, this patient have the spondylolisthesis, but autofused. This patient have only L5 dermatom pain. In that case, we have performed big open surgery and fusion surgery for the correct the lordosis and the surgical reduction. But patient have only foraminal problem. In that case, we have to try decompression foraminal. After that, patient have no pain. And the next time, patient can return to their normal life, right? We can change the indication of the spine surgery. So this patient have the 82, like your mother, right? So 82, old, the female patient have listhesis. But CT scan shows what? Autofused. Also, this patient have L5 dermatom pain. Most of the spine doctor recommend fusion. But in my hospital, I tried. Why? Main patient problem was L5 dermatom pain here, stenosis. That's why I tried. Yes, this is a main cause of pain. Thick ligament flavum. After that, we can expose L5 root. After that, no pain. So patient can return to and can discharge next day. So you know very well this. With a one skin pole, we can do 1 level, 2 level, 3 level with a jumping technique for spine, lumbar, and the cervical sliding technique. That's why in case of the cervical case, especially big open surgery laminoplasty was no longer necessary. Just the posterior decompression, as endoscopic decompression is very useful. Okay? So 2 level decompression also, right? Multiple level like this, 3 level also with one skin pole we can do. 4+2 operation for central stenosis and 2 level foraminal stenosis. We can do 1 skin pole, we can do 4 level decompression and the 2 level foraminal decompression with just a 2 skin hole. Right? Patient have 6 range, but patient can discharge the next day without fusion surgery. It's so the big change in indication of we can avoid the fusion surgery in spine field with endoscope surgery, right? This is my paper, how to. And so cervical case, so endoscope you can do, the posterior decompression and endoscope HDF. I think maybe the Dr. Mati from the Thailand will talk about this endoscope HDF, right? Thank you. Yes, every case we can solve the problem with the endoscope spine surgery, right? With the anterior, posterior, anterior, right? And anyway, for cervical microscope HDF, we will change it to the endoscope HDF, and the laminoplasty was no longer necessary. As I'll talk about the fusion surgery, how to. In that case, the patient have a severe back pain. Main cause of the back pain was the instability motion caused back pain. In that case, we had to performing the fusion surgery. It's impossible to perform in the decompression. So same the endoscope we can do. Okay? It's my first endoscope fusion surgery was performed in 2017. So after the removal of the facet joint, we can expose the traversing root, L5 root, L4 root after the facet remove. And we can create a space to insert the cage. That's by the comparative study for the endoscopic fusion and microscope. Very successful the operation for the fusion surgery. So we can use, it's the same like the open surgery, we need to consider how to remove a disc as much as we can to create the fusion bed area, and need to consider the lordosis and the surgical reduction also, same like the open surgery. Yes, but the problem in Korea is the patient, getting the aging society, becoming aging society. Most patients are the old, 75 or 80, but without under the general anesthesia, it's very difficult to performing the fusion surgery for this old age. But the endoscope spine, the fusion surgery we can do under the local anesthesia is an advantage of endoscope fusion. So approach is the first in case L45 landing point is skin and landing point is upper the lamina and from the midline. We can calculate the distance from the midline. The 3 centimeter is the pedicle direction, 30 centimeter, and then we can do the total fascectomy and ipsilateral, and we can do contralateral the part. This fascectomy is possible with one skin port, and then we can insert the endoscopic system into the disc space. It's very useful because we can do discectomy as much we can. More we can remove the disc. We can make more the fusion bed area is the advantage of endoscopic spine surgery. With one skin port, we can do ipsilateral fascectomy and then contralateral the fascectomy, and then we can do the discectomy as much as we can, and then cage insertion. And additional 3 skin incision required to insert the pedicle screw. So total the operation time is less than 2 hours enough. Right? So with the endoscope, we can insert the endoscope system into the disc space. That's why we can remove disc as much as we can, right? And then allophoreal graft, and we can insert the cage. Yes, and so we can reach to the upper side to remove a disc, ipsilateral and the contralateral side. Same. So in the open surgery microscope, so we can make the fusion bed area. I think the 30% is maximum. But the endoscope, we can insert the endoscope system into the disc space, so we can create the space for the fusion bed area, more than 40, the 50% bone graft area. It's very the advantage of the endoscope spine fusion surgery. And the cage, we can insert the cage in the midline, like this, or allophoreal graft, the same like the open surgery. First, we had to insert the allophoreal graft, and we can insert the cage, the midline, okay? And then, placement of anterior to correct the lumbar lordosis. Okay? Cage hold, and we can insert. Yeah. So we use the 30 perimeter porous the Titan cage is very useful to increase the fusion bed fusion rate and the case, right? Pre and post operative. You can make a space for reduction is very good because I do performing the bilateral decompression, bilateral fascectomy. After bilateral fascectomy, you can make good lumbar orthosis, and the surgical reduction is very nice. Right? Always the bilateral decompression is very useful. Okay, so, and then KG outcome is good, pre and post operate, and to correct the lumbar orthosis, we can use the KG anti-replacement, and the reduction is very good, every case. So bilateral fascitum is very useful to correct the lumbar orthosis and correct the surgical reduction also. It's all process. Under the endoscopic view, we can do. Okay, same. So we don't have any the muscle damage. That's why some post-operative back pain is very less. Yes, we can preserve the muscle damage, small scans and like that. Yes. So the next stage we will introduce the electron endoscope. It's very expensive, the optic lens endoscope. At the end of this month, we will introduce this electron endoscope for you. In terms of durability, very strong and very cheap than the optic lens endoscope. This is the electron endoscope. It's optic lens endoscope. So the education program, the endoscope spine surgery, is very important. So we have the hospital. We have the endoscopic education program, 2 weeks, 1 month, and we have the good team. So, do you know Endofia team is so we will track you to the end of the earth to teach you. Okay? So my good team, so Mongolia and Turkey, Thailand, Uzbekistan, India, Philippines, and Taiwan. Yes, we have a new endoscope system like this, okay? And the USA also. Endofia team. So first, it's very important to organize the good education program in the world. The first is we have done the Dehradun, India, with a cadre workshop and the teaching program. It's good. Dr. Pandey will organize. And here, today, we are here to teach learning the endoscopy program. Dr. Shomansura and Akor will organize every year in Central Asia. And so we are going to Bangkok on this month, in May, Bangkok, to get the cadre workshop there. And we will organize the first endoscopic International Cervical Society program in Seoul, Incheon, Korea. So I will invite you here. And Brazil, October, we will organize the Endofia team will organize 2 city education program in Brazil. And then on the September also, Dr. Alex Liu will organize a cadre workshop in Thailand. So please join us. It will be good for you to learn the endoscopy education program. And I don't know why, maybe Dr. Tata will organize, we will discuss when. Okay, I will introduce you again. So USA, Dr. Tata also good Endofia team, ours. And the Murat Sain also, thank you for your support us as a Endofia team. And every when? February always is good education program in the Turkish also, right? It's a good time. As anyway, now the endoscope spine surgery is the major in spine field. So I will do my best to organize the workshop to teach the teaching program. So please join us for especially young surgeon. As I told, if you do not performing endoscope spine surgery, in the world do not perform endospine surgery in your country in the near future, it's very difficult to survive as a spine surgeon. So let's go with us. Thank you.
Thank you very much. Any question from the floor? Okay. Okay, thank you. Thank you, Professor. The next topic will be by me. Yes. Okay. Okay.
Right? Just
Not
yes, over.
Over. Okay, good morning again. And first of all, I would like to thank you, the organizing committee, to invite me to here. This is my first time in Uzbekistan. It will be my honor. And my topic is the endoscopic treatment in the sciatica pain without the spine etiology. I would like to ask you before my lecture start, do you have the patient have the sciatica but the spine normal? Do you have? Okay. And do you have the patient after surgery, spinal surgery, and the patient still sciatica pain? Do you have? Okay. Listen my talk. This is the patient from Arabic countries. He suffered from sciatica pain for 4 years, and any kind of conservative treatment failed. And he went to my hospital to meet me. The MRI showed negative study. Only positive is the father test positive, and active piriformis test positive. So I hope all of you know two tests, right? And this is another patient, 45 years, female, left sciatica pain. I performed L5S1 interlaminar endoscopy discectomy 15 years ago. And she have sciatica pain again 6 months before he come to meet me. Okay? And MRI show, you see, they have the laminotomy area, but no herniation, no stenosis. Okay? So what is the cause of the sciatica pain? You see, we normally outside the spinal, we have many kind of the sciatic nerve compression. We call this area is the deep gluteal space, and you know that the sciatic nerve can compress by many structures in the deep gluteal space area. The sciatica pain due to non-discogenic pathology, the first is the Dr. Robinson introduced the term piriformis syndrome. And normally under diagnosis by surgeon. Some surgeons don't believe piriformis syndrome exists. but overdiagnosis by pain physician and physiotherapist. The character of the pain in the buttock area, in the hip, may be radiating to the leg. Diagnosis is very difficult because no definitive test. So how can we diagnose piriformis syndrome? The first is the symptom. The second is examination confirm and excludes the spine condition, MRI pelvis positive, and EMG NCV confirm. Okay? The clinical normally complain with the buttock pain, not the lumbar pain, buttock pain, and sciatica light pain, sitting intolerance, limping, disturb or numbness, and pain at night, getting better during the day. Normally, sitting intolerance is the most important symptom. This is I summarize the physical examination for you. The first is father test. That means the flexion, adduction, and internal rotation test, and the patient will pain at the buttock area. Okay, the second is the seat piriformis test. The patient sit on the chair, adduction and internal rotation of the leg, and the patient pain at the buttock area. This is the most strong physical examination, is the active piriformis test. You see, we ask the patient to active adduction and external rotation, and the other hand palpate on the gluteal area, and the patient will pain. And the fiber test, the patient on the supine position and forceful internal rotation of the hip, and the patient will pain. This is the study to see the accuracy of the test physical examination, and they found that the most accurate is the active piriformis test, and seized piriformis test was combined. So we have to test two tests to combine. And what is the etiology of the nerve entrapment in the deep gluteal space syndrome? The most common is the piriformis gemini, superior and inferior gemini, obturator internus muscle, quadratus femoris, and ischiofemoral ligament, hamstring, and in the trauma cases, is the fibrosis. You can see the many kind of the fibrous and fibrovascular, and also in the trauma cases, they have the fibrous tissue like this. But in the non-trauma case, the piriformis itself is hypertrophy in the acute cases, but in the late case, maybe hypertrophy. The accessory piriformis muscle, I will show you later. And because of this disease is dynamic, so we sometimes no pain and sometimes pain. So investigation sometimes negative. Okay, because we put the patient in the MRI, lay down on the table, and no pain. So she will pain, the patient will pain with internal rotation, something like that. So we should have the dynamic study, okay? And this is abnormal variation or normal variation related to muscle and the nerve. You can see many variation. So that's why some patient injection is negative, because they have two muscle barrier sometimes. So you have to look at the MI before you make injection. Otherwise, may be negative because of they have the many type of the variation. And also the variation of the attachment. You can see one attachment they combine with the short external rotator and combine with the gluteus medius. So when you release the piriformis tendon, you have to consider which type of the variation of the attachment. And this is an investigation. You can see the MRI of the pelvis. You can see on the left side hypertrophy, on the right side is normal. So that indicates this case muscle hypertrophy and compare the nerve root, compare the sciatic nerve. And also you can see the sciatic nerve swelling, increased signal. That means they have the inflammation around the sciatic nerve. The MRI will show you. What is the treatment you can perform endoscope? I will show you. This is the first study by Dr. Desawa from Japan. He performed biportal in the year 2003 to demonstrate the trap of the tendon and release by biportal endoscopy. This is another study to show biportal as well, and they found that 83% after surgery have the good result. And you see the clinical examination, the most common is the tender at the SI joint, tender at the get the torque, and the PET test positive. Okay, and this is another study biportal as well to confirm the clinical result is quite good. Pain score decreased from 7.4 to 2.3. This is my procedure. I am the first one in the world to perform with uniportal endoscopy. I use the normal spinal endoscope to perform the piriformis release. Back to the first patient, Arabic patient, and you can see MRI of the pelvis show hypertrophy of the piriformis muscle. You can see the nerve swelling, increase the signal around the sciatic nerve, and this is the EMG NCV confirmed incomplete degree of sciatic nerve denervation. So I start with the fracture table, and then this is the operating theater setup. I mark, and then I use the needle, put in the neck of the femur, and then put the scope in, identify the piriformis muscle and tendon, cut, and put the drain. Okay, I will. This is short video to show you. This is the piriformis tendon insertion to the gator torque. I separate the tendon from the hip capsule, and then I release the tendon. Normally, when we perform total hip arthroplasty, we cut the tendon without any deficit. So don't be afraid, okay? Just make sure you have complete release the tendon, and then go down to the inferior, identify the obturator internus is tight or not. If they tight, you release. This is sciatic nerve. You can explore the nerve and see is no compression, no scar. Okay. And another patient, 55 years old, sitting in tolerance. She came to meet the spine surgeon, and the surgeon diagnosis is the annular rupture, and he performed endoscopic discectomy. Okay, the back pain improved, but the leg, the sciatica pain not improved. So he he performed the epidural steroid injection and not improve. So the patient come to meet me. I make the examination, and it's confirmed this is not only the disc cause, but the piriformis is the cause of the pain. So I perform the MRI of the pelvis. You can see this is the piriformis origin from the sacrum. The origin is different from left and right side. We call the accessory of the piriformis muscle. You can see on the left side is hypertrophy when compared with the right side. And also the sciatic nerve on the left side, you can see enlarged and swelling. See that? Okay, EMG also confirmed. I performed the uniportal endoscopic, but I changed the position of the patient from the first patient to make the leg free. So I will test what during endoscope which structure compared to the sciatic nerve. I will know. Okay. So again, put the scope in, and this is the video show. This is the superior gemini, the piriformis muscle. I cut the band, and I separate the tendon from the hip capsule. Okay. And then I release the piriformis insertion. This procedure is quite easy. You make about 15 minutes to 20 minutes. So you see. Okay, that's it. Okay, this is the wound. The last case, my patient 15 years ago, I performed endoscope discectomy and come back again with the sciatica pain. And you can see the MRI of the pelvis show the piriformis syndrome. And then I performed the piriformis release. And after that, 4 years, she come back again with the same symptom. And the MRI also show the piriformis syndrome. So this is the revision cases. But if you see the MRI, you see that the MRI, I would like to show the MRI. Okay, you can see obturator internus on the left side is also hypertrophy, and you cannot see the piriformis because I relieved 4 years ago. Okay. You see, how can I introduce the dilator to the piriformis fossa? Again, something like that. And then the piriformis scar was released, and then I go down, and you can see the nerve. This is the nerve, right? Have the scar, release the scar, and then go down to the obturator internus, and release obturator internus, and the patient pain-free until now. In conclusion, the diagnosis by rule out the spinal condition first, confirm physical examination, MRI of the pelvis, and don't forget EMG and CV. Thank you for your attention.
Thank you. So, do you have any questions? Yes? Dr. Ram?
Okay, I answer the first question first.
Yeah.
On the first case, I start 7 years ago, I want to fix the position of the patient by use the traction table, and then internal rotation of the leg to create the position that the patient have pain, and then I scope to see what structure is compared the nerve root, compared the sciatic nerve, and then I release. And then I change because I cannot mobilize the leg by fracture table. So I would like to confirm any or another structure still compared the nerve root or not. So I would like to mobilize the hip. So I change to the new position, make the leg free, and during operation I can internal, external motion of the hip to confirm no any structure compression the sciatic nerve. Yes, yes. And also I have some case, they also have the spine problem, particularly like the L2, L3 or thoracic OYL, something like that. So I perform with the prone position. Decompression spinal first, and then release the sciatic nerve by prone position. It depends on the condition of the patient. Okay.
Thank you for the nice, wonderful presentation. I have
Thank
one
you.
question. So maybe if you want to diagnose piriformis syndrome, so diagnosis is a little difficult
Yes.
with physical examination, MRI. So did you try the preoperative, some kind of diagnostic blood or like?
Yes.
Yeah.
Yes. Thank you. Thank you, Dr. The most important thing is how to confirm the diagnosis. Okay, that I told you. Symptom very important. Physical examination confirm. Before we make the decision, we put the patient to the pain therapist. Many modality of the conservative treatment before we make the surgery. The physiotherapist put the injection piriformis under ultrasound. Some they put Botox to the piriformis muscle. So, and then the patient will feel better. But for a month, they come back again. That is the indication for surgery. I use uniportal. Botox. Lateral decubitus. Yeah. Lateral, very easy. Lateral.
And one more question. What's your opinion about the symptoms? Most of the piriformis patients I see, actually, I thought that they were, the symptoms get worse when they sit, but when they walk, it was not worse. What's your clinical experience about? They don't get more pain when they walk.
Okay, good question. In the early phase of piriformis syndrome, the patient painful when sitting. So you can see some patients, they sit like this. They elevate they lift up the ischium from the chair, something like that. But in the chronic case, the muscle contraction and not release. So the patient will pain every position, particularly at night. The pain at night. When he walk, sometimes he feel better. But they limit to internal rotation of the leg, sometimes like that. So it depends on the phase of the disease.
Usually, while doing the surgery, it is sometimes we underdo. Do you check intraoperative range of movement of the hip?
Yes.
Because when we're doing with endoscope, it is always a small cut. So we don't sometimes do the bursectomy or don't do enough of dissection. I think intraoperative, we should check for the range of movement. There is no compression.
Yes. No, normally, I set the position of the patient with the leg free, so we can mobilize the hip, right? Internal rotation, external rotation. And when we perform, we start with internal rotation first. The reason is to move the surgical field away from the sciatic nerve. Okay, you can follow me, right? You internal rotation, the catheter move far away from the sciatic nerve. It's safe for your insert the dilator. And after you release the short external rotator tendon, you should have more internal rotation.
Okay.
Okay.
Yes. We have to finish it. Yeah.
Sorry, just
We
one
have
last question.
time limitation.
Similar symptoms has been reported in colonial nerve entrapment syndrome, and there's a lot of literature written about that, and people doing some decompression for that as well. So how do you differentiate between these two problems?
Yeah, difficult. So,
Yeah.
few minutes. Okay.
Final.
Okay, you have to differentiate about the piriformis is the cause. Short external rotator is the cause. The lower edge of the gluteal medius is the cause. Ischial tunnel syndrome is the cause. Adductor, adductor insert at the ischium tubercle is the cause. So they have many causes of the sciatic nerve entrapment. So you have to focus every client that I inform you. They have the different
Okay.
symptoms.
We have no time. With time limitation, we have to move to the next turn.
Thank you.
So the next speaker is from the Turkey, Dr. Hikmet Uluk, will talk about the step-by-step full endoscopic transforaminal approach and the basic technique. Please.
Sorry.
Honorable Chairman, distinguished colleagues and dear guests, good morning. First of all, I would like sincerely thanks my young colleague, Dr. Showmansur, for his kind invitation and warm hospitality. And also everyone who contributed to the organization of this Congress. Today, I will try to share my experience regarding the fundamental principles of transforaminal approach, particularly for, of course, disc herniations. Sorry, it is working. Yeah, okay. The first and most critical step for transforaminal surgery is the needle placement. And entry angle, sorry, it is not working. And entry angle, entry point, and needle position must be planned preoperatively. The needle tip can be positioned at different points within the foramen. Wherever the needle tip is within the foramen, it must always be in contact with the annulus on the lateral view. This is the tricky point. This is the ideal needle placement. Our target is medial pedicle line here. And during the operation, first approach, epigraphy is okay, but in lateral graphy, the needle tip is outside the foramen. And now we should enter at steeper angle. And now more vertical entry. The result is epigraphy is okay, but on the lateral view, the needle tip is inside the disc space. At that time, now we should enter at a more horizontal entry. And now, more horizontal entry, and that's okay. Epigraphy is okay, and on the lateral graphy, the needle tip is on the annulus, or posterior vertebral line. And now, this is again, in animation, this is correct position. Next step is discography. I am using the indigo, carmine, gadolinium, and SF in same amount, approximately 2 or 3 cc inside the disc space. And I prefer to make the skin incision in this stage, and now the guiding rod placement. Guiding rod advanced with twisting movement, and if necessary, it can be tapped into the disc space. Now this is cannula placement. Open end should face ventrally until it reaches the foramen. And now cannula placement, open end should face ventrally until it reaches the foramen, and the open end rotated dorsally and advanced into the foramen. This method prevents exiting nerve injury. Approximately in 3,000 cases in my series, I didn't met any exiting nerve injury during needle placement or cannula placement. But these tricks are very important. But the cannula tip will contact the annulus before it reaches the target. And I want to repeat it. When we place the cannula, again, I am repeating, the cannula will contact the annulus before it reaches the target. And the cannula, the cannula will penetrate the annulus once it reaches the target. Don't forget this. Every time it will penetrate. And now during the operation, look at this. Needle hole and cannula penetration area, and also upper half of our view is epidural cavity, and lower half is needle hole. Pay attention here, look at this. The needle tip is over the annulus, but the cannula penetrates the annulus. Finally, we are calling this technique as an half and half technique. Not inside out, half and half technique. Now, at entry angle greater than 30 degrees, only the nucleus pulposus can be removed. Access to epidural area or dorsal annulus area is not possible with this angle. Access to the dorsal annulus and epidural cavity is possible with entry angles less than 30 degrees. This is very important trick also. And now, what will I do for various type herniations? If there is non-migrated intracanal and or pure foraminal herniations, a near horizontal entry angle is essential. This is a case example, subarticular herniation, a little bit foraminal and a little bit down-migrated herniation. Look at this. 19 degrees anti-entry angle, needle placement, cannula placement, and the operation. In this short video, you can see epidural access achieved using the half and half technique. Upper half is epidural cavity and lower half is the disc space. And the post-operative image, that's okay. And I want to show another example, a recurrent case after microdiscectomy. And now, entry again is near horizontal, needle placement, cannula placement, and the operation. And you can see the access to epidural cavity, but in the recurrent cases after microdiscectomy, reaching the herniation through an untouched corridor is major advantage of the transforaminal surgery. And this is the untouched area. And the postoperative image, that's okay. And this is another case, recurrent after endoscopic surgery, but there is very narrow foraminal foramen. In this case, we can do foraminectomy under endoscopic vision. Following foraminectomy, herniation tissue can be removed. And the postoperative image, and to look at the foraminectomy. Circumferential foraminectomy can be done with this method. And now, now let's talk about extraforaminal herniations. We know that there are several MRI criteria for extraforaminal herniation diagnosis, but the important one, the displacement of the exiting nerve. Exiting nerve may be displaced dorsal, lateral, cranial, or in any combination. But important one in dorsal displacement, if there is this type of displacement, the entry angles less than the 30 degrees may cause the exiting nerve injury. If there is dorsal displacement, or we cannot identify the displacement direction on MRI, we have to use entry angle over 40 degrees. And an example, look at this steeper entry angle and the midline, middle pedicle line located needle and cannula and the operation. Cranial rotation of the cannula exposes the exiting nerve. And also, cranial rotation cannula allows us retraction of the exiting nerve. During the transforaminal surgery, exiting nerve can be retracted. And there is no light. Look at the intraforaminal ligament emerging from the exiting nerve in this case. And the postoperative image, that's okay, there is no problem. And another case, this is pre and postoperative image. In this video, I want to show that, look at this, herniation tissue adherent to the exiting nerve. And we can safely manipulate the exiting nerve during transforaminal surgery. This is not untouchable nerve. We can manipulate it and we can retract it very easily. And now a little bit migrated herniations. It is very important that in migrated herniations, MRI-based classification should be used. It is very important. And it is important for the surgeon to mentally visualize the herniation in 3D. And then next step is transferring the 3D location to the X-ray. Why? Because during the operation, our only navigation tool are X-ray images, like here. And also there is another particularity, inferior articular process located medially than the superior articular process. It allows us to reach the herniation through the axilla of the exiting nerve. An example here. And look at this. I am reaching the herniation tissue. This is the navigation. And I am removing it from the axilla of the exiting nerve. This is possible to reach cranially migrated herniations. Another example, look at this. And beginning of the operation, this is exiting nerve exposed. I am removing herniation from axilla of the exiting nerve. L3 corpus, Navigation continues, and again navigation. There are another part, and the second, more cranially located fragment is also removed. This is the post-operative image, and this is the post-operative sagittal and coronal sections. So, as a conclusion, a good MRI and preoperative planning based on MRI is essential. Take the time to place the needle and get an early postoperative MRI and watch on your surgery videos. Thank you for your attention.
Thank you so much for excellent presentation. Any question from the floor? Dr. Walapot, please.
What kind of anesthesia do you use when you perform transfemoral approach? General anesthesia or local anesthesia?
Oh, actually, I want to operate with local anesthesia. But believe me, this is a cultural problem. I began this type endoscopic surgery 16 years ago in Turkey. In the beginning, I proposed every patient to local anesthesia. And when I search my series, approximately 5% are accepting the local anesthesia. But now, neuromonitorization we are using, that's a very good method in my opinion, because patients don't accept the local anesthesia. But in Korea, for example, I know very closely, all patients under local anesthesia, but in Europe also, general anesthesia. This is the cultural problem.
Okay, thank you.
Thank you, sir.
Thank you. Thank you so much. So because of the Dr. Santishada Gauri cannot come, we move to the next topic by the Dr. my friend Bang Dawano. He will talk about the endoscopic technique for the multiple level spinal degenerative deformity. Do we need fusion? Dr. Bang, please.
Satusunov and also the organizing committee for many times invitation. It's always my great pleasure to be here. My topic is endoscopic technique for multi-level rigid degenerative deformity. Do we need fusion? Nothing to disclose. What is aging spine? Aging spine is natural physiologic changes of the biomechanical construct of the spine. Life is changing and changing is life, including the musculoskeletal system, experienced by everybody and could not be avoided, leading to a kyphotic deformity. So what is spine degeneration? Spine degeneration is pathologic condition, damage, wear and tear, and change the biomechanical construct in the aging spine, could occur at any age. And the changes of the biomechanical construct might be single or multi-level and lead to a deformity in cervical and the lumbar spine. So this theory of Kirkcaldy Willis, early degenerative cascade ended with late degenerative cascade and ending with multi-level degenerative lesion. We can describe in three phases: dysfunction phase, instability phase, and then stabilization in deformity, because this is deformer, the facet joint, and osteophyte. But Kirkcaldy Willis only described two columns, the middle column and anterior column. 45 years before Kirkcaldy Willis, Bastrup already described the posterior column degeneration, breakdown the interosseous ligament, characterized by abutment, enlargement, stenosis, and bursa, but the theory was forgotten because the etiology not well understood. Then his study was supported by Bristol study and Auckland study, They study 100 standing X-ray, 200 CT scan, and 200 abdominal CT scan between the age 20 until 90. According to their observation, the lumbar spinous process getting larger and wider, and they call it the kissing spine. So if the height and width increase, then the lordosis decrease. Now the loss of lordosis is not merely due to this degeneration, damage, wear and tear, but also by other damage, wear and tear, the enlargement of the spinous process. 3-column theory of Roy Camel, 80% go to the anterior, 80% to the posterior, and the middle column control the burden like a crane theory. So the damage can occur in the 3-column. Now we came to the 3-column damage theory of cervical and lumbar degenerative cascade. It may be occur in the anterior, middle, or posterior, may suffer alone or together, from inflammatory to compressive reaction, change the biomechanical construct of the spine mobile segment, single or multi, and lead to a deformity. This is already published in 2018. The dynamic movement of the cervical and lumbar need the natural stabilizer. That is the disc, fascia, joint, ligament, and muscle. Thank you, Dr. Girish, for the picture. This fascia, joint, ligament, and muscle. So the damage of the degenerative spine, we call it the deformer. It might be osteophyte, hypertrophy, facet, lamina, spinous process, and canal stenosis, and flaviolum folding and hypertrophy. Deformer in cervical spine, multiple disc rupture, ligamentum flava infolding, and annulus rupture and nucleus extrusion. Deformer in Bastrop type 4, oblique abutment, create a torque produced in this level and also create a deformity. The nature of illness of rigid degenerative deformity is combination of two factors in 3-column, the stabilizer, deformer. The deformer will dysfunction the stabilizer, create instability, and ending with the rigid deformity stabilization. This is the 3-column theory of three phases Kirkcaldy-Willis degenerative cascade in cervical and the lumbar. Now the gold standard is open surgery decompression, but some way will sacrifice part of the stabilizer, then we need artificial stabilizer to restabilize. But the question is, if we could preserve the stabilizer, do we need fusion? The concept of endoscopy in spine rigid degenerative deformity is retain the stabilizer, just remove deformer, that is the first decompression. It will release the rigid deformity, reapply the stabilizer function, and in some way will reduce the deformity. We call it the second decompression because the best decompression is deformity correction. Normal fascia joint is a gliding joint in flexion extension and in lateral flexion. So what happened in hypertrophy? It locked the fascia joint in deformity. So to unlock the fascia joint, we perform the medial fasciectomy, the IAP, SAP, and then well decompress. This is a case, male 74, rigid deformity and facet hypertrophy. When we perform uniparted endoscopy, preserve stabilizer, remove deformers, and medial fasciectomy over the top decompression. The IAP, then we can see the SAP and well decompression. So medial fasciectomy, IAP, SAP, lateral recess foramen, and then contralateral, before, after, before, after, before and after. The result, rigid deformity corrected, no fusion device. Another case, female 77, rigid deformity, and facet hypertrophy locked the facet joint in rigid deformity. We perform medial fasciectomy, remove deformer onto the preserves the stabilizer, before, after, before, after. Then the result is rigid deformity corrected, no fusion device. This is another case, rigid deformity. We perform the same unipetal preserved stabilizer, remove deformers, medial facetectomy and discectomy, before after, before after, before after, deformity corrected, no fusion device. This is female 55 with spondylolisthesis also. Rigid deformity, we perform the same procedure in medial facetectomy, before after, corrected, before after, before and after. This male 59, 30 years fracture past interarticularis, inflection extension. Then he has severe low back pain and right sciatica, stenosis on the right side, facet hypertrophy. Then we perform also unipetal endoscopy, medial facetectomy, after and after, deformity corrected, and fracture autopath also reduced 1 month later and 2 months later. Fuse. No fusion device. This is male 78, post-fusion C4567 in another country 2012. Then 8 years later, come with severe neck pain and stenosis due to ASD C34C71. We can see here severe stenosis C34 and C71. Then we perform decompression foraminal-laminotomy and discectomy, C34 before and after, C71 before and after, and the day after he smiled, no pain. No fusion device. This is the worst. Bedridden tetraplegia due to cervical and lumbar spondylosis with rigid deformity. This is the left hand, only move like this. The right hand cannot wake up. We can see the leg also only move like this. It is really due to severe cervical spondylosis and also the lumbar with deformity. Then we perform foraminal-laminotomy discectomy, remove deformer and preserve stabilizer in the cervical. And also herniated, we remove it. And the result is before, after, before, after, before and after. Before, no fusion device, and also deformity corrected. We perform also on the lumbar. Medial facetectomy, discectomy, remove deformer and preserve stabilizer, before, after, before, after, before, after, before, after, before, no fusion device, after. And then we can see starting to move the left, sorry. Start walking, no fusion device. Take home message. Endoscopy is a developing instrument for degenerative spine. The concept is how to use it for cervical and lumbar rigid degenerative deformity. Retain the natural stabilizer. Just remove the deformer only. This will naturally release the rigid deformity, reapply the stabilizer function, and will correct the deformity without fusion device. The best recommendation is deformity correction, and it can be applied for cervical, lumbar, thoracic, single or multi-level. Thank you very much.
Thank you, Dr. Bang Bang. Oh, any question? Okay, please.
Thank you for the excellent presentation. I just believe in you, and I just use the same concept as you. That's nice to hear from that. I just wanted to add something. Sarcopenia is a big problem that in elderly age. So we have to convince the patients to do the surgeries that makes that helps very much after the surgery. If they do some exercises, that makes them very the improvement helps very good, and the deformity is changing very fast when they do the exercises. Okay, thank you.
Yeah, thank you.
I saw you one of the cases where there was listhesis. You have not stabilized that case. You have just removed the deformers. Sir, when there is listhesis, there is also shear on the posterior annulus, which causes pain because there are pain generators there. How you manage them?
Yeah, thank you. So the concept is our philosophy: life is changing and changing is life. Yes, I cannot make my patient younger. Just blame the changing that caused the complaint of the patient. Because the nerve is still okay, only the house of the nerve damaged and then disturbed. So we do fixing anything, and the nerve already free. But this is live tissue, not like a machine. Yes, if machine broken screw, you change with screw. Live tissue, there is a natural healing of the patient 3 months. So very important to educate the patient how to help the healing completely. Because two best operation, one disturb, one support, in the end is not the same because this is live tissue. So I put the patient in a soft collar neck or in a lumbar brace 3 months to let them understand that this is not completely healed, even the pain is gone. They are not allowed to do flexion extension because the bone is not healed. If you put the burden over there, then the bone healing is not good. So this is the key, very important.
You are giving temporary external stabilization. Temporary external stabilization.
Just to remind, yes. Other activity you can do. And after 3 months, we check again, dynamic X-ray, stable. The bone is already healed. Then remove the brace and start to do back muscle strengthening because this is very important.
Okay, thank you. Yes, we're moving to the next the speakers. We're what about the Wichan that from Thailand? We'll talk about the envelope, the butterfly, the phlebotomy, how to remove ligament flavum as an envelope.
Good morning, everybody. Thank you for having me. My name is Dr. Vorapot Pichan from Thailand. Today, I would like to share my experience and my practice, like en bloc butterfly phlebotomy, or the bundle, and ultrasonic osteotomy techniques. The principle, I think, this is a general principle. We do endoscopic, but we have the aim problem, like a good result without the complication from the endoscopic surgery. First, we could have a good visualization and appropriate instrument that we have, and a good technique. We develop it for easier and faster, but safer. Why butterfly? We do butterfly en bloc phlebotomy because it is safe and effective to provide a good result for patients. The key for phlebotomy is how to do osteotomy safely. After that, you can do any style that you prefer, like a phlebotomy en bloc or something. We have many of techniques for endoscopic uniportal, UBE, or hybrid style. We have instruments like a burr, shaver, correction, cutting punch, or forceps. And nowadays, I think the future may be the ultrasonic technique to preserve flavum ligament, to try to remove as an en bloc style, or piece by piece. But the important is prevent instability. We have instruments like diamond burr or Kharisan. But at first, you should select the patient who is the best candidate to perform endoscopic surgery. As we know, the key is patient selection and preoperative planning is crucial. And you should have to know the Asian spine size, for Asian spine size, we are less than the Caucasian, around 10%. That make sure you have the distance, make sure measure before the surgery. If you choose the instrument like a uniportal that have a big size of a uniportal lens, like a 10 millimeter, but your patient just the space from the spinal process to facet joint is just less than 7 millimeters. That you have to sacrifice some part of facet joint like this. Yes, uniportal. The pro is visual and work at the same point and irrigation system instant. But the cons needs to move while working, and big lens size maybe 8 to 10 millimeters. It may you cause difficult to work like a space less than 7 millimeters from the spinal process to facet joint, and had a steep learning curve. How about the UBE? The visual and instruments independent. You can use your dominant hand like an eye, but the other hand like working that's separate and make more you feasible to work. But the cons are irrigation system. You have to create the wicking portal to remove irrigation, and more substitute and made compared to a uniportal. About hybrid that I work, you have used the uniportal lens for irrigation system and for an eye, but you have to make another portal. But the cons are lens is heavier and you need skill both style of the uniportal. Sometimes I work at uniportal, sometimes I work at UBE for right hand or left hand, and sometimes I work at hybrid. It depends on my instrument that day that I have. For osteotomy, we have a high-speed burr or shaver. The difference from the high-speed burr and shaver is high-speed burr is high speed and low torque and very fast. But shaver are high torque but low speed. It's different, a little bit different for working. Instruments for osteotomy that we know, Kharisan chisel or osteotome or combine. And I think the future may be ultrasonic for osteotomy. And this is my demonstration. After we setting patient into the prone position on the loosened bed, and then we approach to interlaminar. And I always start with the lower lamina of the upper part, extend to the opposite side, and then I went down to lower border to upper border of the upper lamina, lower lamina. Sorry. And I usually use my diamond burr osteotomy until I reach epidural space. You see, at the right video, we reach the epidural space and can extend. Diamond burr is safe, I think it's safe, but you have to control your hand, not push the burr to the field, just a lateral side cutting. After you finish and reach epidural space for the upper and lower part, you go to a contralateral side to fasciotomy, like this. I move my lens, my camera, just a little bit for 70 degrees. and I can see the contralateral side and can work like this. The key is you should not cut the frame ligament to spare it to protect the dura. After that, you can detach the frame ligament at the lateral side. Oh, sorry. And make sure you can detach it all around 360 degrees. After that, I remove it like an en bloc or big piece hemi-phlebectomy. Sometimes it cannot remove by the en bloc, but you can take a spare of left of the frame ligament. After that, you can check around the dural sac and your nerve root to make sure you have a complete decompression. And these are the results. You can remove it like a en bloc butterfly or hemi en bloc or big piece or piece to piece by piece. And how about ultrasonic osteotomy? It may be the future, but now I use this as a uniportal, UBE or a hybrid style because it has no design for uniportal now in my country. And how it works? It has like a water jet to guide this. And make another hole and use this like a UBE style. Actually, I think this is faster and safer, but you see, it's more foggy. I try to reduce my water pump and increase the water jet from ultrasonic, but I try everywhere, but it's still foggy. And it's bleeding. It's different from the you use diamond burr that can make it like a heat to stop bleeding. But in ultrasonic, it's no way. And sometimes, special design, but you see, just a little by a bone, it takes time. And just a little angle, it cannot work. It's a problem because of we have no design or proper design for endoscopic surgery now. Take-home message, patient selections and preoperative planning are crucial for endoscopic spine surgery. You can do uniportal, UBE, or hybrid. It's a personal preference. It's up to your style and your instrument. And the key are good visualization and education system are crucial. And in my opinion, butterfly does not matter. But the key is laminotomy, how to laminotomy safely and protect the dura until you can reach equal space upper and lower side and the lateral. And then you can remove frame ligament like your style en bloc or hemi en bloc. But of course, it's a steep learning curve. But you see, it's at the wall, at my fence wall, the plant can grow and bloom. I would like to invite you to our Thai-Miss 2025 on 4 to 7 November in Bangkok, Thailand. We collaborate with Malaysian Society of Endoscopic Spine Surgery for Malaysia and Taiwan TSES and the Korean Research Society of Endoscopic Spine Surgery or COSES. This is our last meeting, 2024. Thank you for your kind attention.
Okay, thank you so much. The excellent lecture. And any question you have? Okay, the Maxime from the French. The use mic.
When you use an ultrasonic device for your surgery,
yes,
I use it since 1 year. And the key for UBE is to have a big water flow, to don't work with pump. If you don't work with pump, you can have a very nice water flow, or you don't have snowing effect. Try this, you will see it's better.
I have tried that as the same problem. Foggy, more than uniportal style or UBE style, but just use a diamond burr.
But if you don't use pump, you use a big water flow.
Yes.
You have a very nice visibility. With
yes,
this
I
system.
increase the pump. I decrease the jet flow and everything. Yes, up, down. It's not working.
With flow, you have a very nice visibility with ultrasonic system.
I use a uniportal lens. You know, it's instead of education system. It's very good.
But with flow, you see, it's very nice. You see everything.
I will try. Thank you.
Okay, thank you. Any question? More?
Thank you for your nice presentation. Did you have any worries about when you use the ultrasonic thing, if it touches your scope, your lens will break? Did it happen? Maybe Maxim can also answer it. What was your experience?
Our lens is very expensive. I far from my lens.
So you were very careful about it.
Yes.
Okay.
Have you tried doing this technique using osteotome?
Sometime.
Yeah, I think the angled osteotome for uniportal is just perfect for this kind of a problem because the osteotome doesn't come in the way of your vision. You can just see the blade. It becomes very easy once you detach, cut the bone, the whole thing comes out and block.
I use osteotomes only when I reach epidural space. After that, just a little of a bone piece. I use that, but not main operation.
Okay, thank you.
For about this, you need to remove all metals, retractors, everything. Because if you touch ultrasonic system with your metal, it's broke ultrasonic system. Or if you touch the scope, it's broke ultrasonic system. So you need to have to did your learning curve before to use it.
Yes, and so we need to think about, consider about the importance of the butterfly technique to phlebotomy. So what is the main purposes of to remove the edge envelope? What is the purposes? Is there any advantages? The skill is not important. The instrument is not important. What's the purposes of to remove, to save the butterfly life?
Yes, I think butterfly is okay, but sometimes we cannot remove it like a butterfly. I think a butterfly is okay, but in my opinion and my practice, I usually use a hemi en bloc, hemi phlebotomy. One side and go to the opposite side. It's very safe. I think it's safer. And sometimes we try to remove deep and superficial part for phlebotomy. I think that's not necessary. Remove superficial part and left deep part, and then go and then work and remove the deep part later. It's okay.
But it's the video. So in your video, I saw too much the bone work because it's difficult to find the underside of the facet. So there was the too big damage of a facet joint during the removal of the ligand flavum, and some case of there is the adhesion between the ligand flavum and the dura. We couldn't realize some adhesion. So after during the removal, it will happen the damage of the spinal cord in cervical, the traction injury. So I think the removal of the ligand flavum little by little will be better than the total removal as envelope. What do you think about this? We need to think about what is the advantage, what is the purpose of the envelope total removal. Is there any advantage compared to the little by little? Any? What is purpose, advantage of multiple removal?
I think that we have the same purpose because we just decompression but not create instability. But sometimes I have a problem like my instruments. But average when I perform osteotomy, I do not destroy just enough to decompression for facet joint, something like that. I usually not go to the nerve root to see the nerve root or the nerve roots or something. I just use my instrument, some kind of instrument like a probe to check the foramen.
Okay.
Okay, I would like to say something about this study that the purpose that some surgeons remove the flavum by the en bloc technique is to prevent the injury of the dura and the nerve root from the instruments like the collisions or burrs. And many studies to compare between the piecemeal and the en bloc, they found that the en bloc is less complication than piece by piece. But I would like to ask all of you to consider the ligamentum flavum is only one of the pathology. So please listen to Gerrit Daksa to explain you about what is the pathoanatomy, and you have to consider in your case which structure is the main pathology, not only the ligamentum flavum. Yeah, thank you.
Thank you. Thank you. Okay. And then move to the next stage. Dr. Omjina from South Korea will talk about the efficacy of modified full endoscopy spine surgery with standard instrument.
Good morning. Thank you for inviting me. This incredible meeting. Yes. So how many doctors are doing biportal endoscopic surgery? So most doctors are doing monoportal endoscopy. Actually, I'm a biportal endoscopic surgeon. I just started monoportal endoscopy. Only you are doing biportal endoscopy. Okay. So today, my topic is modified full endoscopic spine surgery with standard instrument. My disclosure, I made the Uscope with the German Bauer company, and actually Uscope is compatible with FESS and UBE. Before we dive in, let's look at the history of endoscopic spine surgery. 1934, Mixter and Barr, first disc surgeon, and it was a very traumatic approach. And Kempin Hishikata opened the endoscopic spine surgery world, and Tony Young made YES system, and D. Anthony first presented bipolar endoscopic surgery. Now we are doing, UB is spreading all over the world, but still many doctors are doing monoportal endoscopic surgery. So I think I need some integration. So this is it for surgical procedures, as you know, is we need illumination, exposure, and magnification. Sometimes we have to think about instrument handling and ergonomics and cost effectiveness. As you know, this is uniportal, biportal, and multiportal, and MED system and Desando system. And dual mode descent system, and we can use exoscope and intelligence system in minimally invasive spine surgery. Yeah, so AO spine declared like this. FESS is not microendoscopic, not tubular system, not endoscopic assisted. So evolution is inevitable. So there was evolution of interlaminar FESS, but still we cannot use a standard instrument. Let's look at the instrument for uniportal endoscope. Instruments are usually long. Okay? Due to long level arm effect, grasping power is weak and vulnerable to bending forces. So standard instruments are powerful. Sometimes we need a standard instrument. We cannot deny. So there are various kinds of radio frequency ones. So how to allow standard instrument? So first method is enlarge the working channel. That is the evolution. Okay? Second method is making a second large working channel. That is bipolar. And third method, I think, break open the working channel. That is U-scope. So like Columbus breaking the egg, I break the working channel. I remove the upper part of monoportal endoscope. So let's review the development of endoscopic spine surgery again. Campbell has cut open the endoscopic spine surgery world. 1990, yes, Dr. Young developed yes system. We are doing transforaminal FAS, interlaminar FAS. There was evolution, but still we cannot use standard instrument. 1996, D'Antoni first introduced biportal endoscopic spine surgery. Since 2001, Abdul Ghaffar and Korean surgeons developed and established present UBE. But still, we use arthroscope. There is no spinoscope for UBE. What I'm using is UBE endoscope is arthroscope for orthopedic surgeons. So let's look at comparison, okay? So just I mixed. So surgical view is the same as biportal endoscopic surgery because monoportal endoscopic surgery, the endoscope lens size is 2.9 millimeter, but I applied 4 millimeter lens. So just I integrate monoportal and biportal. Okay. Okay. What's this? Oh, sorry. Okay, I got Korean patent, and last year we got American patent. So just I started full endoscopic spine surgery during cervical laminectomy discectomy. I have some difficulties. It was not easy to remove medially and ventrally located disc fragment because the working direction is collinear. So with U-scope, the working direction is not collinear, so I can use long nerve hook and curved cuirass, so I can remove medially located disc fragment easily. And surgical view is the same as biportal endoscopic surgery. And during the interlaminar lumbar discectomy, I felt some difficulties when entering the epidural space. And we can do nerve root retraction with tube rotating maneuver, but sometimes we need a strong nerve root retractor. So with U-scope, we can use this kind of standard instrument, straight Kelson launch and curved Kelson launch, and pituitary forceps and curved pituitary forceps and microdrill and nerve root retractor. Yes, cons of uniportal endoscopes are endoscopic channel restrict surgery and working direction is collinear. Cannot use standard spine instruments, need special long instruments. Hard to retract spinal nerve, steep learning curve, and we have to use expensive instrument and disposable materials. Cons of biportal endoscopic surgery, we need triangulation skill, and we have to make enough working space. We need more soft tissue damage, and we need a good passage of normal cell line. So US take all advantages. During September 2024, I conducted 10 cases. Results post-operative VAS score improved and none of the cases had to be stopped due to technical issues. No surgical complications were noted. No surgical deterioration after surgery, and no patient required conversion to open surgery. So let's look at the cases. And this is C56 right side. We can use standard Kelson plungers. We can use a long knob hook. So we can remove the medial located disc fragment easily. And C67 on right side, also we can use radio frequency devices, and you can use strong Kelson plungers, and you can use micro drill, just the same as micro drill. We already are using the microsurgery. So sometimes we need to explore the medial ventrally located disc fragment, and we can remove easily. The knob is same as microsurgery. We can use. And L5S on right side, okay, we can use micro drill, and we can use Kelson plungers, but surgical view is the same as biportal endoscopic surgery because the lens size is 4 millimeter lens, very clear. And L5S on left side, so surgical view is same. We can use micro drill. And also for lumbar stenosis case, also I agree with Dr. Im's opinions. I don't recommend the embolic fixation. In case, we can use, we can remove embolic fixation, but case by case, we have to remove the ligament from piece by piece, because the first priority is we have to protect nerve root, dura, okay? But we can try butterfly embolic fixation, no problem, you can do, okay? And I tried also usoscope T-lips as L5S1, L45S1 with dual-X expandable cage. But it was not easy. It takes a long time, but also, so we can use micro drill and ultrasonic saw, osteotome, and shaver. We can use all kind of standard instrument. So you can use ultrasonic, so there is some POGI, but I think the POGI will be maybe the ultrasonic saw's shape. What I'm using is a very sharp and a little long one, okay? There is no POGI. Maybe according to the shape, maybe there is some POGI or what you're using is just a round one like that, okay? And actually, this is a very interesting case. So this patient came to my clinic 1 year before, and he complains of serious left arm radiculopathy and numbness and weakness. So we did UBE posterior cervical discectomy, left side. At that time, I removed the ruptured fragment successfully. And after surgery, patient doesn't complain any pain, just mild neck pain only. Radiating pain was gone. But few months later, after surgery, actually 6 months later, came back to my clinic and started complaining neck pain and some numbness, and annoying neck pain and numbness, some kind of weakness. So we checked MRI again, and there is some stenosis and some kind of like that. So we decided endoscopic ACDF. So actually 2 weeks before I did endoscopic ACDF, we tried first an air mode, and in the water mode, we can see the anatomy clearly. So we can see the dura and the epidural space and pathology osteophyte clearly. So we can remove the pathology osteophyte drilling and Kelson plungers. And in the air mode, we can put a cage implantation after breathing control with the various, all kind of coagulation devices. But surgical view is very clear. See? So we can use dual mode. This is Surgery Pro for breathing control. So post-operative X-ray. So benefits of a use of ACDF, I think we can get a crystal clear surgical view and less of this retraction and less breathing. So most important part is we can do safe spinal cord decompression. And usoscope is flexible, no need to focus repeatedly like a microscope. So we can reduce surgical blind area. And usoscope is also dual mode. So advantages of endoscope is acceptable learning curve, and endoscope visual anatomy is the same as MISS. We can use a standard spine instrument. We can retract the spinal nerve and less expensive instrument. Also, in case, we can convert to uniportal and biportal microsurgery easily. Also, endoscope fusion surgery will be easier. Cons of USS is still the outer diameter is 10 millimeter, a little larger, and also not so free instrument handling compared to UBE, long operation time post-fusion surgery, and learning curve. I think that about the learning curve, microsurgery is riding a bicycle, and UBE is driving a car, and endoscopy is driving a flying car, and full endoscopic surgery is operating a flight operating. So conclusion, endoscope might become next generation of full endoscopic spine surgery. We can use large, powerful conventional surgical instrument and familiar anatomical approach. And endoscope fusion surgery will be easier and reasonable cost, and endoscope is versatile endoscope for full endoscopic spine surgery and UB surgery. Thank you for your attention. Thank you very much.
Have any questions for new device? Okay.
What's different from this endoscope compared to
Destandu?
Destandu. Oh. So Destandu system is already, you know, is the incident size is about 2 cm or 3 cm or like. Also triangular approach. So you cannot use curved instrument, Destandu system, right? You cannot, it was not easy. Instrument handling is a little restricted. And the standard system is usually doing in the dry mode, air mode. Sometimes I already introduced dual mode, the standard. They can use in the air mode and the water mode, they can do it. But the standard system is mainly based upon the air mode base. That's a little difficult to breathing control, and the lens system, surgical view is not so clear compared to user endoscopic spine surgery. That is different.
You mean that if you use the water in the standard technique is the same?
No, not same.
No,
not same. But the standard system is based upon the air mode.
Yeah, so if we use the
so what I'm
water
what I'm using is based upon water mode. Sometimes you can use air mode, in the air mode.
Yeah, if you use it in the standard water.
Yeah. But if you use the standard system water,
so if you can change the standard in the water,
no, we cannot do it. We have to use the dual mode standard system.
Okay.
Dual mode standard.
Okay. Thank you.
I would like to ask you about how can you control the water pressure and in and out.
Also, yeah, that's good question. Always in endoscopic spine surgery, we have to worry about water pressure like that. Okay, so especially biportal endoscopic surgery, sometimes water pressure issues happens. But how about monoportal endoscopic surgery? There is no serious water pressure happens because water going and go out is free. But when you are putting a large cage in monoportal endoscopic system, there is water issue happens. But a endoscope is just opened. The channel is opened, so there is less water pressure problem happens. Okay. We can control water pressure, height, or so I recommend just to use gravity. Thank you.
Okay.
Yeah, thank you.
Thank you so much. Okay. The next topic is Dr. Sudex Tata from USA. He will talk about the lumbar facet joint endoscopic surgery for managing spine symptom. Doctor, please.
Good morning. Thank you so much, Dr. Somanshur, Dr. Lim, and Dr. Akror for inviting me back. It's great to see how this conference is growing, and I hope from the US also will be part of the same endofia, like Dr. Lim is saying. So my topic today is actually facet joint nerve avulsion with the endoscope. And I've heard so many nice, great lectures. It's so difficult to follow all these great speakers, but Dr. Bam Bam already referred to how you can do non-fusion techniques to control some of the back pain that you have. And my talk is basically on axial low back pain that happens maybe before the surgery or even after a fusion. You have lumbar pain, which can be from the lumbar facet joint, or it can be from the SI joint in the lumbar area. So I'm going to quickly discuss the modalities of taking care of axial low back pain arising from mainly the lumbar facet joint and the sacroiliac joint. So these are my disclaimers. So the history of the facet syndrome was first described by Mooney and Robertson in 1976, and then a pain management physician from Australia called Dr. Bogduk described the mammaloaccessory ligament and the description of a radiofrequency procedure which was percutaneous, using a needle-based technique to destroy the medial branch nerve. He also noted that the mammaloaccessory ligament through which the medial branch traverses is ossified in 10% of cases. So that's the big advantage of using an endoscope when you're doing this procedure, because you can see the mammaloaccessory ligament, visualize it, and destroy the underlying nerve much more effectively than you can by using a percutaneous technique. So this is a cartoon. On one side is the nervous supply to the facet joint. On the other side is a cadaver dissection, and you can see that the dorsal ramus is the primary innervation to the facet joint. There are also other nerves involved. So this is again a description which is from the studies by Dr. Gore and the people at Wolf, basically showing, and Dr. Young, basically showing the mammaloaccessory ligament with the medial branch traveling under the mammaloaccessory ligament. It's important to note there are also other branches, which are the intermediate branch and the lateral branch, which is never addressed when you're doing a percutaneous rhizotomy using a percutaneous radiofrequency technique. So the medial branch is the most direct contributor to facet pain and innervates the multifidus and the interspinalis muscles, and it runs consistently through the mammaloaccessory ligament along the base of the transverse process. So usual destruction by an endoscope is at the inferior portion of the transverse process. The other branches are the lateral branch. The lateral branch significantly contributes to back pain, and it innervates the longissimus and the intercostalis muscles. And here it runs on the superior aspect of the transverse process. And there is also an intermediate branch which may contribute to back pain, and it's variable in presence and course. So first I'm showing a cartoon of what we do with a percutaneous procedure, which is we target only one nerve that I was describing, the medial branch nerve, and there is no direct visualization of the nerve. Results are you approximately get 50% success rate, and the pain relief only lasts for 6 months. With the endoscope, you are able to visualize the entirety. You are able to visualize all the nerves that supply the low back, and you are able to, under the endoscope, cut the medial branch at 2 different levels, one at the level of the joint and one at the level above. Just doing this procedure with the endoscope increases the effectiveness from 50% to 90%, and the pain relief outlasts everything to about 2 years. So from 6 months, you get 2 years if you use the endoscope. And in my experience, the pain relief has lasted even longer than 2 years. In the first cases that I did were over 5 years ago. So this is, again, showing what I described, which is the medial branch coming from above and also from below. Both are dissected. This is the visualization that you get with the endoscope. You get the epidural fat, and you can see the facet joint capsule. It's very important with this technique also, you are able to actually see the facet joint capsule and enter into the joint. So you're able to denervate the whole complex that supplies the facet joint. So I already mentioned this. Basically, when you're doing a foraminoplasty, you are actually taking care of a lot of these nerves. So, but the foraminoplasty is again not a direct visualization of the nerve. With the endoscopic technique, if you're targeting the facet joint nerves, you can do a much better job. So the equipment is a standard equipment. You don't need a bigger scope for this. The 7mm scope is enough. You have an Axis instrument, which is and various forceps, cutters, anything else you can use to cut the nerve. So again, the punch, the capsule scissors, or the biopsies, all of this. This is showing where the Kerrison punch is cutting the mammaloaccessory ligament. The improvement with the radiofrequency technique is specifically for the facet joint denervation. You can use a biportal or you can use a uniportal radiofrequency probe. I personally like using the bitip probe, which has got 2 electrodes in a small area, and you can actually denervate the capsule, the joint, everything else very systematically in a very small space. So these are the 3 common electrodes that you use for the radiofrequency ablation using the endoscope. So the technique, you basically position the patient in a prone position, and then basically, like I'm saying here, in the 2 joints, you're basically placing 4 needles, 1 needle per site. Usually, I place the needle straight down, no angles, and I usually place it at just a little off the SAP onto the transverse process. And then once you place the needle, you place a wire, and then you dilate with the dilator, and then you move back and forth with the dilator to kind of create a plane so that you can visualize the facet joint area properly. So here is basically what I'm showing is on one side is the uniportal, and the other side is basically using the bitip probe. And basically you can see that the scope is going straight up and down onto the transverse process. Here is a video basically showing this. I'm just trying to play the video. So basically, once you enter into the joint, you basically just see the fatty tissue, and then you can see I'm using the bipolar bitip to kind of open up the joint. And usually, most of the time, you can actually that's the corner of the facet joint that you can see. So you can see the entry of the facet joint. You can see the facet capsule. And this was my initial series, so I was using a little bit of contrast dye to kind of stain the area around the facet joint. Kind of helps me see where I am. I don't do that anymore. But in most cases, you're able to enter into the facet joint. When you change the angle, you basically from the straight angle, you just go up a little bit, and you're able to enter the facet joint and the facet capsule. Let's see if I can move this. So I'm moving next to SI joint denervation. The SI joint is also after a long construct or a long fusion, which happens pretty frequently in the US. You get a lot of SI joint pain. And so the options for SI joint pain is limited. So we have developed the SI joint denervation technique using the endoscope. And basically, anatomy-wise, the SI joint nerves is a complex of nerves. It's not one single nerve like the lumbar dorsal rami. Usually, it comes from 1 to 5 o'clock. So basically, the idea is to denervate the area around 1 to 5 o'clock when you're doing the SI joint. And basically, you can do S1, S2, and S3. Denervate those 3 nerves. And also, because the SI joint innervation is complex, you usually take care of the L4 medial branch and the L5 dorsal rami also. So there are 5 levels that we do, usually when there is an SI problem. So here's the technique. Basically, at the L4-5 level and the L5-S1, you insert it, and like you're seeing, the insertion is just a little lateral to where the transverse process and the SAP intersect. So access marking, usually up higher, you go a little more laterally. When you come down lower, you are a little more closer to the midline. At the sacral foramina, you are at 2 to 3 cm in the sacral foramina. The S1 is frequently difficult to visualize, and it's a little more vascular than the other areas, so just have to remember that. When I'm doing the SI denervation, I usually stand on the opposite side of the patient. So for example, if I'm doing the right side, I usually start at the left side. Whereas when I'm doing the facet joints, I usually start on the same side. And the reason being because of the angulation. It's easier to work off the opposite side when you're doing the SI joint, when you're doing the SI foramina. So you can see I'm basically standing on the other side of the patient and putting the guide wire and then inserting the instrument. It's basically I'm on the opposite side for the SI joint. And these are the targets. S1, S2, and S3 nerves. and also the L4 medial branch and the L5 dorsal ramus. So usually you can use unipolar or bipolar radio frequency. For the SI, the advantage of the unipolar radio frequency, it's a lot easier and faster to get down to the bone, and you can use glycine or water for the irrigation. It's a non-electrolyte thing for the unipolar. So here's an example. I got to just play this quick video. This is on the S1 area, and you can see I'm using a uniportal radio frequency probe. You basically go from 1 to 5 o'clock position, and on the lateral view, if you check on the lateral view, you can see the dilator just entering into the foramen. So same thing, S2, you can see I'm getting to the lateral edge of the S2 foramen, and the same procedure for the S2 area. Usually you don't need to do S3. Usually S1 and S2 is enough for the sacroiliac joint pain. This shows the SI joint capsule, and there's a study on it which also shows the sensory nerve fiber. So this is the dorsal ramus, and usually the dorsal ramus also is in the little ledge between the sacral ala and the sacral top of the L5. So this is a video of a live procedure and the end portion, and like you can see, I'm basically going just around the foraminal area, and this usually effectively denervates the nerve very well. The end point is you're down to the bone. Basically that's the end point. So I am going to end with my last slide. I would like to invite everyone next year to the American Society. We had a very nice initial conference with Dr. Lim, and most of the people here were there. It was very exciting to see everyone come along. US, the milieu for endoscopic surgery is a little more difficult just because it has not become so popular. But it is trying to gain real traction now, and we do have a lot of people who are interested in the endoscopic surgery. It's very impressive for me to see that after the session that we did last year, 2 of the people from the US are here attending the conference. They've come all the way from the US, so I want to give a shout out to the 2 people who have come, Dr. Desmasian and Dr. Munish Lal. Both of them are in the crowd. Thank you.
Okay, question?
I want to ask the question.
Sure.
In sacroiliac joint pain, you
Yes.
just ablated these nerves.
Yes.
You have not cut them.
No.
So what is the fun of using the endoscope when you are not cutting them? We can use the cold RF so that our area of ablation is more.
Very, very nice question. The idea behind the SI nerve is you can't cut the SI nerves. It's a very complex innervation. It comes in multiple levels. There's no sense in cutting because you don't have a single nerve to cut. You have to ablate the whole area. That's why we go from 1 to 5 o'clock, because you can't really see the nerves. They're so small in the SI joint, and it's very vascular. So that's why we avoid cutting it. We just ablate it.
Is it not better to use cold RF, which has more area of ablation?
So I don't agree with that. I mean, in the US, we actually are not authorized to use the cold RF. It's, the science has to follow, and the science is not there for the RF.
Thank you.
I have 2 questions for you.
Yes, thank you.
So I'm a reporter surgeon.
Yes.
So I did a denervation for a sacroiliac joint with
Yes.
UBE. I've developed the same technique. I'm
Yes.
doing the same thing like monoportal.
Yes.
And I have one patient with bad surprise after surgery developed S1 pain.
Okay.
Because I think the power of RF is too high. The plasma system for this. Did you have this kind of problem after?
My results have been really pretty impressive, and then to follow up, now it is a little more challenging to do the SI denervation in the US because the insurance thing changed. And they're giving us more difficulty doing the SI ablation versus doing an SI fusion. So it's easier doing an SI fusion in the US at present than doing an SI denervation with an endoscope. So you can see there's no sense or no rationale, but that's how it is in the US.
So
Yeah.
my second question.
Yeah.
In France, we have insurance pay for fusion, and we have a lot of bad results.
Yes.
Did you try to do denervation after fusion?
Not yet, no.
Okay, I have the question for you. What is the advantage of the endoscope in lysotomy? And how many % that you cannot identify the nerve?
So, very good question. So, in our statistics that we have, 30% of the pain comes from the facet joint or related area, 70% comes from the disc. So, it's a high percentage. Usually, the way we do this in the US is you have to do double diagnostic blocks, and they have to have at least a 50% success rate to the blocks before they will agree to actually let you do a rhizotomy. Now, the rhizotomy can be percutaneous or it can be through the endoscope. My personal preference, I have moved away from percutaneous rhizotomy completely. So I actually do all my rhizotomies through the endoscope just because the results are fantastic. I mean, I have people that have done it 7 years ago and they have not had a repeat procedure, which is unheard of when you're using the percutaneous technique.
So what is your chance of endoscopic facet rhizotomy? You do it.
Yes.
Even in any kind of RF ablation, we strongly believe in UBE or monoportal.
Yes.
Using of ablation on the joint capsule.
Yes.
Will anything you touch a fresh area, it will degenerate. So do you have faced any patients, though pain is gone, the facet capsule is ruptured and the patient ending up in injury?
So a lot of the nerves actually that are contributing to the facet joint pain come actually in the pericapsular area. So there's actually, I was looking in the literature before I came to the meeting, there are actually 2 publications out of the Asian, I think there are Thai people that publish this. Basically, they are taking up part of the transverse process also when they're doing this, and they're taking off the capsule. So the better results they're obtaining is when you're taking off part of the transverse process and part of the capsule. So just denervating that capsule and seeing that capsule is very important in the endoscopic procedure. I always try to get into the joint because I feel my results are better when I see the joint and I can take down part of the capsule.
Thank you.
Thank you so much. So
thank you. Thank
Yeah.
you so much.
So we will move to the last speaker, the endoscopic spinal surgery under local anesthesia. Oh, not you. Okay, you're saying right? Okay, Dr. Garis Dakta, please. His topic is pathophysiology and pathoanatomy for the endoscopic surgery.
Oh, just a minute. Oh, hold on.
They change the topic.
First open it, otherwise it will crash.
Okay, yeah. But on the web, yes, on the website.
Double screen.
No, I can't see. Thanks for the opportunity. I think I need to hurry up because everybody's waiting for the coffee. So a lot has been spoken about endoscopy-related techniques and how we do it, what kind of tools we use. Let me get you back into anatomy class on what is the basis, pathoanatomic basis of endoscopic decompression of stenosis, and let's look into what are the pathological structures that are important, and over a period of time, this anatomy gets converted into a pathology. Professor Bambang Darwano has already told you a lot about how the deformities develop and how degeneration occurs, but I'm going to tell you exactly what are the structures that are important. Okay, the most important thing that we are looking at is if you see a rundown view through the spinal canal, if you reconstruct the whole thing, you see the narrowest part of the whole problem is lateral. The medial part of the spinal canal is quite big, and it is the lateral part which is involved. And the primary structure that is involved in majority of this condition is the superior articular process. The inferior articular process contributes to the problem much later on in the progression of the pathology. So primarily, if you have patient, then it is going to be, in the early phase, is going to be the superior articular process. All components, the base, the part of the SAP, as well as the tip of the SAP. So we have seen this famous Kirkcaldy-Willis diagram wherein you have annular fissures translating to herniations, and the first thing that happens as a secondary disc-related disorder is a lateral nerve entrapment. So you usually have a gap between a primary disc-related disorder, then you have a time when the patient is asymptomatic, and then later on, the patient comes back with the stenosis symptoms. So this is usually what we call it as a secondary disc-related disorder, because the primary problem starts in the disc itself. It is not any other structure that is causing the problem. So you have the lateral nerve entrapment where patient comes. So these are basically how degeneration in the disc occurs. And finally, when you have resorption in the disc, formation of end plate osteophytes and calcifications in the disc or in the annulus can contribute to a lot of problems. What is happening in the facet joint? A lot of things is happening in the facet joint. You see degeneration. What kind of a degeneration? It's an intra-articular. It's a complex synovial joint, the way you have a knee joint. So you're going to have osteolysis, you're going to have osteophyte formation, you're going to have some amount of bone resorption within the joint, which causes some amount of instability, a micro instability. And that is one of the things which is responsible for listhesis or lysis. You can have problems with upshift of the superior articular process. Now, we all think that the tip of this SAP is the one which is causing the whole problem, but we need to understand it is not the tip. It is the medial part of the tip of the SAP and the flavum, because we need to understand the attachment of the ligamentum flavum. The ligamentum flavum is attached to the tip of the superior articular process. Whenever the tip of SAP migrates inwards, that is within the canal, or outwards, it tries to pull the ligamentum flavum from the extraforaminal area or from the canal, causing all the problems. So if you are able to detach it completely and then remove it, it's much, much superior. So the target has never been a central canal. Okay, we'll go into that. So this can cause facetal subluxations, which can cause problems. Whenever there is a collapse, the whole disc doesn't collapse in one concentric collapse. It is always in the form of rotation. That is the reason the facet joint or the superior articular process either comes inside or goes outside. Now, if you see anatomically, in the lateral recess, the traversing root is never underneath the bone. It is only underneath the part of the ligamentum flavum, which is very tightly placed there. Only when you have this kind of a rotation accompanied by collapse, you're going to have a pathology there. So you should have an eye to see the MRI when MRI is actually not showing you a lot of things. Now, ligamentum flavum, a lot has been spoken about ligamentum flavum. Ligamentum flavum, you have as much ligamentum flavum in the spinal canal as you have it in the, sorry, I'll just go back here. You can see you have about 11.9 or 12 millimeters of ligamentum flavum in the canal, and you have similar amount of ligamentum flavum in the foramen and the extraforaminal area. And that forms the basis of transforaminal decompression of stenosis, provided you know where the stenosis is. You cannot have a big lateral recess stenosis in the different zone where you are not able to access with your endoscope, then you may have a problem. Now, the way we see our MRIs is completely different, because we are all used to it, because we all screen them in the plane of the disc. We need to understand that the facet joint, the stenosis pathology is not a disc, it is the facet joint. So if you change the gantry, just change the gantry of your image-identifier, you'll start seeing the ligamentum flavum. So if we have to image stenosis, you have to do it in oblique coronal imaging, which is basically a sequence that is run for the sacroiliac joints. You see so much of ligamentum flavum now. You just changing the gantry and getting the whole thing in the plane of the facet joint, not in the plane of the disc. Okay? These are some papers which are showing where the ligamentum flavum imprint is on the dura. You can see it's basically the axilla and part of the traversing root. So these are the papers which are published. Now, ligamentum flavum. You may see a very bad looking MRI patient is asymptomatic. Why does this happen? This happens because the type of the ligamentum flavum the patient has. So you have a type A, B and C type of ligamentum flavum where part of the ligamentum flavum is only confined to the spinal canal. Most of these patients will have no symptoms, whereas something like, for example, type C, where the ligamentum flavum blends with the facet capsule and continues as an intertransverse ligament extraforaminally, these are the patients more susceptible for all kinds of problems. A little bit of a degeneration and the whole stenosis becomes symptomatic. So ligamentum flavum is an important structure to understand. By and large, we cannot identify this type of ligamentum flavum. These are only from the studies. Okay, past defect, I'll just skip it off. It doesn't mean anything. Now, pathophysiologically, what happens? When you have any kind of a compression, it basically breaks down the blood nerve barrier. And there is an intraneural edema, which causes the whole concept. So where is the stenosis? Whether the stenosis is at the level of the dura or whether it is at the level of the nerve, symptomatology in spinal stenosis changes. Whether you're going to have numbness, whether you're going to have claudication, or you're going to have pain, is dependent upon what is getting compressed. So it is important for us to understand where is the compression. Okay, so understanding the patient's history and symptomatology is important. And there are so many papers when we are saying that you have a stenosis and patient has a ball and bladder involvement, though not great amount of compression. This is because of the Wallerian degeneration that is happening proximally. Even if you have a distal stenosis, you may have it. Now, what are the best ways to see all this stenosis? CT and myelography, one of the classical investigations that are done, predicts this kind of stenosis very accurately. Okay, but again, this is an invasive procedure, so it's no more done as a routine. Now, diffusion tensor imaging is one of the things which will tell us kind of stenosis. You can see the kind of stenosis here, where this is marked here. So this can pick up stenosis at a quite an early stage. So what is the strategy? The strategy is locating the pathology. If you know where the target is, you are able to treat it, you are able to choose your surgery well. So, as I told you, the lateral recess, one of the most complicated areas and less understood, the entry zone, the mid zone, and the exit zone. Now, these are spread over two levels. One is a level above, one is medial to the pedicle, one is lateral. You need to exactly understand where is the pathology. If you understand where the pathology is, you're able to treat it, you're able to choose your surgery well. Okay? Choice is yours. Transforaminal surgery or translaminar surgery. Both surgeries are good. There is nothing, you need to just identify what is more dorsal. Okay? For transforaminal access, we all know, and it's been a lot of spoken about it. So up migrated, down migrated. For exit canal stenosis, again, it is treating the lower foramen. And if you have an inlet stenosis with the borderline mild canal, you can use a primary foraminotomy kind of a technique. Interlaminar, we all know ipsilateral and contra. I'm not getting into the surgery because a lot will be spoken about these kind of surgeries. Okay. Exit canal stenosis can also be done in interlaminar in the posterior axis. Just some brief videos of how things are done. This is the transforaminal. So this is the part of the ligamentum flavum which I told anatomically is in the axilla. So I'm using a Holmium-Yaag laser. You can see at the 10 o'clock position, you can see the exiting route. This is part of the ligamentum flavum which is compressing on the holes. You can see vascularity on. This is evidence that there is some amount of compression there. There is some amount of ischemia which is causing inflammation, causing this kind of neovascularization. So you can treat it. This is a transforaminal surgery performed under local anesthesia. So step by step, you can start decompressing the whole area. What is the end point? In one vision of your endoscope, you should be able to see the exiting and the traversing route with the axilla clear. So short of time. So you can see the route. Already part of the superior articular process and the base is already done. Now you are taking off all the ligamentum flavum. So tool or energy source is of choice. You can use mechanical instruments, you can use laser, doesn't matter. It is just an energy tool. This is the amount of decompression that you have achieved in the entry zone as well as in the little bit of the middle zone. So PSLD, I'm not going to speak about it. A lot will be spoken about it, so I'm not going to talk on that. So how do you choose what to do? So you know the pathology. You know whether it is predominant dorsal or predominant ventral. You can choose your surgery based upon the location of the pathology. So you have an option of interlaminar, you have an option of transforaminal surgery. Thanks for your patient listening.
Okay, have any questions?
Thank you very much for an excellent talk. I'm at the start of the learning curve, so I've just started endoscopic spine surgery. Do you have any tips or tricks how to, I'm finding it difficulty to look at the traversing nerve root. Exiting is easy in transforaminal endoscopic surgery.
What?
I can find it easily.
What level are you talking of? 4, 5, 3, 4, or 5 as well?
4, 5.
So 4, 5, you need to understand. See, how shallow you are going to get into the spinal canal is going to be the key of how whether you will be able to reach the canal or not. Important thing is for you that you need to do a foraminotomy to see this. Okay, so foraminotomy is the key to seeing a traversing route. Most of the times, because of the larger interpedicular distances, you are getting inside the canal shallow is very difficult.
So you need to remove more SAP.
Yes, non-articular part of superior articular process.
Okay, any question? Okay, so we have the time limitation, and I will check the total number of the registered participants in this conference right now. Do you know how many participants? It's more than 400 participants.
Wow.
I think it's the biggest endoscopic spine surgery in the world. We had to give the big hand to Dr. Shomansur again.
Yes.
Thank you, sir. And we have to finish it. Thank you. Move to next session.
Yeah, thank you so much.
Yeah, the coffee and the meals will be available, but everybody cannot fit in that space, so we will keep the next session. But who wants to coffee or snacks can go out and come in with that. So please, for the next session, I will invite to moderate Dr. Hikmet Ulu is coming, and Dr. Grish Datar. Dr. Datar, you will be moderating. Hamma chiqib ketish shart emas, davom etadi, sessiya davom etadi, lekin chiqib kirib kofe olsa bo'ladi, chunki hamma sig'maydi baribir tashqariga.
А листать? Добрый день, уважаемые коллеги. Меня зовут Седых Ольга, руководитель Кадавер Лаб в Екатеринбурге. Мы имеем международную регистрацию, аккредитацию, и будем рады, если вы приедете на любые наши курсы, потому что у нас большой опыт их проведения. Проводим их с 2013 года, уже 12 лет, и провели уже больше 400 курсов. Но вот как раз по эндоскопической вертебрологии пока курсов нет. Это такое новое, такое передовое направление. Нам бы очень хотелось проводить такие курсы тоже. Поэтому я надеюсь, мы в ближайшее время подготовим и вас информируем. А вообще я не травматолог, я врач, но другой специальности. И мне так приятно находиться здесь сегодня с вами. Вы не просто красивые, умные люди, мужчины, занимающиеся серьезной специальностью, вы еще неравнодушные к человеческой боли, настоящие врачи. И вот такие врачи приезжают к нам на кадаверные курсы, и мы даже учредили номинацию. И мне очень хотелось бы сегодня в торжественной обстановке вручить номинацию «Участник года» Шкулову Тестанжону. Как это мне лучше сделать? Да.
Спасибо большое.
Это произведение искусства, бронзовая сова позолоченная. Это произведение Златоуста. Это наш уральский как бы промысел, так же как каслинское литье, матрешка там, и так далее. И такими пока еще обладают немного людей. Но вот Сергей Олегович Рябых завтра будет, он тоже удостоен этого звания, клуба «Бронзовой совы». Поэтому мы очень рады. Приезжайте к нам еще.
Огромное спасибо.
Да. Вот. Ну и я попрошу пролистать на последний слайд. Или здесь это можно сделать? Если заинтересуетесь нашими курсами, вот наши контакты. Спасибо за внимание.
Hello everyone. I request everyone to come to the hall because we are starting the session. This morning session, full endoscopic session. Can we start?
Dear colleagues, first speaker is a highly experienced neurosurgeon from Turkey, Dr. Hakan Sabuncuoğlu. He will talk about highly migrated extraforaminal lumbar disc herniations. Yes, doctor.
Thank you, dear presidents. Welcome, my colleagues. In this session, I will try to tell about the highly upgraded extraforaminal lumbar disc herniations. In daily practice, we use the far lateral disc herniations, extreme far lateral disc herniations, but in this lecture, I will use the formal one, which was mentioned by our spine nomenclature as extraforaminal lumbar disc herniations and extraforaminal endoscopic lumbar discectomy. When we know that extraforaminal lumbar disc herniation is responsible 7 to 12 of all disc herniations, L3 and L4 are the most involved levels, and that the patient's age is between the 50 and 80 years old, and male and female ratio is near 1.5. But what do we know about highly upgraded extraforaminal lumbar disc herniations? They are very rare. They have extreme radicular pain when compared with the other extraforaminal herniations. They have extreme size, difficult to diagnose, difficulty in reaching both the disc space and the extruded fragment which passes through the whole vertebral body. In routine MRI examination, sagittal sections should be reached extreme extraforaminal space. If it doesn't go through the vertebral body and foraminal space, 30% of probability of misdiagnosis can be seen. In this picture, this is our patient, same patient. Look at, there is a foraminal herniation, and now extraforaminal herniation, and the last one, you see that this is the very parasagittal section of the sagittal MRI, and you see the herniation which goes through the vertebral body and near the upper foraminal border. And again, here is the extraforaminal herniation, superiorly migrated extraforaminal herniation, and highly upgraded extraforaminal herniation. If you have a suspicion this type of herniation, please, instead of taking of 3 slices at each disc level, please try to take 4 or 5 slices from disc level, and also this herniation, and if you have a suspicion that this herniation goes up or going to highly up, then please try to take the sections, slice sections, with 1 millimeter intervals from the vertebral body. Also, coronal section is very important for the evaluation of the extraforaminal superiorly upmigrated herniations. In routine MRI protocol, mostly the coronal sections mostly not included. If they include, they don't take the MRI coronal sections till. For coronal sections, the ideal way is to take the images instead of perpendicular sections to 15 to 30 degrees, which is parallel to the posterior vertebral body. This is our case presentation. Male patient, 65 years old, married with 1 child, right extremely strong leg pain, dysesthesia for 3 months, no motor deficit, multi-algologic interventions and physical therapy without improvement. I show you these MRIs before you, and you see at the third one, you see the extraforaminal herniation near the upper intervertebral foramen border. Look at these. The patient came us with a very basic MRI, and we have a suspicion for the extraforaminal high upgraded herniations, and we decided to take thin sections. There are 8 axial sections with 1.5 millimeter intervals. This is the 9th one. You still look at the red arrow. Still the extraforaminal herniation is near the vertebral body. This is the coronal view of the herniation. These are the routine approach, discography, dilatator, lateral plane control, working cannula and taking the dilatator out, and again check the cannula's position, lateral view. And here is the during the operation. During the operation, after resecting the extraforaminal herniation, in this type of herniation, you should go highly up. Maybe you should retract the nerve root a little bit up. Before the operative planning, if you have a decision to retract the nerve root a little bit up, then you can use the neuromonitoring during the surgery. Here is our operation. It's very short, 50 seconds. We first, in this case, the sequestral fragment doesn't have any connection with the disc space. We first decompress the intervertebral disc space, and then we pass to lateral border of the vertebral body, and we see the L3 nerve root here. And under the nerve root, we see the extruded fragment. And then we use the angled forceps for the resection. There are many sequestral fragments, three or four. This is the shortened video. And again, we will take the last one now. And then after, we will check the under the nerve root. It is very important, this type of herniation. If the herniation is only disc level, okay, maybe you cannot retract and you cannot control the under it. But if there is a highly migrated herniation, you should check the under the nerve root, and you should see the big herniation cave there, and you should also believe that there is no extruded residue fragment. Last verse to take away our home. In diagnosis of extraforaminal herniation, check the sufficiency of routine MRI. If you have a problem, if you have a question mark in your mind, please get detailed MRI again from your patient. In DAPT, perform thin section, all 3 plans, not only the coronal, take thin sections, all 3 plans in MRI examination. Remember that highly upmigrated extraforaminal disc herniation is very rare and difficult to diagnose. In preoperative evaluation, plan to use neuromonitoring in cases where the herniation extends over the lower border of the pedicle, as the possibility of root maneuver increases in the operation. Don't perform surgical planning without coronal slices. Don't perform the surgical planning without coronal slices, especially in extraforaminal herniations. In patients with highly upmigrated herniation, always finalize the surgery by checking the under and above the nerve root. You know that we are using minimal invasive surgery, and less is more everywhere and every time in our life. And minimalism is our style of art. Every time we say that less is more, but no matter how much we say less is more, for someone, more is more. Thanks for your attention.
Thank you, Dr. Sabuncuoğlu, for excellent presentation. Is there any contribution or question from audience? Yes, doctor. Become.
Do you prefer to remove just a migrated disc or remove?
Both from the migrated disc and the disc space. Do you prefer?
If I have a chance to take the extruded fragment without touching the nerve root, it's okay. But this type of highly up herniation, we need to retract the nerve root a little bit, because there is a residue fragment over the nerve root and under the nerve root. Maybe we can take only the sequestral fragment, but maybe if you don't retract and if you go under it, you cannot see the upper located sequestra disc herniation.
I mean the migrated fragment and in the discal fragment. Do you prefer remove just outside or inside
No,
the disc?
no, no. Every time I decompress the intervertebral disc space and I take the herniation and protrusion there and the extruded fragment together, every time.
Is there another question or contribution? If there is not, with your permission, I have a little bit contribution, Dr. Sabuncuoğlu. First of all, the MRI diagnosis, every time, every place, every country, there is problem for diagnosis. It is very interesting because there are 4 criteria for axial section. First of all, focal eccentricity. Second one, loss of fat plane around the exiting nerve. Third one, displacement of the nerve root and the thickness change. These are major MRI criteria. And another one then, extraforaminal herniations cannot migrate caudally because there is pedicle. And in our series, approximately 150 cases, 90% there are cranial migration. And you are right, the highly migration is very difficult cases. Also another type approach, you are saying that every time we are decompressing the normal disc space. Did you try without decompress the disc space to reach directly the herniation?
It's up to surgeon, you know.
Yeah, of course.
But I couldn't feel myself better if I don't resect the protrusion, or if I see the annulus tear, I prefer to decompress the disc space.
You're right.
Also, many participants know that Dr. Ulu is our senior endoscopic surgeon in Turkey, and also we learned the coronal MR images importance from him. Not only the extra foraminal herniations, also the other part of the herniations. I every time try to take the coronal images before the operation.
Thanks for your pointed out. Coronal sections every time are very important. You are right. Thank you, Dr. Sabuncuoğlu.
I have one more question for you. Doctor, I have one question for you.
Dr. Sabuncuoğlu, please.
Do you perform all your surgeries under local anesthesia or under general anesthesia?
Sorry?
Do you perform your surgeries under local anesthesia or general anesthesia?
In my preference, I prefer to do all the surgeries with general anesthesia, and if I have a suspicion that during the operation I will do so many retraction, especially this type of herniation, I use neuromonitoring.
Thank you.
Yeah, my question is, when you have extra foraminal herniation, when the nerve root is more dorsally displaced because of the herniation, what is your target point for that?
Every time I use the safe zone, my target point every time, although the herniation is going highly up, I try to put the needle very closest to the lower end plate of the disc place.
Lower end.
I'll call upon the dais Dr. Donghung Yang to speak on advantages of coronal MRI-based classification of upper migrated herniated discs and addition of cardinal surgical steps to facilitate transforaminal endoscopic approach.
Thank you for kind introduction. When I go to the top, my topic is a little bit connected with Dr. Akan's topic. And here, I got some foreign experience. And I hope in some days our society can be expanded to the African continent, across this continent. This is my hope. And let's go to the about microcystic HLD. It is more common in elderly and often involves foramen and separated into multiple fragments. And still there is a classification, but nobody used that classification. And transforaminal approach is the least invasive option among other approaches, but it is technically difficult. So I have two proposals. First, is developing a surgically useful classification for about-migrated HLD. And second is adding cardinal and standard surgical steps to reduce surgical difficulties. This is inclusion criteria. This is material. And the mean age was over 60 years, and foramen type was most common. Let's go on classification. Current classification is from 2012 to Dr. Anyong and Hodongwa and Chegon. All of classification is similar and based on sagittal MRI. My question was that, why not coronal? Coronal has some features. It can visualize more accurate shape of entire ruptured disc. And also it can provide much more and precise relationship with adjacent structures. So I made a hypothesis. If the coronal MRI is superior in detecting the upper tip of ruptured disc, the higher grade will be more on coronal MRI classification. This is important because the surgical difficulty is depending on the location of ruptured disc. Here, the coronal MRI classification, it has two determinants. The first is the height of ruptured disc. Second is medial location of ruptured disc. The height of ruptured disc is the same from the previous studies, and I made it, this description is very simple. So there are two reference lines. First, endoplate, and second is inferior pedicle line. So grade 1 to 3 is easy. And second determinant is medial location. The reference line is inner pedicle line, it's grade M and L. So this classification is very easy. Just remember and memorize two IFLs. Let's compare results. In the present study, grade 2 was most common. Dr. Anyong, the frequency was similar across the grade, and Dr. Hodongwa, grade 1 was most common. The primary difference is this study is coronal MRI based. By this finding, I could make a suggestion the coronal MRI is superior in identifying the upper tip of ruptured disc. By this finding, I made another definitions. Higher and more medial location of ruptured disc, that is grade 2, 3, and M. That is a key factor for the surgical difficulties. That is a top of canvas triangle. I named it as a high axial space. Because of the nature and the character of this name, this is a totally transforaminal endoscopy specific anatomical definitions. When you come to the border, the medial is dura, lateral is the exiting root, inferior is the midpoint. And let's compare. When the disc rupture is in high axial space, I grouped it as a severe, otherwise that is moderate. Age, symptom duration, level of disease, in intensity of pain was not different, but the motor weakness and foraminal stenosis was more in the severe group. And despite the increased surgical difficulty in severe group, but the outcome was not different. It was possible by addition of cardinal surgical steps. The issue is that how to reach the high axial space easily. Let's imagine that high axial space is not a flat area, that is a three-dimensional space. It is looped by upper tip of SAP and the proximal attachment of inferior extraforaminal ligament. So I made some principle for precondition for basic surgical steps. It should be safe and standard. High axial space unlooping was possible without expert technique. And second, sufficient visualization without excess exiting root retraction. Let's go on anatomy. The outer surface of SAP has a convex curvature, and that is the first obstacle for medial advance of endoscope. By the flattening of SAP, more medial advance becomes possible. And this is before and after. After SAP flattening, we can see up to the midline, midline inside the canal, and the size of foramen increases. Because of this advantage of the increased size of foramen, the endoscope can maintain its mobility, and detailed rotation and tilting technique become possible. For the flattening SAP, the contact point of endoscope shouldn't be the foramen. It should be a lateral the outer surface of lateral protuberance. Over there is not empty space. Always there is a bundle of dorsal branches. So don't try to find and locate the dorsal branch and cut it by this small maneuver. And during the entire approaches, you cannot see any bleeding. So this is creating a new space rather than exposing an existing space, like a laminectomy in interlaminar space. So it can expose a hidden laminar space. So because this is creating a new space, this is a very, very safe and very low risk of acting root injury. When you go to the ligament, upper half of the foramen is looped by the ligament. The inner is foraminal ligament. That is a very strong protector of exiting root outside of a foramen. Its proximal attachment is SAP and lateral extension of ligamentum flavum. When the opening is not enough by SAP flattening, cubite and cutting of proximal attachment of extraforaminal ligament by this maneuver, the path to the high extra space can be expanded more. And when you look at this video, in the beginning, the cranial was 3 o'clock side, and when we look at the high extra space, cranial is at 12 o'clock. This is a cranial rotation of endoscope. Considering that TLD is an oblique approach to the vertical foramen, let's imagine that when the angled optic side of endoscope is combined with a 90-degree cranial rotation tilting, and much more expanded view to high extra space can be possible. And when you go back at the beginning, the mean age of the study is over 60 years. In over 60 years, they have some degenerative changes like foraminal stenosis and listhesis. This is my last case in 2 weeks ago. This is grade 3M. Our target is flattening and cutting the tip of SAP. The hypertrophy SAP cannot be a barrier because they are easy to remove. But hypertrophy of extraforaminal ligament can be a barrier. It is harder to remove. A key step is repeat cutting bone and ligament until to see, and you can secure enough high extra space view. And in this case, it's rotate more than 90 degrees cranial rotation and tilting. By this maneuver, you can see entire high extra space without acting root retraction or very critical anatomical structures sacrifice. Okay, you see, high extra space is visible. And after that, only upper tip of SAP was cut. So this is my conclusion. The coronal MRI-based classification represents the shape of rupture disc more accurately, and it can provide clinically useful information and surgical planning. When the rupture disc is expanded into the high extra space, we need more cardinal and routine surgical steps like flattening SAP, cutting inferior extraforaminal ligament, and 90-degree cranial rotation and oblique tilting of endoscope. Thank you for listening.
Thanks a lot, Dr. Yang. Any questions? Yeah, Dr. Pompoit.
Thank you so much for excellent presentation. I agree with you to resect some part of SAP in particularly the foraminal stenosis. My question is how many cases after follow-up, after you resect the tip of SAP, that you know the tip of SAP is very important to protect upward migration. So how many % of the case after you resect have upward migration of SAP?
That will be depend on how many percent of SAP is cut by the cases. And the cutting percentage is depending on the patient, but I never do even that is a very severe pulmonary stenosis, I don't go more than disc space levels, so to protect the passage joint. And so by the follow-up, I can't say how many percent was recurred some symptom of pulmonary stenosis, but if that is only from the symptom by the left disc, I don't remember any recurrent symptom. But that is symptom is from the pulmonary stenosis only. The symptom can be recurred because of the size of foramen. There's a limitation of increasing only by the SAP cutting.
Yes. Any more questions?
Thanks for your presentation. I have another question. Probably you're aware about the pars interarticularis approach for extraforaminal herniations. This is a little bit different from you, from the right angle, and then the drilling of the pars interarticularis along to lamina. And my question is, why are you preferring the drilling of the SAP instead of pars interarticularis? What is the advantage of this method over another, the pars interarticularis method?
Yes, because pars interarticularis is a very strong strut of the vertebral body. But in the outside of SAP, sometimes there's some hypertrophy, and so flattening, it doesn't change any the vertebral stability. But if we cut the isthmus, there is a more risk of the further fracture of isthmus and pars interarticularis. So I don't cut the pars interarticularis, but only by the flattening and cutting only the tip of the SAP.
Sorry, flattening means drilling, huh?
Yes, drilling.
Not drilling, it's okay.
Yeah, but I never approach to the. I don't do the pars interarticularis drilling.
Okay, thank you.
So I have one small question to ask. Do you cut the entire thickness of the tip of the SAP, or you just cut the ventral aspect of the tip of SAP?
Like the last cases, if there's some prominent stenosis, we need to cut entire depth of tip of SAP. But we have enough the space. I don't cut only the flattening. I don't cut the tip of the SAP.
Do you think by cutting the whole thickness of the SAP, you are adding to the natural history of collapse? That means naturally the disc is going to collapse, and the collapse will stop when the tip of the superior articular process abuts against the cranial pedicle. Now, if you have cut the part of the SAP completely, do you think there will be an asymmetric collapse of the disc space, causing tight foraminal stenosis over a period of time?
Yes, if we cut too much of SAP, there is a possibility of that collapse, but I don't cut too much of SAP. Only like in pulmonary stenosis, we can see some overreading of passage joint. So unless that kind of pulmonary stenosis, the tip of SAP is over the inferior articular process. I cut only overridden the part, not entire part.
Thanks a lot. I hope there are no more questions. Excellent talk.
Thank you.
Yes, next speaker is Dr. Fuhita. He will talk about surgical techniques to avoid dural tear and epidural hematoma. Yes, doctor.
Thank you for Professor Rim. I'm Kazuhiko Fujita. I'm from Japan, Aichi Spine Hospital. It's a great honor to be able to speak today. This is Japanese Formula One Grand Prix. For a long time in Japan, the most common endoscopic spinal surgeries were performed using the MED system. But it is now rapidly shifting to UBE. Although I have performed both MEL and full endoscopic laminectomy, I switched to UBEL for lumbar spinal canal stenosis a year ago. We report the clinical outcome and the surgical techniques to avoid some complications. Total 105 patients were performed UBEL for LSCS. Patients with disease as described were excluded. Follow-up for at least 3 months and clinical outcomes were investigated. The decompression method is unilateral laminectomy for bilateral decompression. Left side entry, 2 skin incisions. In early cases, Kelson rongers were mainly used as shown in the video. However, it was dangerous because it was compressing the nerve root and there was a high risk of dural tear under irrigation. After several cases, I changed my surgical procedure slightly. I found UB has a good operativity, so make it easy to operate the chisel. I realized once again that Kelson rongers are dangerous and should be avoided. Then I'm stopping using Kelson rongers. Case 1 is L45 severe canal stenosis. This is video. First, L ligament were detached craniocaudal side by a high-speed drill. On the entry side, inserted a curved chisel and cut out the GIAP. Lift it up with a curette and removed it. Next, contralateral side. Insert the chisel, contralateral side IAP. SLP. You can see the lateral edge of the nerve root. Finally, unroofing was done. Post-operative MRI shows sufficient decompression. Case 2 is L3-4 canal stenosis. The facet joint angle is steep and narrow. In the same way, yellow ligament were detached craniocaudal side by a high-speed drill. In this case, we started from the contralateral side to avoid expressive bone resection on the entry side. Remove the bone fragment. Inserted the SAP. You can see the lateral edge of the nerve root. On the entry side, we inserted a curved chisel and cut out the IAP SAP. You can see the nerve root. Finally, in the same way, unroofing was done. Removing debris. Postoperative MRI shows sufficient decompression. The facet joints are well preserved. Last case is L4-5, severe canal stenosis, and L4 spondylolisthesis. L4 IAP is ventrally displaced. In this case, since there is no SAP directly below, the chisel must be inserted carefully. We carefully removed the adhesion and removed the bone fragments. The contralateral side is the same. The decompressed nerve root can be confirmed. Due to L4 spondylolisthesis, we performed unroofing more towards the cranial side. Postoperative MRI shows sufficient decompression. Result. There were 105 surgical cases, 41 women and 64 men. Mean age was 70 years old. The average surgery time was 67 minutes. After surgery, low back pain and leg pain was significantly improved. 92% of patients scored good or excellent. Complications. There was neither dural tear nor epidural hematoma. However, there was one case of infection and 2 cases of transient motor weakness. Both cases were contralateral side and recovered within a few days. Discussion. Dural tear is a major complication of endoscopic spine surgery. The dural tear rate is generally reported to be around 3 to 5%. Most of them were likely caused by Kelson rongers. Professor Powell reported the no-punch decompression techniques, and there was no dural tear in 68 cases. There was also no dural tear in our cases. Dural tear can be avoided by not using Kelson rongers. Another advantage of using a chisel is that the nerve root can be decompressed from the outside. This prevents insufficient decompression. Chisellectomy can be a high risk factor for epidural hematoma. However, there was no epidural hematoma in our cases. These are our hematoma prevention measures. After general hemostasis, we perform complete stopping bleeding within the muscle layer. After removing the debris, inject proceed. Finally, insert the drain in a loop. This is to increase the surface area of the drain tube and avoid it irritating the nerve root. Conclusion: short-time surgical outcome after conversion to UBEL were good. Dual tears are avoided without using Kelson rongers. When using a chisel, careful prevention measures against hematomas are necessary. Thank you very much.
Thank you, Dr. Fuita. Is there any contribution or question? Yes, doctor.
You know, I'm like to have zero complication. It's very nice, but in UB surgery, in all literature, there is about 8 to 12% of hematoma. And when you do a lot of surgery of UB, you have some hematoma. How you know that you don't have hematoma? You make MRI, you make CT scan. How you know that you have 0% hematoma? How you do? What's your criteria for no hematoma? MRI after surgery? Pain after surgery?
Sorry?
How do you know that you don't have hematoma with chisels? You have MRI? It's clinic? How you know? Post-op MRI?
Post-op MRI is if you do
you
will see is post-op hematoma is 0 or no?
Oh, almost zero.
Zero, but how? Because you know, I use Flowsil, I use drain, I are very fast, I use ultrasonic, I use what you want, I have hematoma. So I need to go to Japan.
Do you do a post-operative MRI after every surgery? Do you do a post-operative MRI after surgery?
Yes.
So, no hematoma.
No hematoma, yes.
So I will go to Japan. Thanks.
Okay, one little thing here I thought was to add in here, the osteotomes that you're using, chisels that you're using, need to have graduations. You need to have graduation of 0.5, 1 millimeter, 1.5 and 2 millimeters, because once you're doing a contralateral, there is sometimes a lot of overhang of the contralateral lamina or the facet. So the moment the chisel goes inside, then you don't know how deep you are going inside. So if you have graduations on your, or markings on your chisel or osteotome, it is much safer, much easier, predictable how far you are going. This was a suggestion. This is not a question. It's a suggestion.
Yeah. Hello. I feel epidural hematoma complication is well appreciated in the first 4 hours post-operative. First 4 hours. If first 4 hours there is no hematoma, there will be no hematoma usually. So, but usually you do a MRI next day. I think you have underdiagnosed hematoma. There would be hematoma, but it would have been resolved. Sometimes hematoma will be there in cases, but they are significant only if it comes in the first 4 hours.
And with curette, you don't have dual tear. With curette, no tears. Curette, no tears.
No tears.
Never.
Never. This method.
Okay, so I'll go to Japan.
Thanks a lot. And very nice talk, something enlightening. Let's give him a hand of applause.
Thank you very much.
Okay, I'll invite Dr. Lavkush Pandey from India to speak on PSLD versus PELD in high iliac crest cases for paracentral or migrated disc herniations. Dr. Lavkush Pandey,
Thank you, sir.
dice is yours.
Hello. Yes, good afternoon, everyone. I'm Dr. Lavkush from Dehradun, India. And my journey in endoscopic surgery started around 12 years back, and my teacher, Dr. Girish Datar, is sitting just near to me. And he ignited my mind to endoscopy and started my journey with transforaminal endoscopic surgeries, and later shifted to Intel Minor and UV. Once I met Dr. Kang Tung Lim in South Korea. So my topic is to talk about the transforaminal versus interlaminar surgeries for the cases with high iliac patients. The percutaneous endoscopic lumbar discectomy for the lumbar disc herniations has been established and well-known procedure. Spinal surgery at the junctional area has always been challenging in terms of surgical approach in cases of with L5S1 level. It has a challenge for the endoscopic procedures. At L5S1 level, the available surgical options for the disc herniation include microdiscectomies, microendoscopic discectomies, suprailiac transforaminal endoscopic, and transiliac transforaminal endoscopic approaches and interlaminar approaches. So while assessing the herniation and L5S1 level, the commonly faced challenges are like high iliac crest, large transverse process of L5, and sacral ala, narrow anterior posterior diameter of the foramina, considerable interpedicular distance, and disc herniation inclination due to the lumbar lordosis. So, in difficulty in transforaminal approach in the earlier cases, earlier journey of my endoscopic surgery, we shifted the new technique we started doing in transiliac approach. So we are generally doing all kind of surgeries, endoscopic surgeries. So we should be knowing about our most of the approaches which are being done earlier very commonly. So the transiliac approaches, the Usman and Malicis reported a cadaveric study on the feasibility of the transiliac approach for the L5S1 level in 1997 and concluded that the transiliac approach in the lumbosacral junction is safe. The Usman et al. In the study reported the results of the transiliac approach in 15 patients for the L5S1 disc pathology. He concluded that the endoscopic transiliac approach to the L5S1 disc and the foraminal is feasible and safe. The transiliac approach allows the entering into the disc in the line of the inclination, and the only disadvantage is the drilling of the iliac bone, which may lead to the increased blood loss, pain, and the discomfort to the patient intraoperatively. So, in India, Dr. Mahesha concluded he done 10 cases earlier, 10 patients in the L5S1 disc pathologies, and he would treat endoscopically transiliac surgeries under local anesthesia in 2015 to 2016, and he concluded that the endoscopic transiliac approach is safe and effective in lumbosacral disc pathologies. Transiliac approaches removes the limitations of the transforaminal approaches for the L5S1 disc spaces. There was no radiological classification and approach and the guidelines for the pre-operative assessment of the patient for decision making in the L5S1 for the transforaminal endoscopic discectomies. So Dr. Prasad and et al. In 2019, under guidance of Dr. Girish Datta sir, presented a study aims to viable a new radiographic-based surgical classification and approach guidelines for the selection of the patient for the suprailiac or iliac transforaminal approaches for the L5S1 level. So in his study, he taken the images in the anterior post AP images and lateral images and few landmarks like the below the lower border of the spinous process, pedicle, and the anterior posterior suprailiac spine, and he divided and classified into the three categories of the patient with L5S1 radiology. According to these landmarks, he classified into type 1, type 2, and type 3 type of high iliac cases. And according to these cases in anterior AP and lateral diameters, he decided you can pre-assess the patient pre-operatively for going for the suprailiac or transiliac approaches. So And another, Dr. Choi analyzed his studies ascribed the relation of the iliac crest for the L5S1 disc space. In cases where the iliac crest is above the mid of the L5 pedicle in lateral radiograph, the foraminoplasty may be considered for the suprailiac transforaminal access for the L5S1 disc herniations. The transiliac approach provides a technically easy inline access to the L5S1 disc space directly targeting to the pain generator at the expense of the drilling of the iliac bone and bleeding, restricted bone maneuverability at the rigid endoscope through the transiliac window, pain and discomfort patient to the post-operatively. These access problems may limit the ability to carry out an adequate decompression of the disc. Later, the interlaminar approach came into the scene, and the interlaminar approach can much useful than a transiliac approach in L5S1 disc pathologies because of the larger interlaminar window at L5S1 level, which is generally around 31 mm on average, and the little overhang of the upper lamina makes interlaminar approach possible and relatively easy. And this has the higher risk of neural injury because the neural structures are encountered before the removal of the disc, and post-operative dysesthesia because it requires a manipulation of the traversing nerve root. The interlaminar approach can escape the blockade of the iliac crest and after several advantages like faster puncture orientations, shorter operative times, and less intraoperative radiation exposures. The interlaminar approach is preferred in types of the axillary type of herniations, high migrated days, central herniation or subarticular herniations, sequestrated dorsally migrated herniations, and concomitant multi-level bilateral lumbal calcaneal stenosis, fixed pelvic obliquity, and previous ilium deformities. So, supra versus and trans iliac approach. Suprailiac transforaminal approach is generally indicated for the foraminal or extraforaminal disc herniation at L5S1 level and for the foraminal stenosis cases. And transiliac transforaminal approach can be considered in patients with the unilateral symptoms and having foraminal herniation, stenosis, or paracentral herniations. This was a case you can see then this is a 36-year-old male with right side S1 radiculopathy for 4 weeks, no back pain and high iliac crest type 3. You can see the iliac crest is reaching up to the level of the lower end plate of the L4 vertebra. In these patients, I was planning for the transforaminal approach, but because of the high iliac crest, we chosen to go for this transiliac approach. In this transiliac approach, we make a transiliac window by using a sequential remus from 2 mm to 10 mm, and rest of the procedure is the same as we do in transforaminal endoscopic discectomies. And this is the second case with a 27-year-old female with back pain, right radiculopathy, and more than left for the 6 weeks, high iliac crest. Here you can see it is a type 3 high iliac crest, and in this patient pre-operatively we can go for any approach other than suprailiac transforaminal approach. And here in this patients we did interlaminar endoscopic discectomy. You can see the fragment was just over the shoulder. We removed that fragment from the shoulder, and easily this procedure was concluded in 30 minutes. And the incision was the same as 8 to 9 mm in transforaminal surgeries. And this is another case, 36-year-old female, back pain 12 months, right leg pain for 3 months, acute exacerbation of the symptoms for the 1 week, and she hasn't relieved from the conservative treatment. In this patient also, the high iliac crest is so high, reaching up to the L4 vertebral body. Here, the choice of technique, again, we chosen for the interlaminar instead of transforaminal, going for the transforaminal. You can see we cleared the shoulder of the nerve and taken out the ligamentum flavum laterally to just express the fragment. We've taken out the fragment, and the dura and the traversing nerve root was well decompressed, and the patient was discharged, walking after 3 hours of this procedure. So by the time the interlaminar get more popular, then the indications for the transiliac approach is very less. So incision, the same 9 mm incision, and the whole fragment was removed. So in conclusion, all approaches has their pros and cons. Always do pre-operative assessment prior to the selection of the technique. Choice of the techniques depends on your experience, feasibility, post-operative management. I prefer interlaminar L5S1 cases because of the easy access and advanced optics. Transiliac transforamen is kept reserved for the foraminar or extraforaminal pathologies in unilateral sensory blockade. And suprailiac transforaminal is kept for the foraminal stenosis and type 2 level of iliac crest cases. And this is the last conference we concluded in Dehradun, India, under leadership of Dr. Kangtok Lim. It was our 16th conference. We are in teaching and training of endoscopic surgeries in India for last 12 years. And my teacher, Dr. Girish Datta, Dr. Lim, always we have big support to training endoscopic surgeries in India. And this is message from my friend, Dr. Varun Agarwal. He is organizing one conference in India in July on Casmiss fusion training course. It's a 2 or 3 days course. You can scan the QR if you're interested. You can join in us in India. Thank you so much.
Thank you, Dr. Lavkush Pandey. Do we have any questions, suggestions, contributions?
My focus was to tell you about the transiliac approach because you should always remember your history. When transforaminal was very popular and we were not getting access into the L5S1 because of the high iliac crest, then this in 2014-15, then Dr. Girish and sir and many people just taught us this technique. We did few cases, but that time we should know the techniques which earlier evolved to this level of surgeries. Now we are doing, great speakers were earlier speaking about the endoscopic surgeries. Thank you so much.
Any questions? I have one question.
Yes, sir.
What is your criteria to decide on transiliac or translaminar or interlaminar?
For last 2 years, I haven't done any transiliac cases.
Okay, thank you.
Because once I met Dr. Lim, sir, in 2019, my whole perspective changed to interlaminar uniportal surgeries.
Yeah.
So I keep all instruments still ready. Whenever I do go for a surgery, I do perform all 4 kind of surgeries, a UB and transforaminal, uniportal, moniportal, but I do generally most of the cases interlaminar only. But I have instruments, get ready whenever I get chance, if patient is ready, because the only thing I found it is a very painful procedure. My first procedure was the army man, so he managed bear that pain when I was just reaming after giving so much of local anesthetic agent. So avoiding the complications and of those local anesthetic agent, the army man was the main fellow who just boosted my confidence, so I can do in transiliac case. So now I don't prefer to do transiliac surgeries. Thank you so much. Yes, sir.
Yes, Dr. Pompovit. Mike? Okay.
To complete your lecture, I would like to ask all of you to consider the area, the location of the disherniation.
Yes.
If the disherniation in the posterolateral or in the central area, the approach will be different.
Yes.
The first thing. The second thing is the calcification of the disc or not. If you want to remove the calcification, you think about how can you remove it. So the approach will be different. So
yes.
Yeah. Idea well taken.
Yes, sir.
Thanks a lot, Dr. Pandey.
Thank you.
Yes, I would like to invite next speaker, Dr. Ali Azamov. Yeah, he will talk about the neuromonitoring in endoscopic spine surgery, enhancing safety and precision. In my opinion, it is a very important issue in endoscopic surgery now, neuromonitorization. Yes, doctor.
Hi, everyone. Thank you very much for inviting Dr. Shah Mansour. Thank you. It's a great honor to be here and talk. My name is Ali Azamov. I'm from Uzbekistan, born in 1974, complete medical school here in Uzbekistan, and moved in 97 to United States. And since then, I've been staying in the United States. When I was young and stupid, I called. Okay, now I was trained as a neurosurgeon in Uzbekistan, and in the United States I do neuromonitoring, and I also do first assist. I scrub into the cases too. First thing, I'd like to ask crowd, how many of you know about neuromonitoring or neuromonitoring technique, and how many of you using, except United States doctors, of course. In United States, it's normal standard of practice, and we use neuromonitoring technique in all spine cases, brain cases, and functional neurosurgeries, and in cases with complex brain tumors, spinal cord tumors, etc. So intramonitoring technique, neurophysiology, very important and crucial in endoscopic spine because it's very limited space, very small approach, and it can be super dangerous outcome to the patient. Why it's important, as I mentioned, because it's a limited approach, and we have very dense area with the nerves, and it might cause a very crucial outcome afterwards. Okay, so advantages of neuromonitoring during endoscopic spine procedures. We call that lumbar endoscopic spine surgery in the United States. And I work closely with Dr. Chol Kim, if you know him. He is the inventor of minimally invasive surgery in the United States. And he's also instrument creator for a company called Globus. Before it's called Globus, now, NuVasive, now it's called Globus. So we work with him closely, and now he's moving from open surgeries to all his surgeries. 85% of his surgical cases is endoscopic spine. So common indication for endoscopic spine surgeries is herniated discs, spinal stenosis, and foraminal decompressions. Okay, so an evolution of minimally invasive versus open and endoscopic. You can see that on the slides. So old technique was open surgery, then we transferred to minimally invasive when we're using tubular system. Some of the colleagues using tubular system, it's called now bipolar, right? Not unipolar, still using tubular system. And then we call pure endoscopic in United States, where is uniportal. It's only one hole. Okay, so for endoscopic spine surgeries, what is the main advantages? So it's a minimally invasive approach, reducing muscle and soft tissue disruption, faster recovery, and lower postoperative pain. As common indication, as I mentioned, is herniated disc, spinal stenosis, facet cyst, foraminal decompressions. Risk and complications associated with endoscopic technique is first one is the nerve damage. So primary goals is prevent nerve and spinal cord injuries, provide real-time feedback to the surgeon because surgeons cannot see what's going on deep in the tissue, improve surgical precision. Common modalities used in endoscopic spine as far as the neuromonitoring is somatosensory evoked potentials, motor evoked potentials, EMG, and NMT. NMT is train of 4. We constantly checking on muscle relaxant level. I know some of the surgeons here, they use local anesthesia. In the United States, the standard of practice is general anesthesia for all surgical cases. Therefore, we use neuromonitoring for all spine cases in the United States. It's mandatory. So challenges in endoscopic surgeries. As I mentioned that, limited access and visualization, continue patient's movement if patient is not fully anesthetized, electromagnetic interference from equipment in operating room, and need for precise electrode placement, which is crucial. It depends on the level we're going to be operating and depends on the approach we have to discuss with the surgeon prior to the case. So optimal neuromonitoring setup for endoscopic surgeries is first is electrode placement strategy, and then anesthesia regimen. We call this 3 major pillars, and then real-time monitoring adjustment. And then electrode placement is we have to see and determine that with the surgeon which level we're going to be operating on. And then after that, we have to discuss this with anesthesiologist, what kind of anesthesia preferred to use in certain cases. We ask anesthesiologists, which is crucial, to use succinylcholine to begin with for induction. And then we have to have all 4 twitches and train of 4 because we have to adequate assess the muscle movements during the penetration of the needles, during the chromatodiscogram, and during the decompression. So then clinical evidence and outcomes. We review all the studies supporting intraoperative neuromonitoring endoscopic spine surgeries, which cause the reduction in nerve injuries and improve functional outcomes. And we analyze all cases after surgeries, and in real-time assessment-wise, we provide surgeons with real-time feedback when surgeon decompressing the nerves, which muscle irritates. We call all the muscle activities as far as the spikes, bursts, train signals, size, and time. And then our machine is quantify all the EMG readings and provide afterwards, after each case, we provide technical report and provide to the surgeon, which goes to the patient's chart. And based on that, neurologists assess the positive outcome of neuromonitoring being used during the endoscopic spine surgery. So this is the usual setup. So we have, as I mentioned, upper 4 columns is all SSCPs. It's upper SSCPs, right and left, but lower SSCPs, right and left. And in this particular case, you can see patient had a problem with the right L4. The case was right L4 5 endoscopic discectomy. So you can see on the right posterior tibial nerve SSCP very low in amplitude in comparison to the left side, which is clinical evidence, intraoperative evidence of the real deficit of the patient, that it's real, confirmed electrophysiologically. So this is the motor evoked potential, same case, same patient, and you can see the comparison between left side. We got the response from left vastus medialis lateralis, tibialis anterior, and adductor hallucis muscles. Right side you can see is wide open and with good amplitude, with good outcome and as far as the compound muscle action potential. In comparison to the left side, super low in amplitude. So future of neuromonitoring in endoscopic spine surgeries, advancement in intraoperative neuromonitoring technology, AI-assisted monitoring, wireless systems that we're working on, and integration with robotic and augmented reality. We're working with AI-assisted neuromonitoring as far as once we place all data of the patients into AI system trying to give us more or less adequate outcome. We provide that outcome with the patient where can be used as a useful tool, and patients see real intraoperative advancement of post-surgical outcome to the patient. In conclusion, I'd say neuromonitoring is very crucial. It needs to be used in, as long as in the United States it's used in every single surgical cases, spinal cases, and brain tumor cases and stuff like that. It needs to be used, I think it needs to be used in endoscopic cases as well. Yes, it's very crucial communication between surgeons and neurophysiologists and anesthesiologists in order to provide a good outcome and have a good neurophysiological signals throughout the case. So as I mentioned, collaboration between neuromonitoring specialists, surgeons is a key. Anesthesiologist is the key person too, because he needs to provide with adequate anesthesia. And in the future, it should bring way more advantages for patient outcome, post-operational outcome to the patient well-being. And thank you very much. Questions? And this is Dr. Shamansur, Dr. Bakhtior. This is Dr. Chol Kim, if you don't know him, and myself. At university, picture was taken in University San Diego, California Medical Center, East Campus in 2023, right?
Of neuromonitorization, very clear and very simple. Thank you very much, because in my opinion, it must be mandatory. And yeah,
for sure.
Yes, for sure. And is there any contribution and or question? Yes, doctor, please. I think that you have big experience also with neuromonitorization.
Yes, I do
please.
neuromonitoring in all my cases.
Okay.
So I have quite significant experience. So talking about the SSEPs, you did not mention, is the criteria 20% decrease in amplitude and latency? And is the amplitude more significant or the latency? What do you look at?
Well, we're looking for amplitude on acute cases. We're looking for amplitude and latency too. So our criteria is 30% decrease in latency, we called as a true respond, okay, and 50% decrease in amplitude and motor. Yeah, latency is crucial too, but not so much. We mostly concentrating on amplitude decrease.
So my experience has been that this is a sudden event. You may be doing a case and suddenly the SSEPs drop. And when that happens, what do you do? And the second question is, how do you eliminate the hypothermia and the hypotension? Those are potential, confusions.
Right.
So, I mean, that's one of the things, but then you're having a change in the SSEPs, and you're also having a change in the temperature or the blood pressure. How do you kind of...
That's why, as I mentioned, it's very crucial to have a strong direct communication with anesthesiologists, because hypertension is controlled by anesthesiologists, temperature controlled by anesthesiologists as well. So my personal experience, when it's a sudden decrease in temperature, you see increase in latency. not much decrease in amplitude, but increase in latency on your SSCP waveforms. And on motors too. Motor amplitude stays the same, but latency increases.
One quick follow-up. I don't normally do the motor. I just do the SSCPs and the EMGs.
For your endoscopic?
Yes.
Yeah. Yes. Well, in our university setup, we have to do motors because we have good positive outcomes statistically when right after decompression, motor compound muscle action potential increased on amplitude.
You know, I am from a very poor country, so we don't have this for this herniation. But I have some guys in Abu Dhabi to do discectomy. So when they put the nerve retractor, the potential are changing.
No, it should be changing.
So what you are doing to stop? You change technique?
Well, once we see the change in neuromonitoring, we ask surgeon to maybe reposition retractor sometimes. When muscle irritates a lot, when we see a lot of irritation on EMG side, we ask surgeon to do a lot of irrigation. Yeah, once they irrigate, the nerve activities comes a little bit down. And then EMG activities, which become more smoother.
So you change your technique with the...
Yeah, we change the technique while he is putting instrumentation. We change the approach. We ask surgeon, please, you have to do this, or you have to reposition your retractor, or you have to irrigate a little bit more, or you have to pay attention, or you're touching the nerve here, because he's not seeing. We seeing that. That's why it's very crucial when you introduce yourself to the patient. Usually we come and introduce ourselves to the patient before surgery when they sign the consent form. I don't know, in the United States, every single provider should sign the consent form. That patient should be aware of this provider will provide certain services. And when we introduce ourselves, we say, okay, we are a navigation system for the surgeon. Eye of the surgeon deep in the tissue, because surgeons can see on the scope or under endoscope, they just can see stuff. They cannot see what's going on in the tissue. We the one who can tell them, you going too harsh, or you close to the nerve root, or you're irritating, or you're compressing the vessel. You agree with that, right?
I have one last follow-up.
Sure.
So one of my cases, I had a decrease in the SCCPs following use of the drill. And it disappeared when the drill was stopped. How much do you think...
It came back, you mean? Yeah.
How much do you think the thermal effect of doing drilling has on neuromonitoring?
Well, thermal effect, we call this direct thermal effect versus indirect thermal effect, which change the temperature, the body temperature, right? This is I saw the cases, I observed the cases where surgeons was drilling and the SSCP dropped, right? When we say, okay, it was too much of a heat causing the nerve, might cause potential nerve damage, then surgeons start irrigate, then SSCPs comes back. Usually SSCPs is a seconds, that's super fast to occur and super fast to come back. When we see the changes in SSCPs, sudden drop, which if surgeons never listen to us, sometimes it happens. Sometimes surgeons said, oh, I'm not even there, or I don't do anything. Yes, sure, you don't do anything, but SSCP drops suddenly, right? When it was like all normal and like textbook. So if surgeons communicate with us, when surgeons stop drilling, we ask them to irrigate. Irrigate sometimes with the warmer saline versus the cold. You guys use cold, right, during your endoscopic. Yeah, we ask to irrigate with the warm saline. When we irrigate with the warm saline, the SCCP tends to come back to the normal, to the baseline, I would say.
Thank you, doctor. We understand that the new dedicated only neuromonitorization workshop is necessary. Thank you very much.
Thank you very much.
Yes. May I call upon the dais Dr. Dahir Abukov, who's going to speak on monoportal or biportal endoscopic technique for spinal stenosis. Controversial, right?
Hello everyone, happy to be here with all of you today in Hospitality Tashkent. My today's topic about comparison of biportal and monoportal technique in cases of lumbar stenosis. Добрый день, друзья. Учитывая, что большинство здесь говорят по-русски, я, наверное, свой доклад продолжу на русском языке. В ежедневной своей практике я использую обе техники, монопортальную, бипортальную. Начинал с монопортальной и до сих пор ее активно использую, и я думаю, что я и дальше буду использовать. Но бипортальная техника тоже занимает немалое место в клинической практике. Какие характеристики для нас важны, когда мы выбираем эндоскопическую методику для декомпрессии? Во-первых, это самое главное, насколько мы адекватно выполним декомпрессию невральных структур. Вот такое понятие, как разница между площадью поперечного сечения дурального мешка до и после операции, показывает нам, насколько мы выполнили адекватно декомпрессию. И еще немаловажно, насколько мы агрессивно выполняли костную резекцию. То есть угол фасцитектомии ипсилатеральный, контралатеральный показывает нам, насколько мы были агрессивны с костными структурами. И степень повреждения мышц. Вот эти три характеристики являются для нас самыми важными, когда мы что-то сравниваем. Монопортальную, бипортальную технику, неважно. И уровень КФК в крови до и на второй день после операции показывает нам, насколько мы были агрессивны с мышцами. Перейдем сразу к декомпрессии. При монопортальной технике, когда мы выполняем декомпрессию, у нас эндоскоп достаточно большой, и при резекции верхней дуги вышеляжащего позвонка, мы должны костную резекцию выполнить до того момента, пока мы не достигнем места прикрепления желтой связки. При бипортальной технике задача та же, но при этом мы можем выполнить такую резекцию таким образом, чтобы больше сохранить дорсальную часть, то есть дуги, и больше резецировать вентральную часть. При резекции медиальной фасетки, при монопортальной мы резецируем слой за слоем, потому что, чтобы иметь возможность хорошей визуализации. Сначала резецируем верхний слой, потом визуализируем глубокие слои, резецируем глубокие слои, и так слой за слоем, пока не увидим медиальную часть верхнего суставного отростка. При бипортальной хирургии мы можем остеотомом, учитывая, что у нас эндоскоп отдельно, рабочий инструмент отдельно, мы можем резецировать медиальную, такой небольшой участок нижнего суставного отростка, гипертрофированную часть, таким образом, чтобы у нас больше сохранить дорсальную часть, то есть вот наружную часть сустава, и больше резецировать вентральную часть. Таким образом, минимизируя костную резекцию. При резекции контралатеральной стороны нам нужно больше резецировать верхний суставной отросток, чтобы создать для себя пространство, чтобы мы могли эндоскоп диаметром с тубусом где-то 11 мм безопасно разместить в противоположной стороне и спокойно выполнить резекцию контралатеральную. При бипортальной технике у меня есть возможность отслоить желтую связку и минимально там резецировать глубокую медиальную часть нижнего суставного отростка с противоположной стороны. И создать для себя достаточное пространство, которое будет, пространство будет достаточно для выполнения декомпрессии контралатеральной стороны.
Ну, вот, резекция нижнего суставного, как можете видеть, выполнена достаточно, и можно безопасно выполнить резекцию верхнего суставного отростка. При бипортальной технике то же самое я делаю, но при этом стараюсь выполнять блок-резекцию желтой связки, максимально сохраняя контралатеральный сустав. По поводу основной вопрос, который возникает всегда, бипортально это 2 прокола, монопортально 1 прокол. При этом основной аргумент то, что при бипортальной большое повреждение мышц. Я не использую никакие распаторы, я использую дилататор из монопортальной системы 7-мм фораминоскопа, который у меня есть. И только касаясь нижней грани верхней дуги из обоих портов, выполняя 2 маленьких прокола, 2 скальпелями, один который побольше, другой поменьше. Никаких распаторов, ничего не использую. И такой подход позволяет минимизировать повреждение мышц, насколько это возможно. Вот смотрите, вот монопортальная техника, мышцы закрываются. Та же самая операция бипортально, вот дефект в фиброзном кольце. И смотрите, как мышцы таким же образом закрываются. То есть минимизация риска повреждения мышц. По поводу разреза кожи. Вот один пациент, я очень люблю эту картинку, потому что мне пришлось у одного пациента выполнить 2 разными методиками. Вот 4-5 выполнено бипортально, 3-4, 2-3 монопортально. Конечно, можно было монопортально сделать из одного разреза, но кожный разрез для нас большого значения, честно говоря, не имеет. Основное это насколько агрессивно мы работаем с мышцами. Провели исследование, сравнили монопортальную, бипортальную технику. Получилось так, что не получили разницы лучевых данных, которые были бы существенными, и не получили, то есть угол фасцитектомии был более острый в бипортальном кейсах, но это не имело никакого значения, потому что это не приводило к повышению риска нестабильности при монопортальной. Площадь поперечной части дурального мешка был немножко больше в бипортальной группе, но это тоже не имело никакого клинического значения. Результаты послеоперационные клинические были примерно одинаковые. Если нет разницы, как говорится, зачем платить больше? То есть, ну, не знаю, у нас монопортальная обходится намного дороже, чем бипортальная, а клинические результаты примерно одинаковые. Так, когда моно, когда би? Естественно, любую патологию, будь то это ревизионная хирургия, кейдж, все остальное можно сделать как монопортально, так и бипортально. Все зависит от опыта хирурга, от желания и ресурсов. Обычно мы ограничены только в ресурсах. Желание, опыт у нас, как правило, у всех бывает достаточный. Поэтому бипортально. При тяжелых стенозах, когда предполагается много костной работы, выполняем бипортально, в поясничном отделе. Многоуровневых тяжелых стенозов бипортально. Ревизионная хирургия бипортально. Фьюжн тоже бипортально. А вот шейный грудной отдел, я имею опыт бипортальный, но люблю делать монопортально, потому что монопортально больше подходит, особенно для шейного отдела, потому что там много коротких важных мышц в шейном отделе. И установить один 7-миллиметровый тубус и выполнить всю операцию мне представляется более, так скажем, целесообразным. И практически все случаи грыж межпозвонковых дисков выполняются монопортально, трансфораминально или интерламинально. Пара клинических примеров. Грубый стеноз, учитывая, что очень много костной работы, поясничный отдел выполнено бипортально. Достигнута достаточная овертоп декомпрессия. Вот, своя сторона, противоположная сторона. Вот такой туннель сделали костную. Особенно полезна бипортальная техника, когда мы имеем дело с адгезией, когда дуральный мешок плотно подпаян к связке. Есть возможность установить эндоскоп между связкой и дуральным мешком и аккуратненько выполнить диссекцию под контролем глаза, потому что, учитывая, что у нас две руки, два порта, два инструмента, можно выполнить блок-резекцию, причем безопасно под контролем глаза. Вот видите, четко видно место спайки, видно, что более-менее легко отходит, поэтому до конца удаляем. Блок-резекция связки. Для фьюжена тоже использую бипортальный, потому что 4 разреза, 4 винта, 1 кейдж. При монопортальной 5 разрезов, 4 винта, 1 кейдж. Вот. А особенно бипортальная хороша при ревизионных хирургии. Это пациент, который дважды пытались прооперировать, но с, так скажем, не очень достаточным клиническим результатом. 2 раза оперировали, после 2-го раза нарушение тазовой функции. Увидели вот такой дефект и, используя клипсы, сосудистые заклипировали. Закрыли дефект без конверсии, без необходимости ушивания, с хорошим клиническим результатом. Если 2 несмежных сегмента, если, например, как здесь, лучше 2 разреза, чем 4, потому что если были бы это смежный сегмент, можно было сделать 3 разреза для 2 уровней. Это монопортальная декомпрессия, овертоп, уровень 2.3 и 5.1. Для грудного отдела я предпочитаю монопортальную технику. Вот пациент со сколиозом и с компрессией спинного мозга, фиксированный сколиоз, пожилой пациент с нарушением функции нижних конечностей. Выполнена овертоп декомпрессия, монопортальная, билатеральная. Вот МРТ до, после операции контроль. При этом мы делали декомпрессию на уровне 4-5 и на грудном отделе. Для шейного отдела при стенозах, я думаю, что самый лучший оптимальный вариант это...
Your time is up.
Окей. Последнее. Неважно, какую технику используем, не так важен метод, как исполнение. Любую технику можно улучшить хорошим исполнением и, наоборот, опорочить плохим исполнением. Спасибо за внимание.
Any questions? So if there are none, we'll jump on to the next talk. We are running late. Yes.
Thank you, Doctor. Next speaker is Dr. Hasan Kamil Sucu. He will tell us why does he need outside-in technique for transforaminal surgery. By the way, I want to announce that Dr. Sucu in Turkey initiated first resident training program for endoscopic surgery in his clinic. Yes, doctor.
I must attach my computer.
What is the problem? Connection?
Connection. Okay. Hello, everyone. I will tell you about my journey of switching from the inside out to outside in technique in transforaminal endoscopic discectomy. I have no financial interest or relationships to disclose. This is my hospital in Izmir. After I decided to learn transforaminal endoscopic discectomy, one of the most challenging issues for me was what the terms inside out and outside in meant. Now I know. Talking about the left L4, L5 discectomy, let's draw a line connecting the posterior corners of the L4 and L5 vertebral bodies on the lateral image. Our guide wire will reach this line in both the inside-out and outside-in techniques. The question is, where will it be in the AP image at that moment? While the guide wire is on medial pedicular line in the inside-out dissect technique, it will be on the midline in the outside-in technique. In the inside-out technique, although the needle usually touches the bone first, it is then slit from the bone, brought into contact with the disc, and inserted into the disc. In the outside-in technique, the needle makes contact with the L5 superior articular process and never enters the disc. We initially applied the inside-out technique with general anesthesia. Then we switched to sedation-supported local anesthesia. We continued with local anesthesia even when we switched from the inside-out to outside-in technique. The positioning in both technique was quite simple and comfortable for the patient. The patient is laid down the operating table in a prone position, just like as in her home, lying down to his bed. Nothing special. We simply place a silicone pad under the ankles. The patient is constantly awake. The voice of the video. We are talking with the patient during the procedure, during the operation. It's supposed to be voice. I asked them, but there is no. Okay. In the inside-out transforaminal discectomy, we draw the line passing through the disc level in the AP view, the line passing through the tips of the spinous processes in the lateral view, and made the final modifications of our entry point according to iliac crest. After spinal needle, guide wire, and dilators, the working cannula is placed under the superior articular process. We advance its tip slightly beyond the medial pedicle line. After the AP image, the lateral image is obtained and the half and half position is confirmed. Half of the tip of the working cannula is inside the disc, and the other half is outside the disc, within the epidural space. We were happy with the inside-out technique, at least at the beginning. It was very simple technique, and we were getting results. So why did we switch from inside-out to outside-in? Because there were limitations. It was almost impossible to operate on L5-S1 disc herniations and caudally far migrated disc herniations. There were also serious difficulties in midline disc herniations. Therefore, we started to outside-in technique, which has the potential to overcome all these difficulties. How do I do? First, I mark the midline. Fluoroscopy is not needed at this stage. In the outside-in technique, just like in the inside-out technique, we need two lines drawn under fluoroscopic control. On a true AP view, first line should connect the tip of the superior articular process to the midpoint of the superior end plate. Second line should connect the tip of the superior articular process and the posterior superior corner of the corpus in the lateral view. Our entry point is the intersection of these two lines. During the surgery, we first touch the tip of the superior articular process with a spinal needle, Then I remove the inner needle and inject Marcaine into the periosteum. Then we pass the guide wire through the spinal needle. When the guide wire touches the bone, we remove the outer cannula of the spinal needle. We first pass a thin dilator, then a thick dilator over the guide wire, and perform a necessary dilatation. After removing the thin and thick dilators, we pass the outer cannula of the Tomshidi needle over the guide wire. When the Tomshidi needle touches the superior articular process, we remove the guide wire. We attach the pointed Tomshidi internal needle. We start to drive the Tomshidi needle into the bone by hammering it. After reaching the medial aspect of the L5 pedicle with the pointed Tomshidi needle, we replace the inner pointed needle with the blunt-tipped needle and advance towards the midline in the AP view. At this very moment, in the lateral view, Tomshidi needle should be at the posterior superior corner of the vertebral body. We remove the Tomshidi inner needle and send the guide wire. Then we remove the Tomshidi outer cannula and send the hand drills over the guide wire up to the midline. We turn the drill counterclockwise until the tip touches the bone to prevent damage to the muscles. After feeling the bone, I turn the drill clockwise. Starting with a 4 mm drill, I continue with the 6, 7, 8 mm drills. I should be at the posterior superior corner of the vertebral body in the lateral view when I reach the midline in the AP view. With each and every drill, ideally. I use the 9 mm drill last. I remove the 9 mm drill and send the thin dilator, thick dilator, and working cannula over the guide wire, respectively. After the dilators and guide wire are removed, only the working cannula remains. Long story short, what is the main difference between inside out and outside in? In inside out, you stand at the threshold of the door and look into the room. You don't step through the door. In outside in, you enter the room. Here the room is spinal canal, and the door is medial edge of the pedicle. Inside out, outside in, you work very close to the nerve tissues. You have to be much more careful. These are my outside-in cases. I haven't performed any surgery with the inside-out technique after December 18, 2024. I have a total of 21 outside-in cases. The second case is my resident. He is still alive and doing well after surgery. The 13th case is the only patient in this series who did not benefit. He had both stenosis and midline disc herniation at the L4, L5 level. I told him that he had two pathologies at the same level. We could operate on one of these pathologies with local anesthesia, but he might not be benefit. The patient who had myasthenia gravis and many other additional comorbidities didn't want to have surgery under general anesthesia. We performed transforaminal discectomy. However, the patient did not benefit. He still has back and right leg pain. We have planned open surgery under general anesthesia. However, due to his medical additional comorbidities, anesthesiologists do not currently allow him to have surgery under general anesthesia. Another point I want to emphasize, 6 of the 21 cases were lumbosacral junction disc herniations, and 5 of the last 10 cases were L5-S1 disc herniations. 5 of the last 10. I have never failed any L5-S1 disc herniation surgery. This is the best summary of why I switched from the inside out to outside in. Last but not least, I would like to say that we will be happy to see each of you in Izmir. Thank you.
Thank you, Dr. Sujo. Is there any contribution? Yeah, please. Question or contribution? Question. Yes. Of course.
Thank you very much for nice presentation. Don't you feel medial pedicular line as a red line when you control in frontal view?
Red line?
For bone resection.
Don't you afraid to go much medial?
This is the mean of outside-in technique. If you are doing inside-out technique, you have to go to medial pedicular line and you have to put the needle just in the medial pedicular line. But this is outside-in technique. This is not inside-out technique. So, in this technique, first, you are going to superior articular process, actually not superior articular process. I don't like the term of facetectomy or superior articular process removing. You only drill the ventrolateral portion to get a way yourself. And yes, true, you are passing through the medial pedicular line, you have to, because this is outside-in technique.
Thank you
it's
very
different.
much. I see. Thank you.
In your cases, in L5-S1, the retractor and endoscope is advanced into the midline. Endoscope and the retractor was working tube was introduced up to the midline of the patient. Always I am trying to go to the midline, but sometimes L5-S1 disc herniations, when the iliac crest is too high, I couldn't go up to the midline, but the my aim. No, my question was not that. Yeah, like if the pathology is in the paracentral or midline, and not in foramen, do you think that is there any advantages over the midline approach, like interlaminar approach? If the pathology is in the foramen, you can stop in the foramen. If the pathology is mediolateral, not midline, you can go to the mediolateral part of the canal. But there is a potential of this technique to go to midline. You can go to midline. Also, there were some mediolateral disc herniations. In these cases, I went to mediolateral part of the canal, but beyond the medial pedicular line, inside of the canal. So, in that case, if the pathology is not in the foramen, and main pathology is in the paracentral and midline, still do you prefer transforaminal approach rather than the interlaminar approach? Of course, this is foraminal, transforaminal approach, but you are not going to foramen itself. You are going to the canal, spinal canal. You are passing through the foramen. You are not going to foramen. Foramen is your way, is your not stop, but it's an anatomical structure during your passing the canal. But it's not your final destination, foramen. The final destination is in the canal midline.
I have a quick question. I've done a lot of the L5-S1 transforaminals, and specifically if they have grade 1 spondy, actually you improve the foraminal size when you're cutting part of the superior part of the vertebral body like you were showing. Do you have any experience with dealing with grade 1 or grade 2 spondy with the transforaminal outside-in approach?
I'm not sure to understand. Okay.
Grade 1 spondylolisthesis when there's
In
a little
grade
grade 1.
spondylolisthesis cases.
Yes, it helps or not when you do the drilling and opening of the
I
foramen.
didn't have a case about with the spondylolisthesis. I have performed only 21 cases, and these are these years cases. But if there is no instability, it's quite possible to perform this technique in grade 1 spondylolisthesis cases.
Thank you, doctor. But I have a little bit contribution. First of all, you have misunderstanding half and half technique, which defined first time in 2007 for migrated herniations by a Voridol group, doesn't mean that the tip of the cannula half inside and half outside.
Half
it means
inside
that,
of the
just
disc,
a moment.
half
It means that your view upper half is epidural cavity and lower half is disc space. The penetration rate is depend to your angle. If you give a horizontal angle, no penetration. If you are introducing as a right angle, you will have the more penetration. Another one is you are saying that we are looking inside the room, but don't forget, after breaking down the walls.
After breaking?
Breaking down the walls, you are looking inside the room. For example, I have approximately 3,000 inside out, not inside out, half and half technique, but rarely I need to drill the superior articular process. If it is necessary, you can do it under endoscopic vision. Why you are doing under X-ray image? And also for L5S1, you are right, you can prefer the interlaminar approach. It is so simple.
Interlaminar approach and transforaminal approach is quite different. I am a strong believer of transforaminal approach because you are going to lateral way, and you are seeing the dura and the nerve root from lateral side, from lateral view. It's completely different mentality. And also think about it, recurrence cases. When you apply the interlaminar approach, you are passing through the fibrosus tissue. But if you are doing transforaminal approach, you are completely free and virgin space. It's quite easier than interlaminar approach in these cases. But of course, it must be in your spectrum. By the way, I want to thank Dr. Hikmetulu. He is the one who teach me inside out, also half and half technique in the beginning. And I want to thank Marius Schmigel. He is not here. He is the one who taught me outside in technique from Poland. I want to thank these two mentors of mine.
Can I bring you the dinner for inside out again? Thank you, doctor.
The inside out and the outside in philosophies are completely different. We should not mix. The pathology for outside in technique, larger is the pathology. I mean, larger is the herniation in the spinal canal, easier it is to perform outside in technique, or you can just do an outside out technique. Whereas for inside out, larger is the herniation in the spinal canal, difficult it will be to do it through the inside out technique. So both techniques have its advantages and disadvantages. So one needs to choose how he is trained in. If you think primary foraminotomy is required for a good access to the pathology, outside in is a better technique, faster technique. Well, you can also do it under vision. Not that you cannot do it under vision, but it's just faster, easier. So there are two different techniques. We should not compare apples and oranges. Yeah, thank you. Yeah. So thanks a lot. Dr. Arvind Kulkarni is not here because of some reasons. He's not able to come. So we close this session here, and you can all have lunch, and faster we come back.
Yeah, it's because we are having more participants. That's why all food is finished. Take a break, 15 minutes. After 15 minutes, will be ready coffee and some snacks. Okay. Just take a break. 15 minutes. After 15 minutes, we have to start the next session.
Dr. Sandip from India, perspective of monoportal T-leaf and hybrid multi-eport T-leaf. Please.
I think I need to do something.
Huh?
I will help you.
You want me to start? Okay.
Please, audience, please enter. We're going to start next session.
Good afternoon, everyone. Maybe I have given the post-lunch session. I will try to make it more comfortable for you. So, in monoportal fusion, there were hindrances why biportal was beneficial, because we were not able to face or place bigger cages, not able to do enough amount of fusion. But according to the new science, you don't need to put a larger cage, but just maintain the anterior lordosis is good enough. So this is just to show that we can put bigger cages, we can achieve good outcomes with just an extra incision, we can do good work. So today my topic is advancing lumbar fusion. So hybridizing interlaminar and transcambins approach for superior outcomes for fusion beds. So why hybrid technique in lumbar fusion? So you already are well versed about evolution from open T-leaf to P-leaf to minimally invasive approaches. Then utilizing the advantage of Cambin's triangle, which is the safest triangle in the spine, which can be accessed into the end plates with minimal soft tissue damage. So hybrid technique combines direct root visualization and decompression with lateral disc preparation, where you have a huge fusion beds. So what is the goal? Maximize fusion, minimize morbidity. So in usually most of the open T-leaves or even in a UB T-leaf, sometimes you need to resect more amount of muscle. So less resection of muscle and achieving the same amount of fusion with big larger cages is possible with this small hybrid approach. Because most of our spine surgeons know to do a transforaminal epidural, just putting a needle in the lateral disc after interlaminar decompression, you can achieve good amount of fusion beds. So first, understanding anatomy of O-leaf approach. So O-leaf is now again divided into two types. One is psoas sparing and one is below the psoas and one is above the psoas. So O-leaf is more of a lateral surgery. Sometimes the sympathetic plexus are involved. So now we talk about something called oblique lumbar fusion without psoas destruction. So this is the normal anatomy, you know. Playing. So this is the cross section of a spine. So you will be seeing sorry about the animation. We tried something by myself. So you can clearly see this is the disc base, this is the superior articular process, and this is the approach where the psoas muscle below we have the transcambins approach. So O-leaf approach is direct lateral decompression, but hybrid O-leaf approach is just not completely lateral but posterolateral. But the advantage is already the cage is directed in a direction, so you can just turn over the cage and place it more anteriorly. So after as a regular T-leaf, after knocking off the facet, IAP and the SAP, you are going to access the transcampins and interlaminar also. The problem with transcampins fusion is your chance of injuring the nerve root, exiting nerve root is more. But when you are combining with interlaminar approach, you can even push the exiting nerve root up and put a larger cage, and there is no problem with the nerve injury. So concept of hybrid interlaminar transcampins approach is first interlaminar window, direct root visualization and protection, then taking a Campins corridor, lateral disc space access for preparing faster end plates because there are no neural structures from there. You can use big raspers, big curettes, prepare the end plates within 2 minutes. Enables placement of large footprint cages which nobody has tried. So mostly people were using bullet cages in transcampins approach, but it doesn't maintain the anterior lordosis. So you need to push the cage more anteriorly, but because of the bulletty nature, it won't take the load on the spine. So it is more oval cages is more beneficial. Of course, after putting that, there is no reduced risk of nerve injury. So this is the key anatomical considerations you have. You know what is Campins triangle. This is the Campins triangle. After you knock off the facet, you're going to directly visualize the traversing nerve root, and the exiting nerve root, which is the safer place to play around. So where we can put very big, large amount of cages. So when to use any kind of spondylolisthesis more than grade 4, I don't do, but grade 1 to grade 2, grade 3 also we do it. Sometimes if the advantage of interlaminar approach, we can do bilateral facetectomy. So the amount of reduction is very good, well achieved. And once the cage goes in, automatically the amount of reduction is expected to will be coming in. So severe instability, active infection, severe facet arthropathy are not the real contraindications, but severe facet arthropathy, as we are already knocking off the facet with a chisel, so it is acceptable to do it also. So you know the position size is the same like the normal, maintaining the patient lordosis. So what are the operative steps? So minimal laminotomy are performed, then we visualize the traversing nerve root, remove the inferior articular process and the superior articular process, gentle retraction of the nerve root, then transcampins approach, identify the Campins triangle with just a needle. You will be seeing in the interlaminar window, and you can use the dilator, access lateral disc space via transforaminal route, then minimize the exiting nerve root retraction from visualizing from the interlaminar root. So this is what is the concept. So we have an interlaminar approach, we combine with the O-leaf tube. So it's just like O-leaf, but with interlaminar approach without injuring the neural structures and also giving good amount of decompression. So this is how we do it. So mixing just a small incision allows us to put a larger cage, and the direction of the cage can also be managed by just changing the position of the transcampins approach. You want to have more centrally placed cage, more transverse cage, you can take a lateral entry. If you feel you're going to injure, you can take a posterolateral entry and just turn the cage after you put it. This is one more approach, and this is one more approach. So what I do is it's kind of hybrid approach. So once it is not UBE, it is monoportal, but I just don't do triangulation. Then I just put a second port through the Campins tripod and put the cage. So you can do a decompression, discectomy, end plate preparation without destroying the end plates. Disc space distraction using shavers can be done. So placement of O-leaf type cages, wide anterior column coverage cages used. This will reduce the risk of substance risk, improve segmental lordosis, insert through expandable hybrid corridor. So this is the size normal cages which normally people use. This is the cage which I use. This is the O-leaf cage. That's also the XT-leaf cages. So this is the amount of anterior lordosis it takes care of. From almost pedicle to pedicle is the cage length. So we are going to place a huge cage with decompression with just an extra small incision, because we have only 4 incisions for the 4 screws from where we do the decompression, and 1 extra incision just for putting the cage. So direct visualization reduces the nerve retraction injuries. Use of retractors to prevent exiting nerve root injury is also monitoring. Nerve monitoring can be done. So less manipulation compared to traditional T-leaf, because it is a lateral entry. So you don't have manipulation of the neural structures. The final fixation is placement of percutaneous pedicle screws, rod incision under fluoroscopy, minimal muscle trauma, faster recovery. So this is the cage I have put with monoportal. This amount of, see, this is the, almost from pedicle to pedicle, you have a huge cage anteriorly placed, which is the XT-leaf cage. You can put two cages also. You can put a small, you can push it anteriorly and put a small posterior cage. So these are the size of cages which we use. So you can see that good amount of lordotic curvature is maintained, the foraminal length is improved, and the cage has been turned down enough. And in interlaminar approach, when you're trying to put a big cage, turning is a problem because you have a posterior entry, posterolateral entry. Here already the cage is turned and going inside, so turning is not a big job. Interlaminar, just use a chisel, you can turn it. So these are the amount of big cages we use. I also use double cages. You can see the cage transfers very well. These are the expandable cages with Jayon. So you can see the pedicle to pedicle olive cages very much visible. These are expandable cages again in the AP and lateral. So you can have a good fusion bed even with monoportal, which they say that it is not easily possible, but just adding up a small approach. There's a transcampus corridor, which is a more safer corridor where the chance of very less of injury to the neurostructures. So post-operative protocol, early mobilization of day one, dressing optional based on stability, routine follow-up X-ray at 3 months. So I just wanted to present this presentation because you can put a safer cage with just a small transforaminal approach with interlaminar access, with good decompression, even bilateral fasciectomy. You can achieve good reduction of grade 2 or grade 3 listes. Even the end plates are screwed up also. If there is no end place also, but we can easily take care because a disc needle is a small one, transforaminal needle. You can sequentially dilate it, use a disc rasper, open up the space, break the ALL. So the disc will listen what way you want to listen. So the average fusion with larger cages was around 90 to 95% 3 months follow-up. The VAS score improved by 4 to 5 points immediately. The ODA is very fast because we don't do muzzle resection much. It is just a small stab. So, and of course, when you're having a small muzzle trauma, the chance of infection is also less. So advantage, larger cages, better neural protection, faster recovery. Pitfalls, a small learning curve, and cost of expandable cages and olive cages are little costly in my country. But of course, things come costly, but if needed, yes, it can be done. So these are the new endoscopic fusion set which I have designed with Jayon. So endolive set. So these are all instruments go through the scope. So every instrument what we are using will be done under vision. So it's like you have dilators, you have funnels for putting the bone graft, you have multiple size cage, you have raspers, you have multiple stuff. So you can use this stuff to prepare the end plates, even transforaminally or interlaminarly. So you can use, I have done even putting transforaminal larger cage, interlaminar smaller cage. So I wanted a fusion bed of 95% like A-leaf, so I have done it. So these are the instruments going like. So the instruments are visible under your surgery. So it is not a blind surgery. So it is more safer. And this is the L retractor through which after you put the transcamin dilator, just glide the dilator, this sleeve over the dilator, and you can usually push down the big olive cages after good end plates. So these are the expandable cages which are there. These are the olive cages and expandable cages. They are 8 to 13. So 8 size cage goes up to 13. 13 size cage goes up to 18. So sometimes you get young patients who needs pars fracture, who needs fusion. The problem of substance because of smaller cages. So usage of expandable cages for me is only for the patients who are young and I feel the disc space is very big. So references, there are some people who have already done, but not like this. We are writing a paper on it, mixing up these two things. But still, there is only transcamin's fusion, facet sparing or facet partial fasciectomy reamer fusion. But here we knock off the facet, so this is a different reference. But these are the references I want to give you. Thank you. Any questions?
Any questions?
I want question from Boris. Ask me. Yeah, please. That's why I asked you. No, that's why I asked you.
I will help him to translate. Я буду тебе помогать, Борис, не переживай.
Ну, приятно взять микрофон от моего друга Максима, он является бипортальным хирургом, вот, и пропагандирует данный метод, но я на самом деле хочу сказать, что для каждого метода, да, есть свои показания, и то, что ты показываешь, это очень здорово и очень красивая такая хирургия. Я возьму на заметку, обещаю, что я вот приеду, вопроса нет как такового, мне все понятно, обещаю, что по возвращению в Москву повторю и сообщу тебе о своем результате. Спасибо тебе за красивый доклад.
So there is no question, no questions. It's a very nice presentation, very nice topic, and you need to go to India to see what you are doing.
Yeah.
And
I
to say
think there is a
Scott-
question from him. Yes, yes, please.
This is last question because of time. You spent lots of.
You know, OLIVE is amazing technique. We do endoscopic assisted, even navigated with computer navigated. But you know, the vascular complication is disaster.
Yeah.
So you can lose the patient within 1 minute,
Yeah.
especially if you injure the iliolumbar vein.
Yeah.
So my question is, do you do CT angio before?
No.
Do you have vascular surgeon as access surgeon, or you do everything yourself?
No. So this is not a true OLIF. True OLIF is a lateral surgery. Yes, you are right. Lateral surgery is very risk of vascular injuries, sympathetic plexus injuries possible. So this is a kind of a posterolateral OLIF. So we take the advantage of the facet orientation. We put the cage, olive cage, and then turn the cage in the olive direction once it is in the disc space.
So it's more like a TELIF through transcamping
Yeah,
approach.
and then turn it. So we achieve the similar outcomes of olive, but we turn the cage into the anterior part after it is entering the disc space. So that is why the risk of injury is less.
What about exiting nerve root injury?
Yeah,
especially the
because
do you use neuromonitoring during the
no, I see the exiting nerve root from the interlaminar axis. I see the cage going into transcambin. I'll be seeing through interlaminar approach. I'll be seeing how the cage is hitting the exiting nerve. Since I remove the complete facet, I'll be seeing the head to toe of the exiting nerve root. So if required to take care of exiting nerve root, I can use a small hook, push it aside, then push the cage inside.
What about L5S1 level if you have high iliac crest?
Yeah, it's
you
a
can
trouble.
do it also?
It's a trouble.
Okay. All right, thanks. Thank you. Thank you.
Okay, next. Because of our time, next presentation, please.
Thank you very
Thank you
much.
for
Thank you.
saying that.
Next presentation by Dr. Haji Su, Advancement in Biportal Endoscopic Lumbar Fusion, a comparative analysis of cage option and technique.
We are very can be used posterior approach that former the Indian Salawadi was presented that, and it is actually invented by Dr. Gina who is presented this conference. So and hybrid 2 cage means mixed use of 2 different types of cages. So I show you next pages, and the blue or the revolving technique is a transversal line technique. That means if you put the cages and we have to transversal line the cages in front of the intervertebral body, that gives us a more stable and more lordosis we can achieve. This is a revolving technique that I published on the one Asian Spine Journal. So let's see the videos. After the discectomy and endoprothetic preparation, we can use the cage gliders like this. UB have this cage glider. So this has own 3 blades. So 3 blade is a protected nerve root from the cage. And if you use a cage glider like this, you can easily and safely insert the cage without any losing bone graft in the cage and even root injuries. So after the obliquely, the insert the bigger cages like this, and the distal tip of the cage, if the distal tip of the cage is across the midline, then we can use some impactors and make some revolving these cages. So you can see the big cage is inserted obliquely, and then we use some kind of triangular shaped impactors, and then we can make that transversely to the anterior portion of the vertebral body. So when selecting a cage, these factors must be considered. First, the approach, the unilateral or bilateral factor assess and the trajectory and levels of the fusion and type of surgery. Also, diagonal diameter is very important to choosing a cage size. I will talk about the next pages. And bone marrow density and endoplate status is essential for stability and determine the risk of subsidence. We must also consider about the spinal balance after surgery and available cage options. So many evidence-based studies already reported about the different cage types affecting fusion rate and subsidence and migration. So at this fusion rate among different cage types actually not significantly different. However, the single PLIP or single tilly cages have been a little bit associated with a higher subsidence rate. One study even reported statistical differences in subsidence rate between the small and large cages. So expandable cages allows easier insertion, as you know, and provide effective restoration of disc lumbar lordosis and disc height. And also 3D printed cages, they have own micropores itself, so enhance the osteointegration and promote some fusions. Additionally, axillary cages and the two cage insertions offer a broad contact surface, so contributing to improved stability and fusion potentials. In conclusion, when endoplate conditions are favorable, outcomes are not comparable, are very comparable. But however, in case of poor endoplate integrity or low bone quality, a single cage technique are often associated with inferior outcomes. So therefore, using a double cage or a large cage may be more appropriate in these situations. So maximal contact surface and a proper cage position is also key to successful fusion. So a large cage in an ideal position can reduce subsidence, but size must match the patient's anatomy. That's why I always measure the diagonal diameters before the surgery. In this case, the diagonal diameter was only 39 millimeters, so I selected more shorter cages instead of the axillary type. So using a longer cage, not everyday right answer, and it would make, because the transverse placement is technically difficult and risky. Based on the diagonal diameter, we can make our own categorized optimal cage options, like this simple algorithm helps in preoperative planning. These are post-operative images that I did various types of cages. You can see from axillary to the two cages. Based on factors we've discussed, let's see how can we match it well with different clinical and anatomical situations. This is case number 1, and factors. Let's see. This patient was a 4-5 recessive grade 2. And, but diagonal diameter was long enough, it's 45, so he has a wide intervertebral space. And this was a primary surgery, so there was no reason of the revision-related complications. So, and BMD was good, and the sclerotic change makes us strong enough to support the cages. So that means less rate of the subsidence. So we can use all kinds of the cage options. You can see the preoperative MRI is severely narrowed and tight impacted entrance to the intervertebral space. So I used serial dilators and serial triers before the cage insertion, and the cage rises transversely in the front part of the disc space. And you can clearly see that uroseg is well expanded. Case 2. In this case, bone quality was good, but the diagonal diameter is so short. The bone is good, so I didn't use axillary because too short diameters. So I choose one single PLIP cages for simpler and stable solutions. And case 3 is a really interesting cases. This patient has both coronary and septal imbalancements was there before the surgery. You can see the left side is more collapsed than the right side. And diagonal diameter was 38 millimeters. It's too short because it's a lumbar area. And bone marrow was not bad, and the prosthesis was good. So I choose the bilateral approaches for the two expandable cages. As you can see, I choose first to the right side approach, and then I took a left side. So after the endoplate preparation, is very advantage of the endoscopy surgery compared to the open surgeon. And measurement the height of the cage and use expandable cages like this. And after the insertion, we can make expansion. It's very easy and very fast surgeries that we can do. But since the bilateral approach is required on this working, so on each side separately, so it usually takes a bit more time. So after the right side approach, then the same as the left side. And post-operative X-ray shows the excellent restoration. You can see the effective canal decompressions also. Case 4 is the same, but so I use hybrid techniques. So it's better to show you some videos. Hybrid technique means I use one of the another peak plate cages, and ipsilaterally I put the expandable cages. So first I put the plate cages on the ipsilaterally, and using an impactor, the peak cage was being advanced contralaterally, and then insert an expandable cage on the ipsilateral side. So you can see it need a short time than a bilateral approach. So you can see the post-operative hemorrhage is good. And this patient was very interesting also. The initial post-op is, I didn't do that, but it's another hospital maybe. So he underwent the fusion surgery 2 years ago, but 5 months later, the collapse was aggravating. That is a failed fusion because I don't know why, but cage is too laterally inserted. So maybe coronal balance was not achieved. So I use expandable cages and make some balances after surgery. So endoscopic revision is possible by a UV. So I did a screw remover by endoscopy surgery and also put the cages in. As you can see in the middle and lower pictures, there was an unpreparative prep was done by a conventional surgery, but our endoscope surgery, we don't do like this. So after the meticulous prep, and I put the cages in. So you can see the good post-operative MRI and X-ray images. This is also the non-fusion surgery. Some surgeons input the tele cages conventionally, but it's aggravated the coronal imbalancement. So at the preoperative CT images, the cage was very subsided and impacted in the bone. So I first tried to remove the cages with endoscopy surgery, but it was so stuck. So it's very dangerous to remove it. So I changed the mind, and I used an impactor, and more tightly I put the cages and stuck between the intervertebral body. And then I put the cages, expandable cages, and expanded like this. So coronal balance is very good after the surgery. Important thing is we can put the very much enough bone graft as possible. It's very good for fusion. Empty space is forever empty space, so I think the more bone graft insertion is better for the fusion. Case 7 is long level, so it's not a big deal, but it's 2 levels, it's coronal system imbalancement, so I use hybrid techniques, and I put the 2 cages even per the levels. So you can see the post-operative full spine standing lateral images shows good collection of the lumbar lordosis and restoration. In conclusion, the endoscopic spine surgery provided great flexibility in cage selections without any additional limitations. So therefore, the UB or PSLD or endoscopic surgeon must be like a talent of the spine surgeon, I think. So thank you for listening. Thank you.
Any question or comment from the floor?
We don't have much time, so
Okay.
I will take questions after this session, personally.
Thank you for your nice presentation.
So next, next presentation from Prince Maxime Chalali. What is the best option of endolip and UB clip?
So I'm Dr. Chalali Maxime from France. I speak Russian, but I will speak English today. So I work in France, in south of France. Since 1 year, we start to work. It's here, but not there. Excuse me, working. So I work in south of France with one surgeon, Dr. Wagner. He's a monoportal surgeon. He did almost 5,000 monoportal surgery. And every day we try to find what's the best options, like UB TLIF, or OL leaf, or endolif, or transcomblin monoportal fusion. So to resume, you know, you see today a lot of hardware, cage like this, but if you want to have fusion, you need to have biology. So in UB, what's very interesting in UB is that you can perform a very nice discectomy, or you can prepare perfectly your on plate. This is the key point in UB. Or you have possibility to put a lot of bone graft. So the most important thing for UB is the possibility to make perfect discectomy or to prepare perfectly with the on plate. So about endolif or OL leaf or transcombined leaf, there's a lot of papers about this now. It's a very quick technique. It's possible to put a cage in 20 minutes. It's safe. And you can use endoscope, or if you want, you can not use endoscope as you want. So the technique is described by American surgeon Abaisi, or Ralph Wagner do the same technique. You make incision about 7 centimeters from midline, and you have access to middle part of disc. So it can be done by endoscopy, but it can be done with no endoscope. So it's a technique that's described in literature. It's very effective. And with my colleague, we can do it in 20 minutes. No endoscopy. So in my clinic, we have two options. For each patient, we can do UB TLIF or this. We use better this system. It's a Titan cage with a wire system from one German company to perform this surgery. So if you look to literature, you see there is some study. Endolif or mid-TLIF is the same result. The rehabilitation is faster. On the endolif versus UB TLIF, the thing that they say that UB TLIF is faster, I think if you do with no endoscope, it's very fast to do this technique. So we do the two options. And every day we are speaking what's the best options. So I wanted today to see a lot of good results, so I need to show you a bad result. So it's a patient you have in France. She have a prosthesis L5S1. And during surgery, they make vascular injury on L4, L5. She had a 3 discectomy L5S1, 2 discectomy L4, L5, and she had dual tear. And she's coming for radicular pain and low back pain. This is the MRI. So this is not a great patient. It's a modic one, post-discectomy low back pain. And she had already anterior approach with bad result on the posterior complication. So for this patient, we have a lot of options. So the best option is to don't do surgery. But she's coming, and we try to find the best way to resolve this. So we spoke about this case with my colleague Ralph, and we decided to make an endoleaf with no endoscopy, percutaneous endoleaf. So you see, this is the CT after surgery. The cage is very nice. The patient is not so happy because she has a huge pain on all four pain. So at this, we did the CT scan to try to understand what's going on. At the end, make a revision of surgery with a PAR-UB, and I find the disc, this piece of disc in foramen. So when you do fusion surgery, you need to come back to basics. You need to do good discectomy. You need to good implants, good bone graft. After, cage, expandable cage, olive cage, blah, blah, blah. It's not the most important thing. The thing is to have a good preparation of your end plate. So for a small fast presentation, so what we do, if you have high disc, we do UB TELIF, because you need to make good discectomy, good preparation of end plate. If we have vacuum disc or bad disc, we do oil leaf or endoleaf. Now I start to do UB-assisted endoleaf after these patients. So I make a PAR-UB approach. I do a discectomy, but by this way, it's not possible to do perfect discectomy. And after this, I put the cage with the same system, but I check what's going on. This is endoleaf assisted by UB, to be sure that I don't have this kind of problems. So today, we need to come back to basics. You do fusion, you need to have good preparation of plate and good bone graft. If you have big disc, you need to remove it. So it's not only to do endoscopy, So this is the conclusion of this. But when you do this kind of surgery, you need to be effective and to choose the two options, endoleaf or UB TELIF. Thanks for attention. So we have time for questions. No questions? Questions end of the day. Okay.
Thank you, Dr. Mosim, for excellent presentation. We invite the next speaker because Dr. Sudhir is not available. It's Dr. Chiranchuk Doris from Russia.
Thank you for invitation, for possibility to make our presentation in such auditory. I'd like to talk in Russian because a lot of people understand this language. So, спасибо за возможность выступить. Начну свою презентацию. Моя презентация также посвящена бипортальному эндоскопическому тлифу при поясничной патологии дегенеративной. Здесь уже было много об этом рассказано. Я позволю себе остановиться на таких наиболее значимых моментах, которые мне кажутся актуальными. Ну вот по новизне это, сказать, эндостабилизация популярна последние несколько лет, хотя набирая в поисковике разными, так сказать, вариантами бипортальную или эндоскопический тлиф, я увидел, что вот последние годы почему-то волна немножко схлынула. Не знаю, с чем это связано, может быть, дальше снова будет подъем. Но вот как увидел, так и показал вам. Преимущества микрохирургического доступа или эндоскопического при стабилизации, они показаны на слайде, но, конечно, эндоскопия в физиологическом растворе с минимальной травмой мышц, методом свободной руки, она, мне кажется, более эффективна. Ну и сейчас я вот видел на выставке вариации монопортальной эндоскопии, которая позволяет тоже ставить кейджи. Это получается такой вариант гибридной хирургии. При бипортальной эндоскопии, мне кажется, очень удобно то, что два разреза можно использовать и для эндоскопии, и для чрезкожного проведения винтов, как тут уже показывали. Ну, известная работа наших специалистов, которые всех здесь учили, из Корее показаны точки доступа, они известны. Какие трудности есть, особенно при листезах? Если мы говорим об удалении грыжи диска, это всегда какой-то небольшой мини-доступ для того, чтобы брать секвестр. Если мы говорим о том, что нужно еще выполнить фьюжн, то здесь мы или убираем полностью сустав, или выполняем какую-то большую такую медиальную фасциэктомию или латеральную фасциэктомию в зависимости от доступа. Это большой объем костной работы с использованием остеотомов, шейверов. И это занимает определенное время, и это не просто удаление секвестра. Помимо установки стабилизирующей системы, мы должны не забывать о том, что в некоторых случаях приходится еще выполнять и декомпрессию невральных структур. И тут, помимо задачи стабилизации, еще мы выполняем задачу устранения неврологического дефицита, освобождения корешков, выполнения декомпрессии. Бипортальная эндоскопия за счет своих разрезов при наличии, там, допустим, лордоза хорошо позволяет иногда даже выполнить не только на одном уровне какой-то объем декомпрессии, но из тех же, так сказать, доступов, из тех же разрезов двух, допустим, выполнить двухуровневую декомпрессию, что, допустим, вот на этом снимке видно, что и на одном уровне, и на другом мы, в общем-то, из тех же двух маленьких разрезов выполнили декомпрессию. Для того, чтобы полноценно реализовать зону междискового дискового промежутка, нужно хорошо зачистить замыкательные пластины, как здесь вот представлено на видео. И эндоскоп в данном случае, в отличие от микроскопа, позволяет зайти в межселовой промежуток и визуализировать все пространство, чуть ли не до передней продольной связки, настолько, насколько это нужно, и получить максимальный, так сказать, эффект для того, чтобы зашел любой кейдж любого размера. Ну, используются различные инструментарии. Вот мы видим, что эндоскоп позволяет нам тогда кровяной росы зачистить замыкательные пластины, и все готово для установки кейджа. Под контролем глазом мы устанавливаем кейдж. При открытой хирургии это невозможно сделать. И, в общем-то, хирург смотрит на экран и выполняет установку кейджа, видя, как это все происходит в режиме реального времени. Вот, собственно, красочно хорошо видно на представленных видео. Помимо рентгеновского контроля, у нас еще контроль, так сказать, в онлайн-режиме, внутри, по сути, межтелового промежутка, внутри канала. Ну и то, о чем я говорил, если для монопортальной эндоскопии нужно делать какой-то дополнительный разрез, гибридной техники, то здесь 4 разреза, которые используются для черезкожной стабилизации, они же, по сути, они используются для установки кейджей. Ну, позвольте несколько таких примеров коротких. Женщина 73 лет с болевым синдромом на МРТ с листез со стенозом канала. Выполнена эндоскопическая бипортальная стабилизация, устранен листез, выполнена декомпрессия. Хороший результат по данным рентгеновского снимков. Или, допустим, если мы говорим иногда о ревизионной хирургии, мы можем установить кейджи также из экстрафораминального доступа. В данном случае пациенту выполнено несколько операций интраламинарным доступом, с удалением грыж диска, с декомпрессией канала, но, в общем-то, настало время стабилизации. Экстрафораминально мы заходим, такая вот ревизионная хирургия, и, видите, достаточно большой кейдж с широким основанием установлен на этом промежутке. И при этом интраламинарный доступ, где достаточно большое количество рубцов и риск травматизации невральных структур высокий, мы можем этот доступ вообще не использовать и в канал не заходить, а выполнить только этап фьюжн экстрафораминально, что очень удобно для ревизионной хирургии. Ну и также под контролем зрения мы понимаем, где установлен кейдж, контролируем процесс самой имплантации. Ну и как короткое видео, может быть, насколько это. Вот пациентка сразу же, по сути, на второй день после операции наклоняется, все у нее хорошо. Мы проконтролировали, что, в общем-то, проблем, цель операции решена. Ну, еще хотелось бы отметить, что вообще эндоскопия, в том числе бипортальная, с фьюженом, она очень удобна у пациентов с ожирением. Потому что если мы говорим об открытой хирургии, то это всегда большие разрезы, риск нагноения раны, долго ушивается такая рана. Как раз пациент с ожирением, особенно с диабетом, если эндоскопия позволяет решить этой проблемой, в общем-то, риск таких осложнений он минимальный. Спасибо за внимание. Thank you for your attention.
Thank you for nice presentation, but sorry, because of time, no question.
We'll start the next session.
Okay.
So no questions now.
No question,
Because we are way behind of time, 1 hour behind of time. So
Thank you
without
very much.
questions, we will go to the next session already.
Okay, thank you very much.
Thank you very much.
So we close this session. Thank you.
For the next session, cervical and thoracic spine endoscopy, moderator Dr. Vichan and Dr. Yang.
Good afternoon, everybody. Now, this section is sections of endoscopic, thoracic spine, endoscopic and cervical spine decompression. And my name is Dr. Borapot Pichan.
I'm Dr. Yang Dong-hoon.
For the first speaker of this section will be Dr. Yu Zhen Lu from Taiwan. He will talk about the SAP on-box resection in percutaneous endoscopic cervical foraminotomy. Please, Dr. Yu Zhen Lu.
Is there a pointer over here? Yes, right. Second. This one. Oh, okay. Thank you. Oh, which station? Okay. And good afternoon, everyone. And thanks for the organizer, Dr. Shimasu and Dr. Ako, for giving me the chance to present in the third Casmiss annual meeting. And I'm honored that I joined the first one. And the second one, I have some visa problem. I cannot come here. And today my topic is advanced SAP resection for PECF. And compared to just now, Dr. Wei Chen talked about the en-bloc reset of the butterfly yellow ligament. I want to talk about why I suggest the SAP en-bloc resection. And my name is Yu Zhen Lu. I'm from Taiwan Lincoln Chang'an Memorial Hospital. I am the professor of neurosurgery. So SAP extends from the junction between the pedicle and the laminate articulate with the inferior articular process of the vertebra above, forming which called zygophysio joint. So what causes the cervical foraminal stenosis? So as you can see here, the anatomy of the cervical neuroforamen, which is composed of the cranial pedicle and the caudal pedicle, and the ventral side is we call ancovertebral joint within a process, and the dorsal side is the SAP. And what accounts for cervical neuroforaminal stenosis? AP diameter compared to the lumbar spine is more important to the cranial caudal diameter. So along with this concept, let's see this Japanese group study from 11 cadaver study from C3 to C7. They compare different kind of surgical methods with anterior ACDF or ACDF with UVR or foraminotomy or anterior plus posterior surgery. So they compare in neutral, flexion, and the extension position, and what's most important is extension. And if you just choose one simple procedure, the foraminotomy can create the most foraminal size enlargement compared to all the other procedures. So along with the MIS instrument development, so people start to think if we can do just posterior to choose the adequate patient, maybe PCS is very efficient and powerful. So this is a study from Netherlands, which called the facet randomized control trial. So they compare the unilateral arm pain from cervical reticulopathy. So they compare 100 patients from ACDF and 100 patients from PCF. So the results show that not only the vast pain of neck or arm or NDI, but also all the side effects, including surgical related or other serious side effects, PCF is not inferior to ACDF. Is there any drawback of the PCF surgery? So that's this 2015 analysis. So they study the patient choose the PCF as a primary surgery. So they pick up 178 patients. So they found that if the patient are not satisfied with the result, they choose ACDF as a salvage surgery. So ACDF revision is a primary outcome. So as you can see, 9 out of 178 patients, they are not satisfied with the result. The reason is disc herniation, steel foraminal stenosis, or other spondylosis. So let's see the category. So for moderate to severe foraminal stenosis, if you are not familiar with how you do the PCF or PECF, maybe the decompression is not enough. And otherwise, in addition to this, there are other drawbacks of this surgery. So as you can see, the ACDF revision for the residual pain, but the non-revision and the ACDF revision group, both of them has up to 30%, they have post-operated numbness or tingling. So I have to raise the problem that need to be solved. The first is inefficient foraminal decompression, and I want to provide the method how to standardize the PECF procedure. The second, there is inevitable a certain percentage of post-operative numbness or tingling. So does the approach method matter? So let's see the anatomy first. For the yellow ligament in the cervical spine, as you can see the diagram here, it's a skipping. And if you circle the V point over there and you make a quadrant, you found the yellow ligament doesn't go to the foramen comparing to the lumbar spine. As you can see, the nerve is go along with the quadrant third, and there's no yellow ligament. So if you enter, you want to decompression the nerve roots in the cervical spine, you meet no yellow ligament. So this is, I provide this concept, I call this partial pediculotomy and the en-bloc medial SAP resection. So the first, the step including 3. The first, remove the shingling IAP. The second, exposing the SAP tip, thinning with spur and metagutter, and cut the SAP along the margin of the caudal pedicle and taking the whole piece away. And let's see this. The first, this one, as you can see, this is okay, the diagram A, that's find the V point. And the diagram B is taking of the IAP, exposing the SAP and make it very thin, and you find the pedicle. And then you take the whole piece of the SAP away, you find the root, and you surrogate along with the pedicle from medial margin to outer margin to make sure it is sufficient decompression. So let's see the video. So find the soft tissue, find the SAP, and I like to make it a landmark. This is make a T like, make a V like a T, and so from this you're going laterally to decompression nerve root. And you find the ligament, you find the third quadrant, there's no yellow ligament. So here you find the pedicle inside the cancerous bone, and then you remove the residual IAP, or initially you can make it all away and curate the cartilage within the SAP and the IAP, and then make the gutter along the medial SAP like this. I like to make it like an L shape. And then you break the SAP with your punch just above the pedicle upper margin, so you can take the whole piece of SAP away without repeated maneuver over the nerve root, so you can see the nerve root will decompress. So before operation, I use MRI and the CT scan for preoperative planning. As you can see here, the MRI can see the soft tissue, and the CT scan can see the osteophyte. So I like to, before operation, I like to draw a line that is lateral margin of the disc or osteophyte and calculate how much medial SAP, the length I want to resect. So the yellow 8.2 millimeter, that's the part I want to resect. And as you can see the right upper the diagram, the green one is the nerve root. That one goes all the way through the quadrant 3. And the red dot line, that's a medial SAP that I want to remove. So if you want to find the pedicle quickly, that's one. You want to along the pedicle, make the SAP tip break. So there you have to first find the yellow ligament, the lower margin, and then 45 degree, and you can diagonal, you find the pedicle. Or you can burr the SAP and you find a cortical bone within the cancerous bone. That one is the cortical where it is. So let's see here. So when you augment the V point and taking out the IP, you see there's a cortical bone within the cancerous bone. So from here, you know where the pedicle is. So you en bloc, reset the SAP, you make a break along where you create the gutter. And then you take the whole piece of SAP tip away and avoid repeating maneuver above the nerve root. And after you take the whole piece of SAP away, what's more important, you intraoperative, you know where you have sufficient decompression. The important is the pedicle. So you decompress along with the pedicle. It's over here. You decompress along with the pedicle, and gradually you remove the lateral margin of the SAP. You see there's a round shape over there. That's a pedicle. So you decompress until the lateral margin of the pedicle. That's a sufficient decompression. Because lateral to the pedicle, there's nothing ventrally to compress the nerve root. So this is preoperative and postoperative. As you can see the right side, I augment the foramen pretty dramatically. As you can see, I just removed the medial SAP. So the capsule and the RIP are all preserved. So it doesn't interfere with the stability. If you want to do the ventral lesion, you need to know the anatomy with the nerve and the disc. So above C5, the disc is in the shoulder side. Below C5 is in the axillary side. So using my standardized procedure, you take partially of the pedicle. You don't need to retract the nerve root. You can shift your endoscope to caudally, and you remove the disc without retraction of the nerve root. That makes your nerve root very safe. So this can go to partially pediculotomy and the partial vertebrotomy approach to remove the disc without retraction any nerve root. So my take-home message is partial pediculotomy and the medial SAP resection. It is a standardized procedure to make sufficient decompression. And one piece remove the SAP tip may decrease repeated maneuver over the nerve root, decrease post-operative dysesthesia. See my patient's result. I have 17 levels, C4, 5, C5, 6 the most. After I discuss with Dr. Lin, I want to see how I can be more successful in decreasing the postoperative numbness or tingling. I discussed with the central approach or direct electron muscle approach, which one is better. As you can see the red line, this is central approach, incline approach. So be a little bit caudal side, under decompression the foramen. And the red one is the lateral margin. You just cut the facet joint. And let's see the result. So I kind of forget what method I use. So I calculate with the postoperative SF and AA angle. If it is negative, it is incline method. If it is positive, I call it the lateral mass method. So as you can see, I calculate. Of course, the lateral mass approach has significant more facet joint resection. And I compare medial foraminal diameter and the distal diameter enlargement. And the lateral mass approach has significant more foraminal enlargement. Distal still significant, but not as significant as medial side. Okay, 1 minute. So this is the result that, as you can see, the lateral mass approach has significant more facet joint resection and the more medial and the distal foraminal enlargement. But the patient's results seem similar. No matter incline or direct, they are very satisfied. So how about the stability? Both groups are stability are very good. Lordosis or kyphosis, they recover their lordosis. But I find one thing very interesting is postoperative numbness, central approach are much higher. Even using my method is 15% compared to the article 30%. It's still much higher than the lateral mass approach. So my theory is, after discussing with Dr. Lin, using the incline method, your caisson punch is 20 to 30 degree incline. You are inevitable using your foot plate or your caisson punch to touch your nerve roots compared to the lateral mass approach. So you will touch your nerve root without yellow ligament protect, so you make the patient numbness. So I prefer the lateral mass approach to decompress. So this is my last slide. Conclusion is PE-SAFE is safe and effective surgical method to treat unilateral cervical radiculopathy. And combine what I suggest partial pediculotomy and en-bloc SAP resection. To standardize the procedure, you have sufficient decompression and without post-operative motor or sensory unsatisfied results. An incline method may reduce the facet joint resection rate, achieve adequate foraminal enlargement, but may cause post-operative dysesthesia. And thank you for your listening.
Thank you, Dr. Yu Shenru. Any question from the floor? Yes, please.
Agree with you. Why? Because approximately 25 years, I did posterior cervical foraminectomy via only keyhole foraminectomy. You began your speech as a priori acceptance. You are saying that if you did this type surgery, you will see recurrence for pain or dysesthesia. No, we didn't see. And now our young surgeons, and I am, we are doing only endoscopically. We are opening the posteriorly the nerve root. But there is one trick. Okay, you are right. The ligamentum flavum doesn't go to foramen. But over the, inside the foramen, over the nerve root and the medulla spinalis, over the dura, there is peridural membrane, which is carrying the small vessels. If you open also this membrane, you will not see any recurrent pain or any other things. So I didn't see any problem with the conventional method. And in my opinion, I am very sorry that it is unnecessary extended operation. Only opening is sufficient for me. This is my idea, of course, or my experience.
I don't get your point. It's you think not opening.
SAP resection.
Why SAP resection?
It is unnecessary, in my opinion.
So if you don't do SAP resection, how do you decompress the stenosis?
You are saying that you are taking out the SAP. It is not necessary. Only if you open over the nerve, approximately 1.5 centimeter or 2 centimeter laterally.
I didn't take all the SAP away.
But not this type extended operation.
Oh, this is not extended operation. This is minimal invasive
maybe
operation.
I have to show the post-operative MRIs. It is not same with you. I think that.
I think the endoscope spine for the cervical foraminectomy is quite different to the open surgery. Why?
Also, sorry, sir, they are doing endoscopically now.
No, yeah. Anyway, we have so many the reference. It's very safe. No instability post-operative, like the Dr. Liu operation, because most of the spine doctor don't like the operation. But result is very nice. You can check so many reference. Why? So anyway, before operation, the first you should check out CT scan is very important. CT scan. If most of the older the patient have disc space collapse, means autofused. In that case, full decompression is that we can do, and there is no any the instability post-operative. Sometimes we can encounter the vertebral artery after full decompression, but there is no any instability. Why? Autofused case. In the open surgery, we have to preserve the fascia joint more than 50%. But during the operation, how can we calculate the 50%? Right? Full decompression is very important. But if you choose, you can check the CT scan before. If the disc space is diffused, total removal fascia joint is one of the strategy. Need to change the strategy, quite different endoscope. What do you mean? Okay, I just want to know.
No.
Surprise.
This is. No, I have no any problem. This is my idea, and in my opinion, really, I insist.
Your idea, but we have so many evidence. Okay?
Yeah.
So many evidence we have. With the reference, post papers, so many. You need to talk about with the evidence.
Sorry, Professor, we are behind the schedule. Okay, thank you, Dr. Ru. And let me introduce the next speaker, Dr. Jin Young Lee from Korea. Okay, his topic is the basic techniques of UBE, cervical fragmentomy, and discectomy. He will talk about some basic and advanced technique for UBE.
Hello, I'm Jin Young Lee from South Korea. I work in Dubai now, so it's a great pleasure to make a presentation at this conference. I work in this is my hospital, Sharjah. Okay. Today's my topic is a UV cervical foraminotomy with discectomy guided by surgical landmarks for effective decompression. The cervical foraminotomy and discectomy using UV was first published in 2017, and since then it has continuously developed and is now performed around the world. The method of UV cervical foraminotomy has also developed, allowing appropriate surgery based on the location of the pathologic lesion. Depending on the pathologic regions, the location, the surgery can be performed either the posterior cervical foraminotomy or posterior cervical inclinatory foraminotomy tailored to the individual patient. The difference between the two procedures is then in PCF, surgeon operated from the same side as a lesion, whereas in PCIF, the surgery is performed from the opposite side of the lesion. Due to the difference in the surgical view and instrument access, it is important to adapt the approach according to the location of the pathologic lesion. In cervical radiculopathy, posterior cervical foraminotomy has already been shown in RCT papers and produced results similar to the ACDF. When performing the adequate cervical foraminotomy, approximately 50% of facet joint resection is required. Anatomically, considering the course of the nerve root, it can be compressed within the narrow space between the hypertrophic SAP and uncinate process. For adequate decompression, it is necessary to decompression up to the zone 2, the point 1 and 2, like this. Then, will the stability be adequate after the performing the 50% of prostatectomy? The following experimental study shows that the stability is well maintained ever after resecting 50% of facet. Therefore, posterior foraminotomy should be considered the first line choice treating the radiculopathy. In studies related to the learning curve, it is stated that with the experience from the only 20 cases, one can achieve proficiency in over 90% of surgeries. Therefore, if you have sufficient experience with UBE, you can consider starting cervical foraminotomy. The cervical foraminotomy indication as follows: cervical foraminostenosis, disc herniation, osteophyte, juxtafacet cyst, and other things. Surgical position is the patient was placed on the prone position with the chest raised under the general anesthesia. The operating table was adjusted until the patient's cervical curvature was straight and parallel to the ground. In cervical foraminotomy surgery, the first target to focus on the V-point. The V-point included the inferior margin of cephalic lamina, and then the medial border of the junction facet, and then joint, and then the superior margin of caudal lamina. Check the V-point under the CM guidance, and then the skin incision should be made along the medial pedicle line, and then using a tense blade is advantage for the skin incision. During the surgery, the pedicle would serve as the indicator to determine how much of the bone margin should be removed to ensure effective root decompression. So, maximally posterior lobe root decompression lateral endpoint is the pedicle lateral margin. When you check the V-point and perform the drilling to remove the cortical bone, you will see this anatomy, this V-point, and nerve root pass in these directions. The key point for performing the surgical easily, the point is here, that as you drill lower lamina, you can identify the insertion point of the ligament flavum. And through this area, you can easily detach of the cervical epidural membrane. After removing epidural membrane, there is another layer, the perineural membrane covered this whitish arrow. This membrane must also be removed to perform the adhesive lysis and to remove the ruptured disc. The useful following tools help perform the cervical foraminotomy surgery more easily. I showed three cases in cervical foraminotomy case. So the first case is the PCF case, the neck pain and left severe arm pain cases. Left side is disc rupture and stenosis. I'll do the surgery. Check the V-point first, and then drill out the cranial and lower side lamina. This cranial lamina, remove, and then detaching the epidural membrane first. You can see, you can identify the dural sac, and then SAP medial border remove, and remove the epidural membrane also, like this. And then remove the disc from axillary portion. And then annulus coagulation for rupture site. More retracted on the root like this, and then more coagulation for the opening site. And well decompression seen. And post-operative shows that the well decompression and disc removal. The second case is a PCIF case. Neck pain and right severe arm pain, and even if hand weakness also. So 71 right side, disc herniation and PCIF surgery. I do the. On the MRI shows cervical disc rupture and foraminal stenosis in the C71 right side observed. Since the disc rupture mid portion of the facet, I choose the PCIF surgery. PCIF is different, reverse V-point to first check also. And then same is to remove the cranial and caudal lamina drilling. You can find the facet joint and then remove the medial border of the SAP. You can directly see the disc rupture. And then remove the ruptured disc. we'll see the PCIF in the middle portion or lateral portion of the disc rupture. PCIF is more we'll see the rupture disc. And then fully decompression and endless coagulations. And find the end-to-end the pedicle and fully decompression. We'll see. Third case is the multi-level PCF surgery, featuring the sliding techniques. Sliding technique, the Dr. Ha has also published performing two cervical parametromy in 2023. The distance between the two skin incisions is a little bit wider than the one-level surgery. So only two skin incisions is needed, only two-level surgery. The case is the left side, the arm pain, and left side disc rupture and stenosis patient 5, 6, 6, 7 level. I did the nerve block twice, but pain was not controlled, so I considered the surgery. The first is same. The surgery method is the same. Check the V point first, and then the drilling the lamina, cranial and caudal side, and check confirmation V point, and then the lower lamina margin. After remove the SAP medial border, drilling the fully decompression. Curettage is also easy to remove the epidural membrane and ligament flavum. Remove the epidural membrane. And you can find the disc rupture on the axilla site. Adhesion is very severe. So adhesion lysis is very important. And then just move to the scope, the caudal side. Check the V point first. You can see directly 5, 6, 6, 7. Yeah. Okay. And then the same method. Yeah. And fully decompression and skin incision only 2. So the last slide is regarding radiculopathy. It has already been proven through the RCT studies that there is no difference compared to the ACDF. The learning curve is only 20 cases. So don't be afraid, start the UV cervical foraminotomy. The tips for reducing the surgical time is the skin incision is use tense blade in fascia cutting and bone touching is very important, and target the weak areas, the cervical epidural membrane, and while removing the perineal membrane, bleeding often occurs, so it is advisable for perform the coagulation while removing the membrane. Thank you for attention.
Thank you, Dr. Yi, for excellent presentation. And education from Flo, because we are behind of the time, only one question I accept. Anyone? Okay?
First of all, thank you very much, because you are aware about existence of peridural membrane. It is so important. Yes. And in my opinion, you are right. The resection should be as extensive as it necessary. And now I have a question for you. Do you need the total SAP resection anytime?
No, I don't.
Thank you very much.
Yeah. Okay. Wait a minute. Dr. Lee, we need have another questions.
Yeah.
Yes, please.
Thank you for your excellent talk. And I think we have agreement with uniportal and biportal. And the same as you can see, the medial border of the pedicle to outer border of pedicle is where we need to reset the SAP tip, right? Similar.
Total SAP resection is not available, I think. But
Not
SAP
total.
tip, yeah, OCP tip only
Medium
resection,
SAP
yeah.
resection, yeah.
I'll do.
Yeah, and then that's a margin I mentioned about the SAP tip that we need to reset. But the difference is the membrane. So do you routinely open the perineural membrane for?
I always open the new perineural
so do
membrane.
You find if you don't remove, does it still enough for patient symptom to recover?
I think.
Okay, Dr. Lee, and if I comment some the terminology, you talk about the epidural membrane and perineural membrane, but actually that's official name of that is peridural membrane. That is the correct name. Thank you.
Thank you. And the next speaker is Dr. Meti Pakawet from Thailand. He will talk about endoscopic surgery for cervical spondylotic myelopathy. Please, Dr. Meti.
Thank you very much. Thank you, Dr. Shumanse, for the invitation. Thank you, Dr. Lim, for every knowledge and recommend me here. So today I will talking about endoscopic decompression. Endoscopic decompression for the cervical spondylotic myelopathy. Yeah. Let's start. This is the outline. I will show the indication and the patient selection, example case, and the surgical technique. For the indication, I think as the endoscopic surgeon, we still need to do the same indication as the traditional surgery. Spinal cord compression with the myelopathic symptom, we need that. And some patients come to see us with the arm pain, but the MRI showed the significant spinal cord compression. So we have to do both foraminotomy and decompression also at the same time. And if the patient has the acute weakness with the disc herniation, with the myelopathic symptom, so we go for endo-ACDF. For the patient selection, instead of doing the laminoplasty, I choose the endo decompression. So indication still almost same as the traditional. With the single level spinal cord compression posterior pathology, we're going to do the endo decompression only. But the single level anterior pathology, we do the endo-ACDF. And for the multiple levels, posterior pathology, and or the OPLL, I prefer the endo decompression for multi-level decompression. For the good side of the endo decompression is this take less operative time and less operative pain compared to the laminoplasty. Anyway, this operation is more difficult and riskier operation. And due to the severe soft tissue bleeding, this is the main enemy of this kind of surgery. For the laminoplasty, we can get the wider decompression and easier, safer operation, but we have to destroy more the posterior structure. In the uniportal decompression like this, we decide to do one side approach, unilateral approach, or both side approach, bilateral approach. I always prefer bilateral approach because I think it have the better bone cutting and safer decompression, and we still can keep the subvenous process for the posterior stability. Anyway, it takes longer operative times compared to when you do the unilateral approach. But if you do the unilateral approach, the risk of the contralateral spinal cord injury is very high. It's difficult to cut the bone on the contralateral side, and normally you have to break the subvenous process to reach the contralateral side. So I always do the bilateral approach. For the example case, for the first case, that is the spondylolisthesis on C3-4. This case, I recommend to do decompression. Then maybe you can ACDF later, but decompression first, it makes safer. And the second one, also decompression. The third one, decompression. And the last one is ACDF, I will show. The first case have 58-year-old female with a severe numbness on both arm and both leg. for 2 months and difficult to walk. Yes. From the MRI, show the severe spinal cord compression on C4-5 and C3-4 and C5-6, only a little bit compression, but we need to cut the bone along the way to make the space for the spinal cord shift to the posterior part. Yep. For the surgical technique, I do only one incision in the middle, which is C4-5, and sliding up and sliding down, only one about 8 millimeter incision. I start C4-5, preparing the bone cut at C4-5, and try, when you do the decompression like this, try to reach the opposite side as much as possible. So when you come back later, you can easier remove the flavum. You can see the flavum down here. And the severe bleeding, this is a problem of this operation. And then slide up, and find the edge of the lamina of C3-4. And do the same things. Remove the soft tissue and drill the bone, prepare the bone cut. First I try to cut the bone first, but I keep the flavum. I don't remove yet at the first time. I try to cut the bone for all level with the sliding technique, middle levels, and slide up, cut the bone. Yes. And then, after middle, and this is, you can see the bone bridge between the C3-4 and 4-5. This is C4 lamina. And then we slide down to the C5-6. Just do the same thing as the bone level. For the C5-6, after prepare the bone, I also do the decompression at the same time, remove all the flavum at this level. And the most difficult part of this technique, I think, is the hemilaminectomy, which is, if we want the 3-level decompression, we have to do the hemilaminectomy in 2 levels, which is C5, then I up to C4. It's difficult and dangerous because below the lamina, there is no ligamentum flavum anymore. Nothing protects you from the spinal cord anymore. Need to really be careful. Yeah. After finish the bone cut here, we're going to remove the ligamentum flavum and then finish. Yeah. I do the same things in opposite side, but for the opposite side, I do only decompression, don't remove the bone. So I just want to keep the stability as much as possible. Remove the lamina only one side. This is the post-operative MRI. You can see the spinal cord have that much better going down to, yeah. And there is no more nerve compression. Yeah. This is the surgical wound. This is a bilateral approach. For the second case, 67 years old female with the severe numbness both arm and difficult to walk for 2 weeks. This case actually have the multiple level nerve compression too, but the main pathology is the C5-6 disc herniation, which I think the most proper operation is ACDF to cure this pathology. So for the endoscopic ACDF, actually it looks like the hybrid approach because I do the open before. The open surgery, open the wound, and put the detector as we do the microscope ACDF. But inside, in the posterior, I use the endoscope to look at the posterior structure. Yeah. And with the secret that this like this, we can use the hook just to remove the disc herniation as much as possible. Yeah. So sometimes we scared about the water that leakage to the soft tissue allow the surgical wound, but actually, when we do the mini open, so water is leaked outside already. It's don't have any problem in my experience. Yeah. Yes. And this is the post-operative MRI. The disc was totally removed, and the case was in the good position. So thank you very much.
Thank you for excellent talk, Dr. Mehdi. Any questions or share from the floor?
Thank you for wonderful lecture. There are some cases that occurred restenosis after cervical endoscopy decompression a few years later. Are there any indication to do not occur restenosis?
Okay, so I think I always told the patient like this. For the severe spinal cord compression, when you start ACDF first, sometimes it have the spinal cord injury because of very narrow space, right? The laminectomy always have the benefit. So if we start laminectomy like this first, and then symptom is improved, not coming back, so just finish. But if the future, at least sometimes we have to go anterior and ACDF again, which is we already laminectomy, so it's safer for patient. It have the benefit, yeah.
I think that multi-level and cervical endoscopy decompression, that is a risk factor. How do your opinion?
Oh, sorry?
A multi-level decompression, or not one or two level decompression. That's a multi-level decompression is a risk factor. Do you think about that? Risk factor. Yeah.
Risky, yes, really risky. Really risky, I think so. But I think that's why, you see, I try to keep the bone bridge, keep the bone before remove everything, because the bone bridge is very important to hold the scope sleeve before you go inside. If you destroy all the structure, so you don't have the hard structure to hold the sleeve, that's sometimes you put the scope inside and you don't know. So keep the bone bridge and cut it later. Yeah.
Okay, I think so in case of the lead stenosis, the posterior approach decompression again is possible. And about the multiple level decompression, there's no any the instability, no kyphotic change compared to open surgery. Why? There is no detachment of the posterior neck muscle from the bony structures. No any kyphotic change in case of multiple level. It's one of the advantages, I think.
One last question.
Sorry, when you do this ACDF endoscopically, is it not too much water goes into the spinal canal itself? Could be a lot of water leakage into the canal.
When the water pressure, I think the problem is if we do in the closed space, the water will leak inside because outside there's no space to leak, right? But in my surgery, I do the mini open, so all the water is leaked outside, and because of the traditional approach, we stop bleeding very carefully when you do the approach, so no bleeding at all. Only, I think if you feel the cup of the normal saline inside, that's it enough. Never have bleeding when you do this approach, so water pressure is very less. Yeah.
Thank you.
Yeah. Thank you.
And let's have a next speaker, Dr. Vladislav Kalmakov from Russia. And his topic is, I can read. Can you introduce your topic by yourself, please?
Yes, I talk and write my presentation. Здравствуйте, господа спинальные эндоскопические хирурги. Я рад очень присутствовать на этой конференции и рад возможности доложить мой опыт по эндоскопической хирургии заболеваний грудного отдела позвоночника. История этого эндоскопической хирургии позвоночника началась с 1910 года, я не буду на ней останавливаться. Началось все с цистоскопа. Использовали его для того, чтобы посмотреть на плевральную полость. Так. Распространенность. Ежегодно заболеваемость грыжами диска 1 человек на миллион. Соответственно, грыжи диска в грудном отделе составляют 0,25, 0,75 всех грыж диска. Частота хирургических вмешательств составляет до 4%. Особенности. Возраст 30-50 лет, симптоматические грыжи диска 75%, в основном встречается на Т8, Т12. И преимущественно Т11, Т12, потому что это более мобильный сегмент. Осифицированные грыжи диска 42%, гигантские до 70 бывает от 15, и асимптомные вообще грыжи диска с 11 до 37% бывают. Зачем оперировать? Потому что может быть миелопатия, может быть корешковая боль, и также может быть, но на МРТ признаки миелошемии, скорее всего, в дальнейшем это проявится с миелопатией. Есть несколько опций для хирургии грудного отдела позвоночника, и одна из первых опций – это трансферминальный подход. Он используется только если на грудном отделе мягкая грыжа диска. В основном он не используется вообще. И это все дело началось с доктора Джо. Он опубликовал, что использовал эндоскоп 4 мм для того, чтобы убрать эту грыжу. Причем он это делал транспедикулярно. Он ее убрал, симптомы прошли, все сказали «ого» и начали заниматься этим всем делом. Клинический случай, есть небольшая грыжа диска, но она симптомная. Сделали трансферминальный доступ, убрали грыжу, человек хорошо себя чувствует. Интраламинарный доступ. В основном он используется при центральных стенозах, и центральные стенозы, которые вызваны осификацией желтой связки. Это очень опять же, небольшая группа людей, они до 6%, в Японии, в Китае до 4%, очень небольшая группа. И если сравнивать, то эта осификация желтой связки, она больше, чем осификация передней продольной связки, но меньше, чем грыжи. То есть еще меньше, чем 1 человек на миллион. Учитывая, что сдавливается грудной отдел, вы знаете, кровоснабжение грудного отдела, и оно очень скудное, консервативное лечение не помогает, какие-то вытяжения и тому подобное тоже не помогает. И если появляется какая-нибудь симптоматика, рекомендуют тут же делать операцию для декомпрессии. В основном используются открытые операции, но учитывая, что мы владеем эндоскопической техникой, надо, конечно, использовать ее. Это классификация, есть 5 типов осификации задней продольной связки, и все они могут иметь клинические проявления. Клинический пример – эмпиема. Если анестезиолог не может интубировать одно легкое, тоже не надо использовать. И у человека есть какая-то тяжелая дыхательная недостаточность. Тут написано, что можно оперировать с D2 до L2, в зависимости от уровня, надо заходить с одной или с другой стороны, там есть важные сосуды, поэтому надо учесть этот момент. Так располагается человек во время операции. Конечно же, надо делать маркировку уровня, потому что когда заходишь в плевральную полость, относительно непонятно, что там происходит. Удаление грыжи диска. Это этапы, то есть убираем ребро, потом убираем диск, убираем грыжу. видно, асифицированная грыжа диска, на КТ показано, миелопатия, как зайти, трудно зайти сзади, соответственно, для того, чтобы не ухудшить симптоматику, надо зайти со стороны тела позвонка. Так это выглядит. Мы заходим, убираем плевру, коагулируем плевру, убираем головку ребра. После этого мы заходим, мы видим диск, убираем диск, потом убираем еще диск, и в дальнейшем вот видно, что компримировали спинной мозг. Вот он, спинной мозг, убрали асифицированную грыжу диска, никакой ретракции, очень все здорово. КТ, МРТ после операции. Спинной мозг освобожден, грыжа удалена. При травме такой же доступ используется, если травмировался позвонок, имеется в виду сломался. Здесь сломался позвонок, мы сделали двухэтапную операцию. Первым этапом мы поставили транспедикулярную фиксацию, транскутарную, транспедикулярную фиксацию, малоинвазивно. И потом мы сделали эндоскопический трансторакальный доступ. Видно, что ставится порт, ставится веер для того, чтобы убрать легкое, которое не заинтубировано. Она убирается очень хорошо. Освобождаем позвонок от плевры. Так, убираем смежные межпозвонковые диски, убираем тело позвонка и ставим телескопический кетч, и потом ставим кость, которую мы убрали. Ну, соответственно, дренаж. КТ после операции. Очень хорошо. Этот же метод можно использовать при опухолях. Паравертебральных опухолях зона доступа с D2 до D12. Пациент с опухолью, скорее всего, невринома, она находится в грудной полости. Как ее можно убрать? Вот так вот можно и убрать. Делаем трансторакальный доступ и убираем. Эту полость, вернее, опухоль как раз видно. Освобождаем ее от плевры монокоагулятором. В дальнейшем можно даже ее просто вылущить из ложа опухоли. Соответственно, используем коагуляторы тоже, чтобы не кровило. Вот. После операции такая картина. Устанавливаем гемостатический материал. После операции картина. Какие могут быть осложнения? Могут быть осложнений много. Пневмония, потом повреждение легкого, может быть нагноение, но бывает конверсия на открытый доступ, примерно 1%. И если сравнивать частота осложнений при открытых доступах, она составляет 14%, при малоинвазивных до 6%. И результаты хирургии грудного отдела позвоночника, они зависят от того, насколько долго имеется симптоматика. Если миелопатия длительная, то, соответственно, неврологический дефицит может полностью не восстановиться. 53% пациентов улучшение неврологической симптоматики. 45% без улучшения симптоматики остается на предоперационном уровне. И 5% с ухудшением, ну это если не очень пошло. И размер грыжи не влияет на исход операции. Спасибо вам за внимание.
Any question from floor? No. Then can I ask you one question? As also I didn't, yes, I didn't understand your language, but I can ask you a question.
Yes,
so
yes.
you like in thoracic, if there is some chronic spondylotic myelopathy in 1 or 2 levels, you show us transthoracic approaches and posterior laminectomy. And for your case, what do you prefer, transthoracic or posterior laminectomy in 1 or 2 level chronic spondylosis with myelopathy patients in thoracic spine?
Мы должны знать, из-за чего миелопатия. Если миелопатия из-за осификации желтой связки, конечно, надо делать интраламинарный доступ. Если компрессия с миелопатией вызывается передняя компрессия, проще говоря, то надо разными доступами, можно разные брать доступы. Можно трансторакальный доступ, можно эндоскопический трансторакальный доступ, может быть, ну, еще можно что-то придумать для того, чтобы освободить спинной мозг. Мы просто говорим о том, что это не шейный отдел позвоночника, это не поясничный отдел позвоночника, это грудной отдел позвоночника. Ни в коем случае на грудном отделе позвоночника смещать спинной мозг нельзя. Сразу появляется ухудшение неврологической симптоматики, и в основном это имеет ишемический паттерн.
Can you translate a little bit?
Yeah, it's which is pathology. If main compression part is calcified ligamentum flavum, I mean it's posterior compression. If of course it's posterior approach, just do it bilateral decompression. If main is compression part is anterior or calcified disc or central disc herniation, is go to the anterior approach, and depends which pathology.
Okay, thank you.
Thank you.
Any other questions from floor? Okay, thank you, doctor.
Thank you.
And the next speaker is Dr. Shaikh Imran Ali from India, who is talking about posterior endoscopic cervical discectomy and decompression. Please, Dr. Ali.
Hello everyone. I would like to thank the organizing committee, Dr. Lim sir and Dr. Shomashur, for inviting me to this excellent conference. I'm from India and my name is Imran. I would like to present this topic, endoscopic cervical discectomy and decompression. The indication would be foraminal nerve root compression, which leads to radiculopathy. In elderly patients, this is due to bony spurs and foraminal stenosis, and in younger population, it can be due to foraminal disc. So, this is a rule that that is published in a paper. We draw 2 lines to the lateral edge of spinal cord, and if the pathology is majority of the pathology is lying outside these 2 lines, it is amenable with posterior approach. If it is between the 2 lines, it is preferable to deal this pathology anteriorly. So contraindication of this procedure is central stenosis, medial localization of disc herniation, and definitive segmental instability and cervical deformities. So aim of the surgery is to widen the neural foramen, relieve the pressure over exiting spinal nerve. In the previous presentations also, we have compared the advantages and disadvantages. And for radiculopathy symptomatic relief, ACDF and posterior cervical foraminectomy are equal in relieving the radicular symptoms. But what are the advantages of posterior cervical foraminectomy as compared to anterior cervical decompression? We can easily decompress at the level of C7T1, which is quite difficult via anterior approach. When the patient is presenting to us after a failed ACDF surgery, posterior cervical foraminectomy is a lifesaver. When there is adjacent level foraminectomies, instead of fusing the adjacent level, we can offer the patient cervical foraminectomy posterior approach. When there are multiple level pathologies involved, we can do a posterior laminar foraminectomy and avoid fusion. So again, there is a nice study that is done comparing open, tubular as well as full endoscopic cervical laminar foraminectomy posterior approach, and it has demonstrated that endoscopic approach is superior to both tubular and open procedure. As when it comes to UV or monoportal, there is no significant difference between both the procedures, and both are equally good in competent hands. Anesthesia and position, we generally perform this procedure under general anesthesia in prone position. Neck is slightly flexed and resting on a head foam, which is made up of gel. Abdomen is free without any pressure, and patient is positioned in such a way that the cervical, the area of operation is parallel to the floor. So, starting with the procedure, we would like to mark the site of entry. We usually draw a few lines. One is midline along the spinous processes, and one is medial pedicular line, and one is lateral pedicular line. I usually prefer my point of entry is between medial and lateral pedicular line, just towards the medial pedicular line. And when we are in lateral position, we usually like to place our needle at the level of the disc space. I usually use this spinal needle to go deep down onto the bone, feel the bone, and then infiltrate LOX with adrenaline. This infiltration will help me provide a bloodless field when I'm operating. So once I'm inside with my endoscope and trocar and endoscope, I do soft tissue dissection, expose the medial part of the facet joint, and then the dissection starts. This is an illustration of the V point. We can see the cranial and caudal lamina. We can see the pedicle. We can see the tip of SAP and ligamentum flavum medially. So after drilling, we can see the exiting nerve root. We can see the axilla from where we can remove the soft disc. Now I would like to talk about few complications. As any surgery, there can be incomplete decompression via posterior laminar foraminectomy approach. Dural injury and CSF leaks are very devastating. Injuries to the nerve root and spinal cord can happen if you are not careful with our approach. Bleeding and hematoma formation and instability. Instability happens when there is too much of bone resection. So I would like to present a small case presentation. I had operated on this 46-year-old female who presented with right arm radiculopathy. VAS score was 5 for neck pain and 8 for arm pain. She did not respond to any conservative treatment. On imaging, peculiarly, she had a C5, C6 congenital Brock vertebrae, which was causing bony fusion. And right next to it, at C6, C7 level, she had a right paracentral PIBD. So I performed a monoportal full endoscopic posterior cervical laminar foraminectomy and C6, C7 discectomy. This is the video. So you can see in this patient there is a block vertebrae, and adjacent to that block vertebrae there is a paracentral disc herniation. So this is the placement of my port. This is the V point, and dissection of the V point has started. I use kerosene punch as well as drill to dissect the upper and lower lamina and the V point. After drilling adequately, then we start dissecting around the nerve root to tease out the soft disc. So here we are teasing out the soft disc under the axilla. Postoperatively, we confirm if any loose fragments are still present under the nerve root. And once the procedure is complete, we do good hemostasis. Residual fragments, if any, have to be removed carefully. So this is post-operative image of the disc fragments that we have retrieved, and this is the post-op surgical scar. Sorry, I don't have the post-op MRI film with me. Thank you so much. Any questions?
Thank you, Dr. Ali. Okay, questions and share.
Hello, doctor. I'm Nabillah. I'm a neurosurgeon. I'd like to ask about your strategy management technique about CSF leakage. Thank you.
Sorry, sir, can you repeat?
CSF leakage.
CSF leakage in cervical spine?
Your management.
In sir.
During the surgery, yeah.
Okay, sir, it depends upon the amount of rent. Intraoperatively, if I can see if it is a small rent, I usually pack the rent with gel foam or with the Duragen. If it is a large rent, unfortunately, I have to convert the procedure to open and repair it.
Any question?
Thank you so much.
Thank you. Thank you, Dr. Ali.
So let's have a next speaker, Dr. Ng Bing Wee from Malaysia. His topic is navigated uniportal endoscopic decompression for thoracic myelopathy secondary to OYEL, technical pulse and outcome. Please, doctor.
Thank you for having me. Before that, поздравляю с такой прекрасной конференцией. My name is Ng Bing Wee. I'm a student of our beloved Professor Lim. So maybe this topic is more for a newer endoscopic surgeon, because master endoscopic surgeon, they don't need GPS. So because I am new, so I'm going to somewhere new, and I found myself a GPS. So today I'm going to share my experience on how I do this. Maybe hopefully this is my personal learning curve. So of course, I hope that by the 4th or 5th case, maybe I also can throw that GPS away. All right? So my topic is navigated uniportal endoscopic decompression for thoracic myelopathy secondary to ossified yellow ligament. So there's no doubt the MIS posterior decompression is good result. And I've seen Professor Lim perform during the fellowship, and it is fast, the result is good. There's already a lot of studies that shows that endoscopy could decompress the thoracic region. Some of the obvious advantages, lesser tissue dissection, less blood loss, short post-op stay, clear visualization, ability to be performed under local anesthesia, and of course, reduced complication rate. But however, the complication that I want to avoid is the insufficient removal of the yellow ligament. So the descriptions of a lot of studies is on the landmark and the maneuver to ensure safety and complete decompression. And of course, the CT has been described to be used as a tool to evaluate the effectiveness of the decompression. So the purpose of my presentation today is to showcase the advantage for a newbie like me. Okay, some challenges and how I do it. So I have a patient with 47 years old female, complaint of 1 year history of instability, on and off numbness of lower limb, inability to walk far without holding on to nearby objects. The MJOA score is 13. This is the MRI. So we notice that T9, there is some OYL, T10, and T11. And this is the CT scan of the 3 levels which is involved. And we decided for endoscopic decompression. So on the left is the placement of the tracker. And then we did an intraoperative CT scan. And this is the CT scan that we gotten. And instead of having a very big preparation, I only decided to put the tracker on my burr. And that's it. And I do not need other navigated instrument, only one navigated instrument. So with that, I did place the tracker and did the spin. And with that, we are able to see where is the entry point for the 3 level that we are going to decompress. Okay. And then from there, I plan my skin incision, how far it is, and how extensive it is going to be. So during the surgery, I only navigated the burr. So that burr will tell me where I am, how far I have to go, how deep it is. So with that as a guide for my operation. And the beauty of it is, before the patient wakes up, I do a CT scan again. So these are the post-decompression, and this is the MRI after the operation. So the outcome, patient complained of pain. Pain not because of the endoscopic surgery, but pain because of the navigation tracker, because the incision is too big. But anyhow, at 6 months, patients feel better, but still with some instability, but the numbness, variable numbness and tingling has reduced. So what do I like about this setup is that it is simple. I only navigate one burr. And of course, it is live. The moment I put in, I can know where I am. I have GPS, I'm not in the jungle. And of course, it guides my incision, the angle to tackle if I have a contralateral yellow ligament ossification. And I can also test cranially and caudally whether I have finished the total decompression before the patients wake up. So post-procedure CT scan is also the best thing. Challenges that I face when I do my first navigated decompression is that it is not 100% pinpoint accuracy because there's breathing. The patient is moving, and then the tracker is there. So depth is not pinpoint accuracy. But if you move cranial, caudal, medial lateral, it is still quite accurate. And of course, I don't like that the tracker pain is more than the endoscopic incision pain. And of course, during the surgery, I have to be very careful not to touch the reference frame. So I think about it for some time, and then I've decided to use a pelvic brim tracker the next time if I see a patient like this, and I will maintain the surgical flow. So I was lucky because 2 weeks after that, I have the second case. So 53-year-old male, MJOA score of 13, instability with walking. He is walking stick dependent. So again, but this time I have a T10 and T11 OYL. So this is the CT scan. And this is during the removal. So again, I navigated only the burr. Of course, as I'm still in my learning curve, so it is very helpful to know that how deep you are and how far it is you are. So this is after deciding the cranial caudal extent of the OYL, removal is just proceeded as normal. And of course, the beauty is before the patients wake up, we can do a CT scan. So pain, this time pain of navigation tracker side is less, and then this time the MJOA score also almost maintained the same, but there's reduce of numbness and trunk of lower limb. So the challenges is that the depth of the navigation changes by time, and after some discussion with other people who are good with navigation, they say that on and off we have to re-register or revalidate the instrument. Of course, the tracker reference frame is less painful with the pelvic pin. So advantage of endoscopic spine surgery in decompression surgery is well proven. That we have no doubt, all of us have no doubt. But navigation provides the precision and pre-drilling planning of trajectory and depth live when patient is on table. And of course, there's reduced radiation exposure for us. This simplified setup that I have aims to reduce the complexity of navigation, the burr being the most trajectory sensitive instrument because we use that the most. The fewer the specialized instruments, the less complex the OR is going to be. And the workflow is also quite streamlined. It's like validate the burr, we place the tracker, and then we perform a pre-surgery CT scan, decompression, and post-surgery CT scan. The limitation, of course, is still about the depth precision. Of course, I'm not saying that my method is the best, but of course, more case is needed to validate the reproducibility of this setup. And of course, there will be further refinement with different navigation system. So my conclusion, navigation can be paired with endoscopy to provide 3D navigation to younger surgeons, especially when anatomy is tricky. The simplicity of the setup enables easy handling of instruments and streamlined workflow. Post-surgery intraoperative CT provide good check to avoid inadequate decompression. Thank you.
Thank you, Dr. Ren. Any question from floor? Okay.
Excellent talk, and I like the idea. The only thing is you do the T-spine thoracic. So where do you initially put your reference pin?
Yeah.
In the pelvic ring or in the thoracic?
The first case, I place it at the lumbar spine. So it's a new incision for the tracker.
Okay.
The second time, I use a pelvic brim pin, which is also another incision, but smaller.
So you make a 2 incision eventually for all your cases?
Yeah.
Is that possible? You use just only 1 incision and put your ring?
The nearer it is to the tracker to the place of the surgery, the risk of hitting the reference frame is high. Yeah. So you risk losing your navigation. The further it is, even though it is from the lumbar and the pelvic brim is considered further. So you will also have some problem with precision. So during the surgery or throughout the surgery, you have to always check your anatomy. But if you do cervical, you can always put it on the frame.
So the thing is, if you do thoracic and put the reference over the pelvis, so your OR need to scan for at least twice, right?
No.
Your OR can cover the whole spine. I think if you put the reference over the lumbar, so you need to scan at least twice to cover T8 or T6.
No. Actually, that is also the misconception of navigation. As long as wherever you scan, be it the reference frame and the place of surgery, as long as both is in reference to the frame, it doesn't matter how far you want to scan. It will still be accurate.
Okay.
Yeah.
Any question? Okay. Okay, please wait, Mike.
Navigation take time to install. Do you have any tip to overcome it?
I think the best way to reduce time in navigation is to pre-plan what you want to do, because the tracker and the scanning of the pre-op CT on table can be done by other people, and you are not necessarily scrubbed in. When you go in, you have already have the navigated burr and you can start your surgery. And the other time is only the post-op intraoperative scan. So that will take some time. But if you have good support, all this will be done without you even inside the OR. Yeah.
Okay. Yeah. How does it take time?
For the one scan is around 40 seconds.
I mean, all those things, all the
for my
time to install.
This is the first time I'm doing thoracic level. For the 3 level I did, it only took 3 hours. Is it a bit too long?
Yeah, okay.
Any more questions?
Can I have a question for everyone? Because of the CT scan and O-arm intraoperative field that may impossible for everyone, you know. I want to know how to identify and locate the lesion, the actual lesion from the experienced professor here. For that in a thoracic spine, how to identify the level. How to identify the level without a CT scan, intraoperative CT scan or O-arm? C-arm, just C-arm. How to locate, how to identify.
The same like you. From the low parts, lumbar, and we can calculate, or you can do.
You mean just level from the lumbar, right? Up until you find the lesion.
Shape, right? Shape of lateral view, the same like you. It's not easy.
And by rib also. By rib also is EP view we can find.
The others?
Like for me, and when we identify the thoracic, maybe when you use the C-arm, mostly like the lateral images, but in many cases in AP C-arm is more helpful because by AP we can identify the level of where start the lumbar and thoracic. So try to use AP C-arm to identify and locate the exact locations. Okay, thank you, Dr. Thank you.
And the next speaker is Dr. Vinod Agarwal from India, who will talk performing thoracolumbar fixation under local anesthesia.
So this is my first attendance in this meeting here, and there is a lovely lectures we heard on endoscopy, and that's why now we are going to see some other part of the spine, which is a percutaneous pedicle screw fixation. All of us do that percutaneous fixation, but here we are looking at, we had a couple of patients in which we could not give full anesthesia, and we had to do the procedure under local anesthesia, which was little new for me because I've been putting pedicle screws for more than 40 years, from 86 till now. And under local was little difficult because these patients were not fit for surgery under any, and we were not given even spinal fitness. So in this situation, this was new to me, and I thought if I can just put this across few points only, because all of us are putting pedicle screws in the spine. And the percutaneous pedicle screw is nothing new, but in case the patient is unfit, in that situation, it becomes difficult when the patient is moving, patient can't be given prone position, and it is always difficult, and we are struggling with time. So how do we cut down the time and make the patient comfortable and do this procedure very quickly? So we had one patient with ischemic heart disease, post-coronary angioplasty. Patient already had a severe aortic stenosis and waiting for valve replacement. And he also had other issues for which we could not do that, and he had an L1 vertebral compression for which vertebroplasty was done, and now he was getting severe back pain and could not get better even after 3 to 4 months. So this is the situation the patient had come to us with the cement in front and unable to sit for more than 4 months. So in this situation, we would certainly fix it, but because the patient was unfit, we had to do under local. These are the pre-op images that we see here. And there's the situation we are heading. Patient had no neurological deficit, so we had to just stabilize the spine in this situation. Here we are seeing few more pictures of the same patient. So anesthesia was not possible in these patients. So under local anesthesia, we decided to do this procedure. Here we use Prelox cream that we use for general surgeons, also use for other surgeries. This is piroxicam with lignocaine jelly, which can be applied 2 hours before the surgery. And this really helps to kill the pain and patient is comfortable. The problem here is the patient is in prone position and is getting all possible sensations. So we have to make the patient a little more numb in that operative area. And how do we decrease the radiation? Because in O-arm, we don't have the O-arm at present, so we were using C-arms only for percutaneous pedicle screw fixation. And we need to improve the speed, decrease the complication, and decrease the radiation also. So this is what we do here. This is the setup in which we use 2 C-arms, one AP and lateral. The AP one goes from the head end of the patient, and the lateral goes from over the top. And that's why you can fix before surgery both the C-arms in perfect position. And if you have 2 surgeons, if possible, then the surgery can get over in 15 to 20 minutes. So here is what we do under C-arm. This is nothing new to say about it. So this is just a small presentation to say, just a minute. So this is what we could achieve in about 20 minutes from surgery under local anesthesia with 2 C-arm technique. So here we don't have to move the C-arm, so the time we can save a lot during surgery. And this we could achieve very quickly in the procedure. So we cannot use a sextant implant here because in the dorsal spine, the convex curve cannot be given. So we use either Globus implants, which have no separate entry. In the literature review, local anesthetic can be given. The combination of local anesthetics and 1% lignocaine and bupivacaine can be done for rapid onset and extended duration. Some nerve blocks have been recommended now, like thoracic paravertebral blocks or thoracolumbar infrafacial plane blocks. This can also be used to give local anesthesia because as the age, we are getting more and more older patients. This is becoming a problem of that we can't give anesthesia for longer time. So the inclusion criteria for these cases were 1 to 2 levels only should be involved. Predictable duration should definitely be less than 1 hour because patient can't lie down for more than that time. A patient should be adult, should not be a pediatric, and he should not be BMI. It cannot be much more because patient has to lie down prone. Patient has to be little compliant, well trained. Assistant should also be there, and you should have one more team if possible. And 2 C-arms are a must for this quick procedure. Thank you very much.
Thank you, Dr. Akawal. Any question or share from the floor?
Why patient cannot get anesthesia? Patients have multiple issues from cardiac, from valve replacements, and so many. How old was the patient? One 43-year-old and one was a 82-year-old. 2 patients we have done.
Any more questions?
I mean, this is just one-off because, I mean, if you do say 200 cases or 300, 250 a year, most of them are under GA. So local was little, we are doing kyphoplasty under local, but this pedicle screws were little, we were also more anxious whether patient can lie down prone, they are already unfit. So how do we save time and make the patient comfortable so he's not moving? So that was the issue. So this was the time that, we are moving the C-arm, so you lose time. So if you have 2 C-arms, 2 people, you can quickly do this procedure. Thank you.
Thank you.
Okay, so next speaker is the last speaker of this session, Dr. Sayın Murat from Turkey. The topic is extreme unique cases for endoscopic spine surgery. Please.
Dear Chairman, dear colleagues, it's a wonderful conference here. I thank the organizers, Akor and Dr. Shumansur, for their kind invitation. It's a great privilege to be here. Okay. Does it go to the screen? Okay. I want to. Okay. I want to talk about some different cases that I'm from Izmir, Turkey. I'm a 100% full endoscopic spine surgery. I do only endoscopic spine surgery more than 5 years. And it's all uniportal. And this was a 56 years old male. He had right arm pain. The VAS was 8 of 10. He had both numbness on hands. The right flexion was 3 to 4, about 5, and the Hoffman test was positive. So surgery was suggested, but he didn't want any anterior surgeries. He was suggested, so he was looking for something new, and he wanted to have an endoscopic surgery. So they came here, and I did a decompression. And during this posterior decompression, you can achieve every corner. You can see anything that you want, but you have to work very meticulously. You can go to the other side. You can see both nerves. You can decompress the lateral recesses, everything. And with one skin incision, with the sliding technique, you can go up and down. It's very useful, and it's really minimal invasive for the patient. And this was also another case that had multiple stenosis there. As you can see, it was nicely decompressed. These are pre-op images on the upper side, and the lower side shows the post-op images. And these are the CT images. You can nicely drill the spinous process. And the final stage in a 3D CT, you can see the nice decompression that can be done with one single incision through that place. And as we saw from our other colleagues, the endoscopic cervical discectomy is a very nicely, you can see everything very closely, and even without touching or doing anything to the nerve, you can nicely decompress everything. And this was a very special case for me. It was a 79-year-old female. She was operated because of breast cancer. The general anesthesia was very risky. The cardiologic, she had arterial diseases. She had a chronic renal failure. She was using steroids, and because of that, she had a very bad osteoporosis. Her DEXA revealed -5. And her neurological examination was bilateral lower limbs were to about 5, and she was bedridden for 2 months, and she was really she had a very painful back. And this was her MRI. As you can see, it was compressing the canal, and we had no other option to do. It was only a local anesthesia surgery. Actually, I didn't think also putting any screws, because as in a -5 DEXA, you cannot put any screws. They will get out. And I performed an endoscopic decompression at the posterior side. And simultaneously, I put some cement inside, and she was independently mobilized in the first week. And this is her 1-year follow-up MRI, and she's still with her brace. She's very happy, no screws. There is still, as you can see, the canal is still narrow, but she feels happy. It's Turkish, so I'll skip her language. And as you can see, The lateral recess decompression is very, very important, as Dr. Lim always says. The central, you have to take care about the lateral recess when you do decompression surgery. And with the full endoscopy, you can see every corner. And as you can see, with one skin incision, even in upper high lumbar levels, we can perform the surgery very easily and usefully. This was also a 57-year-old female. She had an L2 to L5 fusion surgery, and after 10 years, she had an adjacent segment disease, both on the upper and the lower segments. So there was a stenosis there, and she didn't want to have a big surgery anymore, so we performed endoscopic surgery. As you can see, it was nicely decompressed, and she's very happy now. And the extraforaminal part in the L5 phase 1 can be sometimes very challenging. This was a case on the right side. It was looking as a schwannoma. So I planned to make a schwannoma surgery at the L5 phase 1. So I had to drill the L5 facet, as you can see in the right lower part in the post-op. I went there, but it was not a schwannoma. It was a swollen L5 nerve, and it was a big disc causing that pathology. And in this, it's 2 years ago, the follow-up, nothing, no complaints. This was an interesting case again, 75-year-old male. He presented with cauda equina syndrome, what's called in the night. So we made a very, as you can see during the MRI, timing is in the midnight. It was just looking something different. I was curious about, and when we checked out, it was a ligamentum flavum hematoma that occurred. He was lifting weights after weightlifting. He had produced that, and as you can see, when you touched the ligamentum flavum, bleeding came out, and the pathology said also that there was blood vessels, that was ligamentum flavum hematoma. Okay, just skip there. Even in cases that you think that it is unstable, you can very safely use full endoscopy. As we can see, this was a male. He had a very aggressive discectomy 20 years ago, and now he had an adjacent segment disease, and he didn't want to have any big surgery. So we came and we performed an endoscopic surgery again. These were his functional X-rays, and there was a little bit movement, but it was okay. And this was a 37-year-old male. He had bilateral foot drop, and his left leg muscle was about 5. He had both hypostasia in both legs. He was in wheelchair for 2 months, and his EMG said that there was axonal degeneration. And there was a very, as you can see, there is a disc herniation and a central canal stenosis. So it was a double-sided, double-crest syndrome. So I performed, I wanted to go also from the anterior side. I took the disc herniation causing that. And in that place, you can see that there is a disc taken out. And L3, 4, and L4, 5 were also narrow canals. So this was the pre-op, and you see at the right side the post-op image of the L1-2 level. Okay, And this is his CT scans, MRIs, and his skin incisions. This was, it's a L5. She was an obsessive psychological problem. There was right leg pain with urinary urgency problems. As you can see, there is an, sorry. Oh, I cannot show you that. Okay, yes. Okay, there is a mass there at the L5 part. There is an intradural mass that looked like a schwannoma, and she didn't want to have any surgery, so we planned an endoscopically removal. I just opened the dura, and after the dura, just like we do in microsurgery, I wanted to pull one side of the dura up so I can easily take the tumor out between the rootlets. It's 1 minute more. I'm sorry for a late person. In every angle, we just use the same tools as we do it in microsurgery. We just split it, we just check it, but this surgery, I normally don't use any intraoperative neuromonitoring, but for this surgery, we have to use it. It's really risky, and you can just take it out. I'm sorry, it's because it's very clear here, but you don't see it so clear there. The image quality is really better than this. This is not normal. Sorry for that. Okay. And this was the post-op thing. And this is still 1 year follow-up, no problem. I think I have to skip the other one. As you can see, we can also make the dural repairs as well with full endoscopy. We never have to switch to open surgery again. Okay, I'll skip the other ones. Okay, thank you very much for everyone.
Thank you, Dr. Sain. You showed us some breast case of some difficult case. Any question and comment from Flo? Okay.
We immediately can start next session, okay? Because time is going on. Wonderful dinner waiting us. That's why we should immediately start next session.
Thank you.
Dr. Fujito, yeah, you are moderator.
Okay, today's final session is tumors and complications session. First speaker is Dr. Rashid from Malaysia.
Thank you very much. First of all, I would like to say thank you to the organizers, Dr. Shomanso, Dr. Harol, Dr. Lim, for inviting me to this wonderful event. It's very nice to be here with all the great surgeons. Today, the topic is minimizing complications in endoscopic spine surgery. I'm Dr. Zakiri from Malaysia. I do both uniportal and biportal techniques as well as transforaminal and interlaminar approaches. So why the topic is minimizing, I believe that it's impossible to avoid all complications. If you do enough, you will have your complications. So that's the reason why I don't think that we can totally avoid and have zero complications. Okay, I'm coming from Malaysia. This is a beautiful picture of Kuala Lumpur. First of all, is failing to prepare is preparing to fail. We always hear this one. Why I mention this? Because part of the thing that we want to avoid complications is to have a very good preparation. The first one is always comes back to our knowledge. We know that the knowledge for transforaminal approach is different from interlaminar approach. For uniportal, it's different to biportal. So we need to have adequate knowledge for each techniques. And what I cannot emphasize enough is we need to have a good knowledge on reading our MRI. So like this, if we have a big disc, we need to correlate the size of the disc with the size of the disc on the MRI. So when we remove the disc, it should be correlating nicely with the MRI. The second one would be to have adequate preparation for precision surgery. This is like a sniper. So a precision surgery requires a very specific tools, especially for MRI. If you use obviously 0.3 Tesla MRI as compared to 1.5 or 3 Tesla MRI, the image would be different. So we need to have a very clear picture of what is the pathology. So it's better to have at least 1.5 Tesla MRI. The second one would be a camera system. The camera system is our eyes inside. We are very close to the surgical field. So at least we have to use a 4K or HD monitor. I believe that some of us have experience in using very blur monitor in which we can hardly see the edge of the dura. So it will increase the risk of complications if we don't have a proper camera system. And the third one would be a radio frequency probe. This one is very important to use the most recent, most advanced radio frequency probe to reduce the heat-related complications. Obviously, we need to have low versus high voltage choices. Low voltage is better when we are dealing surrounding the nerve structures. We know that the radio frequency probe can cause direct and indirect injuries. I think during the neuromonitoring lectures, we talk about how the heat actually can influence the SSCP reading, even though the paper shows that the increase in heat is only less than 1 degree. Actually, it's minimal, but it's enough to impact our SSCP reading. And the last one would be the irrigation. I think it is by choice. Some use the pump, some use gravity. Either way, it's important to use the irrigation to have a good hemostasis, flushing of the small bleeding, identification of the bleeding source, better identification of microanatomy, and actually it's very helpful in separation of tissue layers by simple irrigations. That's the reason why when we are doing the stenosis case, we always try to have a small area at the phlegm where the fluid can go in and do the separation for us before we go in and remove the phlegm. So it's good to have a good monitor with a very clear picture, with good image identification during the surgery. And then to flatten the steep learning curve also is one of the steps to reduce the complication. Previous exposure actually is very good, especially for transforaminal approach. If you have exposure in needling in percutaneous procedures, it will definitely help to get a good landing point, especially in transforaminal approach. So proper case selection is important, especially when, if let's say interlaminar surgeons want to do transforaminal approaches, so it's important to choose a proper case to gain confidence and to avoid complications. Obviously for L3, L4 and L4, L5 is good for transforaminal approach, L5, S1 is good for interlaminar approach. I believe that each technique has its own advantages and we have to try to minimize the collateral damage for the patients. So if let's say for foraminal disc, if I do it interlaminar approach, of course I can do it by contralateral interlaminar approach to get into the foramen, but that would require more tissue removal as compared to direct foraminal approach using the transforaminal approach. And same goes to, let's say the patient has a lateral recess stenosis, I can do it with transforaminal approach, but I need to remove part of the SCP as well as the pedicle. But if I approach it with the interlaminar approach, it would be easier to have a good lateral recess stenosis decompression. So I give an example of a case, L5S1, recurrent disc prolapse. She had open surgery done previously, and a spacer was put in. You can see that the spacer is there. So if I approach this one with interlaminar approach, it's going to be very difficult because the spacer is blocking my approach. So I approach it. This is the axial view. So I approach it with a transforaminal approach. So this is after the removal of the disc. So this is the post-operative MRI. You can see that the disc is removed nicely, is remodeled nicely. This is the axial view. So the evolution of the techniques in endoscopic approach, I think, is to achieve two targets. One is good and adequate decompression of neural elements. Number two is we try to minimize the collateral damage. So I think that inadequate exposure will always lead to excessive manipulations. Like in this case, we know that for L3, L4 is narrower interlaminar window as compared to L45, L5S1. So obviously we need to have more lateral space before we do the discectomy. So this is the video showing that we have a good space, then we can do the discectomy, do the rotating maneuver to remove the disc. And by having more space laterally, we can avoid manipulation of neural structures. We know that manipulation leads to a lot of complications, leads to paresthesia, leads to adenoiditis. So this is one thing that we have to keep in mind. For specific neural complications of endoscopic spine surgery, number one is dysesthesia. Obviously, this one is more common in transforaminal approach. It's a headache for the surgeon as well as for the patient because it's a different symptoms. So there are papers showing that more postoperative paresthesia and dysesthesia in transforaminal approach as compared to interlaminar approach. How to prevent this? We have to get a good landing point close to the target and a more caudal approach in the foramen. And if need to, we need to do foraminoplasty to have a better foraminal space. For the dura tear, it's more common in interlaminar approach as compared to the transforaminal approach. Upper lumbar levels have a narrower interlaminar space. We have to keep this in mind. And for stenosis cases with calcification especially is more at risk of having dura tear. So there's a paper showing that there are more dura tear in interlaminar as compared to transforaminal approaches. And we have to have a good plan how to handle the dura tear. We can use a gel foam, taco seal, depend on the surgeon's preference. And for a very big tear, more than 1 centimeter, it's either you go for open repair or, in my hands, I can convert to UBE, and then you use a sliding knot like we use in the shoulder surgery to do a repair. So the last one would be the adhesive adenoiditis. I think this one is sometimes is maybe underreported and is mislooked as one of the cause of the failback syndrome. Actually, it can be devastating. It's a very rare complication, but when you have it, actually it's very bad. The risk factor is severe stenosis, spine surgeries, as well as spine epidural injections. As you can see, in some of the patients, they already have the severe stenosis, and then we do the surgery, and then some surgeons actually, after they do the decompression, they put some injections in. So all these are putting patient more at risk of developing adenoiditis. So basically adenoiditis, when we do MRI, we can see the clumping of the roots. So obviously we never want to see this in our patients. So try to avoid manipulation of neural structures, avoid any injections, steroid injections, local injections, if you are in doubt whether there is a dura tear or if the dura is very thin, and to minimize post-operative hematoma. So the last one would be the incomplete decompression or recurrence. I think this one is also a headache, so be careful in the large fragments, need to remove extruded as well as intradiscal part. Sometimes when we are misinterpreting the MRI, actually we do only the paracentral disc removal when there is also the foraminal disc as well as lateral recess stenosis. So this one is something that we have to keep in mind. I think one of the things that maybe we as endoscopic surgeons are guilty of is maybe we tend to do quite a big annular defect, especially in cases when there is no obvious annular rent. So maybe we cut the annulus a bit too much. Sometimes in under endoscopy, the tendency is there to cut the annulus a bit too much. So we have to keep in mind that large annular defect, more than 6 mm, is associated with higher risk of recurrence. So definitely we need to minimize the annulotomy during our discectomy. If possible, we try to find the annular rent, not to create another weak point at the annulus. So we, if possible, try to remove the disc through the original annular rent. And there is no consensus on annular repair. I know that there are quite a lot of studies on how to repair the annulus, but until now, there is no consensus on annular repair, so it's better not to have a very weak annular defect to prevent recurrence in our patients. With that, for the conclusion, it's almost impossible to avoid all complications. If we do enough, we will have complications. We cannot run from statistics. Even if the complication is 0.5%, if you do 1,000 cases, you are bound to have complications. So knowing how to minimize and manage complications is an important skill set for endoscopic spine surgeons. So we have to say that proper planning and preparations and improvement in our surgical skills are essential to avoid complications. With that, I thank you.
Thank you for a nice presentation.
We would like to call next speaker, Dr. Oscar Selükür from Turkey. Topic is surgical approach to full endoscopic spinal tumors.
Good afternoon, dear President and colleagues. First of all, I would like to thanks to organizing committee for inviting me to this presentation. Dear participants, welcome all of you. The subject of my presentation is full endoscopic surgical approach to spinal tumors, separation surgery. 53 years old male patient, back pain, fever, night sweats, weight loss, complaints started 2 months ago. He started having difficulty walking for the last week and developed weakness in his legs. He couldn't stand up without support. Extradural tumor case, a tumor that involves the T7 vertebral body and compresses the spinal cord from the extradural space. You can see the tumor location on sagittal opaque MRI. In this coronal MRI, you can see specifically how much the spinal cord is compressed. You can see that the extradural tumor pressure is on the right side in axial MRI sections. In the hospital where I work, we first take this type of cancer patients to the oncology consult. Treatment is planned according to the results. In this patient, it was decided that he would receive surgery, separation surgery, and then radiotherapy or chemotherapy according to the pathology results. This site is cranial and midline and caudal and lateral. Bone decompression is performed from the lamina with the help of kerosene. You will watch the separation surgery in this approximately 3-minute video, this video. This is an extradural tumor that you see. I'm trying to reach the border of the neural tissue carefully. Look, deep in the middle, this spinal cord has started to appear. Decompress the spinal cord by cleaning the tumors tissue one by one. Look here, the T7 right root is visible. And finally, the spinal cord is observed to be relaxed. After the separation surgery was completed, vertebroplasty was performed on the T7 corpus. In order to provide column support from the anterior, intensive filling was applied especially to the anterior part of the corpus. And all this can be done through a single 0.5 centimeter incision. Why is it important for the one to be small? Because these patients are not the primary patients of the neurosurgery or orthopedics department. Low risk of infection, and these patients should be quickly referred to the oncology, hematology, or radiation oncology. In these axial MRI images, decompression of the spinal cord and passage of CSF are observed. Pathology result, diffuse large B-cell lymphoma. These MRIs are from the patient's 1 year later checkups. The patient is now completely cured. In this MRI, it was observed that the patient's T7 vertebra didn't collapse and the patient didn't go to sagittal kyphosis. Thank you.
Thank you for nice presentation. Next speaker is Dr. Baykar from Turkey. Spinal fluid endoscopic extremes cases.
Yes, good afternoon, dear President and colleagues. First of all, I would like to thank the organizing committee for inviting me such a good organization. Okay. Extreme cases. First case, a gunshot. In this case, a pellet locked in the entrance of the left foramen C5. As we can see on the CT scan. Here, near the C5 foramen, coronal view, we can see the bullet. The patient was intact, no neurological deficit. This is our surgical video. You can see the bullet here, spinal cord here, and posterior approach. Our small foraminectomy window here, and we took out the bullet without any neurologic deficit. This is our post-op CT scan here. Our small window is here. And second case, this patient was brought to emergency room, 70-year-old patient. This patient was stroke, so they gave the neurologist gave a blood thinning treatment, and after the treatment, the patient got worsened, and they took a cervical MRI, and then epidural hematoma was occurred after the blood thinning treatment. So early stage, we took her to endoscopic surgery because new treatment, new blood thinning treatment, so open surgery will be more dangerous. Posterior approach with unilateral endoscopy. This is phloem. I'm skipping here. We are taking the phloem with angled scissors. The hematoma cavity was just under the phloem. C5 lamina decompressed. And just here the hematoma cavity will appear. We rise up the phloem. By the pressure of the water, the hematoma will also come out. Here you see the hematoma is coming out. And more decompression was performed, and the hematoma was totally evacuated. This is the final view, spinal cord here, no hematoma. Post-op CT, our small window, post-op MRI, no hematoma on post-op MRI. And the patient started walking after approximately 3 hours of the surgery. And another case, again a gunshot, 30-year-old male patient. It's the gun, the bullet was entered from the nose and up to C2 right, near right the foramen, and the spinal cord was also intact, no neurological deficit. So we decided to take out the bullet via fully endoscopic approach. We also published this case. And this is the surgical video, posterior approach. Again, we easily reached the bullet. This is 9 millimeters, so we drilled the bullet to take out because of the tube diameter was not suitable for this, and with diamond drill we drilled the bullet. Also for holding with forceps, we drilled it, and then as you see with holding the punch and take out all the system and the bullet outside. This is the final view of the bullet cavity. Spinal cord is here intact. No neurological deficit also. This is the previous case, Dr. Özkan. And also in first presentations, even if listhesis in listhesis patients also can be performed in fully endoscopic surgeries. Dynamic X-ray, no instability. We performed fully endoscopic approach also. And this patient has a small protrusion, but 3 months conservative treatment, no pain control. So we decided fully endoscopic surgery. This is L5 root, but another root is also on the medial part of the L5 root. there is a root anomaly here, and a small piece, disc piece, will also come from the lateral of the lateral root. You see here two roots, this one and this one. Yes, the disc will come from here, a small piece. This is also root. Yes, a small piece here. And this root and this root, parallel, two roots. And an interesting case, again, also. Here, we first thought that it's a black disc, and here on CT looks like black disc. So we decided fully endoscopic approach, and it was not a black disc, it was a gas. You see here bubbles. Yes, bubbles are coming also again. And post-op MRI, no gas. Another patient after this operation, 2 or 3 months later, similar patient again came. So we said, yes, this is gas. And again, endoscopic, fully endoscopic approach. Here we will see the bubbles again. You see the bubbles here. Just we opened the phloem and then bubbles came out. And thank you.
Thank you, nice presentation. If anybody has question after finishing this session, we'll discuss, okay? I kindly invite the next speaker. Dr. Molvi Abdul Basit from India. Topic is discites and its management.
Good evening, respected chairpersons, my dear friends and colleagues. I'm thankful to the organizing committee for inviting me to discuss on this topic. My topic is post-operative discitis, which is a nightmare for any spine surgeon. It's not nightmare because you cannot handle it. It's nightmare because patient eats your brain whenever he suffers from such type of complication. So post-operative discitis is a significant complication after spine surgery. It accounts for around 20 to 30% of pyogenic spondylodiscitis cases. It can be easily misdiagnosed due to its vague symptoms. Most commonly occurs after lumbar discectomy procedures, and when this happens, it usually delays recovery, increases healthcare costs, may cause chronic pain and disability. Its incidence is around 0.2 to 2.7% depending on procedure and risk factors, and infection rate is less than 1%, but can increase to 6.2% with fusion. And most common organism is Staphylococcus aureus, and other gram-negative organisms like E. coli, Pseudomonas are there. So when we talk of post-operative discitis, it's usually due to direct inoculation during the surgery, and it can be due to hematogenous spread, which is rare, or it can be due to contiguous spread from the adjacent tissues. And if there is biofilm formation on the spinal implants, then it complicates the problem, and there will be a lot of difficulty to treat such cases. So what are the risk factors? Usually we divide them on the basis of patient-related, which are like diabetes, immunocompromised patients, obesity, malnutrition. Procedure-related, like repeated spinal procedures, prolonged operative time, contaminated instruments. and hospital-related risk factors, which are breaks in sterile techniques, poor infection control and practices. So the clinical manifestations can be divided into early onset and delayed onset symptoms. The early onset symptoms are severe back pain, muscle spasms, fever. Sometimes there can be wound drainage, and systemic symptoms like malaise, weight loss, and night sweats. Delayed onset symptoms often appear after 2 to 4 weeks post-surgery. There can be some neurological symptoms, but they are rare, and if included, they may be like radiculopathy, myelopathy in advanced cases. So what is the differential diagnosis that we should keep in mind? It can be these type of symptoms, which are more often same as discitis, can be due to recurrent disc herniation, epidural hematoma or abscess, non-infectious or inflammatory conditions like spondyloarthropathies. So what are the investigations that we should do initially when the patient who has been operated and he comes back after relief of some time and comes back with pain? We should directly go for blood tests. We should do CRP and ESR. It usually comes elevated. White blood cell count may be or may not be elevated, and then we can go for microbiological tests like blood cultures and CD-guided biopsy. Best is to go for the endoscopic biopsy if you don't want too many radiations. So after blood test, you should go for radiological investigations. X-rays is the most common and important investigation, but you will not find anything if duration of symptoms is less than 2 weeks. You can find some things in X-ray if it's more than 2 to 4 weeks. Look for disc space narrowing, vertebral end plate irregularities. You can go for CT scan. It will help you to see any abscess, or you can detect the bony destruction early in CT scan. Gold standard is the MRI with contrast. So this is the lateral radiograph of a patient who had a recurrent backache and leg pain 3 weeks after percutaneous lumbar discectomy. You will see there are no early changes in this X-ray, but you will see this in same patient at 4 to 6 weeks. You will see destruction at L3, L4 level, and prevertebral soft tissue shadows will be visible. And if there was implant, you will see also the lysis around the implants. This is the CT of the same patient. You will see bone destruction. This is MRI of another patient which shows the discitis at L4, L5 level. You can note the increased signal intensity of the end plates and disc on T2-weighted images. So we should go for biopsy and microbiological tests. CT-guided biopsy is good, but you can go for endoscopic biopsy. That will help in both treatment, and you will get the material for the biopsy. Indicated if MRI findings are inconclusive, and it confirms the bacterial etiology, which is most commonly Staphylococcus aureus or gram-negative bacteria. Intraoperative biopsy can be done. It's used in surgical cases where conservative management fails. It's essential for culture and sensitivity testing, and implant sonication is helpful. It detects the biofilm infections, and if there is biofilm, you can use the implant sonication. So what is the step-by-step guide that how we should manage it? First step, if patient comes with back pain and fever post-surgery, order for CRP, ESR, and WBC. Second step is if CRP is elevated, ESR is MRI with contrast should be done. If MRI confirms discitis and spondylosis, go for blood cultures. If culture is negative, CT-guided biopsy for definitive diagnosis, or you can do endoscopic biopsy. Treatment is planned based on the findings. It can be conservative, it can be surgical. So prevention, how to prevent it? We should do patient optimization. We should screen and treat infections before surgery. Intraoperative aseptic techniques should be used. Limit OR time, and prophylactic antibiotics should be given. Post-operative, we should do vigilant monitoring. Early recognition of infective signs should be done. And treatment, if patient presents early, we should opt for conservative approach. We usually start with empirical antibiotics for 4 to 6 weeks IV, and we can, after the patient is getting relief, we can shift to oral antibiotics. Bracing if spinal stability is intact, and pain management and physiotherapy is important. So if there is abscess, instability, or neurological deficits, then we should go for surgery. We can do debridement, drainage, and surgery can be open or endoscopic. Drainage should be done if it's more than 2.5 centimeters. Fusion and instrumentation in severe case of instability should be done, but personally, I even do it for those patients who are not responding to conservative treatment or who are having severe pain. I go for endoscopic fusion in such patients. So vacuum-assisted dressing can also be used. So in antibiotic therapy, you can, when patient comes to you, you can directly start with empirical antibiotics, like you can use, you can cover gram-positive, gram-negative by giving vancomycin and ceftriaxone, and gram-negative by by metronidazole. And if you have culture-specific, then you can use vancomycin and linezolid or meropenem or ciprofloxacin. Duration is around 4 to 6 weeks for IV antibiotics, and for oral antibiotics 6 to 12 weeks. Monitor CRP, ESR for response. Treatment duration should be minimally for 6 weeks for IV antibiotics. This is very important. Physio and rehab protocol is in acute phase, strict bed rest for severe cases with instability, bracing for spinal immobilization. In subacute phase, that is 6 to 12 weeks, gradual mobilization with physiotherapy, core strengthening, posture correction exercises. And in chronic phase, that is more than 3 months, return to normal activity, avoid high impact movements for 6 to 12 months. So now, whether we should go for open or endoscopic. I usually prefer endoscopic, but open is also required in some cases. If a lot of tissue planes are involved, if the abscess is too big, then you should go for open. But endoscopic should be performed with minimal incisions, effective for small abscesses and localized infections, and lower post-operative infection rates are seen with endoscopic procedures. These are some of the we should go for usually minimal invasive procedures if there is no abscess, and if a patient. These are some of the cases in which the open procedures have been done, open debridement, then help of plastic surgeons was taken. And endoscopic treatment for post-operative discitis is better because it's minimally invasive technique. Benefits of endoscopic surgery: it's less muscle damage and scarring, faster recovery and reduced hospital stay, lower risk of post-operative complications. And these are just the comparative chart for this. And follow-up and prognosis assessment is very important. Pain improvement and absence of neurological symptoms should be seen. Biochemical markers like CRP should be normalized in 6 to 12 weeks. Persistent elevation suggests ongoing infection. And radiological monitoring should be done. MRI at 3 months to assess resolution of infection. Dynamic X-rays if instability is suspected. And 80 to 90% success rate is with early intervention. Delayed or inadequate treatment may lead to chronic pain, deformity, or neurological damage. I'll just discuss these two cases. This is a case of a patient operated with microdiscectomy, L4, L5 post-operative discitis was there. We did endoscopic debridement and fusion. You can see the patient was not able to sit on the wheelchair even. It was very difficult. This is immediate post-op. Patient is walking comfortably. This is another case of L5S1 discectomy was done somewhere else, and patient came to my hospital after 3 months. She was not responding to conservative treatment. We did endoscopic decompression. You can see this. We did debridement of the L5S1 disc. You will see a lot of granulation tissue and a lot of infective tissue coming out. You'll see the pus coming out of this disc segment. And we debrided it thoroughly, cleaned it, and also you can see the pus coming out of the disc space. And after proper debridement and thorough debridement, we put the expandable cage and fixed it. And this was the post-op video of the same patient. Initially, she was not able to walk. She was in severe pain. This is immediate after 12 to 24 hours post-surgery, she was able to walk. So I'll conclude my talk with these few points, that in case of discitis, early diagnosis is crucial. conservative treatment is effective in most cases. Surgery is reserved for severe infections and stability. But if patient is having severe pain, is not responding to conservative therapy, one should go for surgery. This is my paper on incidence of discitis and endoscopic spine surgery. If you have any questions, you can ask. Thank you.
Thank you, Doctor. Nice presentation. Okay, next speaker is
Hello. This is a nice presentation. One question. What endoscope do you use? Only one endoscope, primary surgery, and infection surgery, or different?
I have around 5 scopes with me. I usually when I go for debridement, I usually transforaminal scope for these surgeries. So I have 2 transforaminal scopes. I usually use one of them. But I can understand your questions. You are saying you are using same in another case. We do proper sterilization of equipment, and there is no problem using it again.
Thank you.
Thank you, Doctor.
Thank you.
Next speaker is Dr. Ramadasan from India. Talk about spondylodiscitis following for endoscopic discectomy.
Завелся у тебя?
Thank you, everybody. I am Dr. Sridhar Ramadasu. I have been a student of Dr. Lim. Earlier to endoscopic introduction, I was doing very less number of open spine surgery cases. After 2023, I have been converting all the lumbar spine cases into endoscopic only. This is my first complication. This is my first discitis case following lumbar discectomy. So this, I considered it as a failure. I'll tell you why down the line. The principles of management has already been discussed by the earlier speaker, so I'll be rushing through the slides. So when disc prolapse isn't just a disc prolapse. So a typical presentation of spondylodiscitis in a 51-year-old male, actually he came to me in July 2024. His complaints were right-sided list and right-sided sciatica. His SLR was positive, and there was a history of steroid injection 1 month prior to clinical presentation in the clinic, and clinical diagnosis was a right-sided herniated disc. The same was confirmed in the MRI. The standard operative procedure PSLD was performed from the right approach. Disc material actually extracted, but I did not send the specimen for HPE. That was my mistake. Post-operative, immediately patient had pain improvement, but his list continued. This was the initial presentation. Right-sided list. The initial MRI showed right-sided massive disc at L5S1 level. So it looks as if it is innocent, so I just did the discectomy only. So again the patient came back to me in January, new symptoms, difficulty in lying on the back. I did the MRI again. This time it showed end plate changes and features suggestive of spondylodiscitis. Plan was to drain endoscopically or open debridement. Initially attempt was made to do endoscopic drainage, but due to bleeding I converted into open drainage, and the material was sent to culture. This time the culture became negative. So since there was no organism identified, I gave only 2 weeks of broad spectrum IV antibiotics, and the patient noted initial improvement, but it was not complete relief, but he could sleep. Okay, so that was the end point, but still I followed up the patient because he kept coming back. Mild dysfunction was there. So this is the MRI second time. The L5S1 level shows changes suggestive of spondylodiscitis. So open debridement was done. So this is again a complication, suture line abscess. That is what I felt. Then the timeline was 6 weeks post debridement. Suspected vicral abscess, vicral tag was there, so I removed the vicral tag, and no antibiotics were given because I felt it was a vicral abscess. So and patient did not have much symptoms. So advice was to return to the clinic if symptoms recurred. So again the pus came. This time it was on the lower aspect, frank purulent pus. 1 week later, after the 6 weeks of presentation, this time I sent the culture, I sent the collection for all investigations, including ZN stain, gram stain, KOH, extended culture, and CBNAT also. The CBNAT became CBNAT was negative, and in ZN stain, paucibacillary AFB was noted, and this was a clinical picture. And this is the microscopic picture. If you can see, there is a live AFB. So based on this, I immediately started the patient on ATT. Patient started improving. 1 month down the line, patient came back with the features of instability. So patient had pain radiating on the left lower limb whenever he is trying to walk. So 1 month following ATT, patient, right side difficulty again. So post-infective instability was the diagnosis. So what are the constraints were, his daughter's marriage was arranged in just 2 months. So I decided with the patient and told him that it is best to fix the spine. So the same was executed. Open debridement with fusion and autologous bone graft was done. I did not put the cage because of the fear of flaring up of the infection. So this was the bone graft, and this is the fixation. So the HPE which I sent actually confirms resolving granulomas. This was taken on just 3 days before. So epithelialized giant cells with caseating material is seen. So histopathology says feature suggestive of granulomatous inflammatory lesion, but no organisms were seen again. So this was a case of missed tuberculosis on my part. There were 2 papers which I will be discussing why you have to consider. I consider it as a failure because I did not send the material which I extracted from the patient body for HPE. So this was a failure of my case. So after that I have been sending all the patient's material which I extract from the patient's body for histopathological examination, and including KOH mount, all the gram stain, culture, extended culture too. So what is spondylodiscitis? Infection of vertebral intervertebral disc plus or minus adjacent vertebra, rare but serious complication post spine surgery, presents with persistent recurrent back pain with systemic signs plus or minus. So what are the risks of spondylodiscitis after surgery is any breach in the sterile technique, prior epidural steroid injections, diabetes and other immunocompromised status, prolonged operative time, inadequate post-operative care, and missed tuberculosis in my case. So traditional transfemoral approach has a longer route and you cannot change the direction. What happens in this case is we are directly invading the annulus. There is no blood vessel in the annulus because it is relatively avascular. Any organism gets lodged into the avascular spaces. That is why transfemoral approach has got more chance of infection than the direct posterior interlaminar approach. So I follow, for foraminal compressions, I follow para-PSLD taught by Dr. Lim. It's just going just lateral to the lamina and going into the foraminal space. It has got narrow, lesser depth of the scope and lesser chance of infection. So why foraminal approach has got higher chance of infection is frequent annular disruption, long skin folds incision, and irrigation is often limited, exposure to the flora is more, and visibility and control is often limited to direct compared to direct posterior approach. So, and sometimes we do miss what we call it as modic changes. So nobody actually, at least me, I don't see the seriousness of the modic changes in the preoperative MRIs. There are 3 types of modic changes defined. Modic type 1, it is because of the edema, and pain can be because of this modic change itself. It indicates early inflammatory changes and sometimes infection. So how does it seen is both in T1 it is hypointense and T2 it is hyperintense. So type 2 modic change is fatty replacement because of the chronic degeneration. It is hyperintense in both T1 and T2. In type 3 modic change, there will be sclerosis. It is a late stage change in the preoperative MRIs. It is both. It is darker in both T1 and T2 images. So modic type 1 should alert you in the preoperative MRI itself. There might be some infection process going on. So coming to tuberculosis as a differential diagnosis. So there were 12 out of 87 failed back surgeries had tuberculosis origin. Patients presented as disc herniation with no initial infection signs, relapsed in 4 to 6 weeks, and diagnosed via CT-guided biopsy, treated successfully with bracing and ATT. This was the paper presented by Pandey et al. In Spinal Cord 1996. So this was the base of our presentation today. And also in 2021, there was a case of postoperative tubercular spondylitis following microdiscectomy for lumbar disc herniation presented from Korea. So this patient also had hepatitis B positivity and underwent L4, L5 microdiscectomy. Right side is the picture of the postoperative MRI, shows collection in the posterior aspect. And initial RT-PCR and MTB were negative. Biopsy revealed granulomatous TB, and this was the case. So even if no infection is suspected, it is better to send the material which you extract from the patient's body for all the infective parameter tests. So management and outcome, laminectomy and abscess drainage performed, started on antitubercular therapy, and markers were monitored, and the same was continued for 11 months. So coming to diagnostic red flags after endoscopic spine surgery, pain recurrence after initial reliefs, night sweats, weight loss, and rise in the inflammatory markers, and radiological findings, disc space narrowing, end plate erosion, and granulomatous features in HPE. So how to approach? Always do HPE of the material, gram stain, Zn stain, including KOH mount and culture, and sometimes consider extended culture also. Because this case, I had to open and fix after what I felt was a very, very effective endoscopic spine surgery. It turned out to be a disaster in my practice. So that is why I am presenting here this. So management principles, if you are suspecting tuberculosis, start ATT immediately and monitor inflammatory markers. And infection in spine can be controlled effectively after fixation. Do not worry about fixation of the spine. Implantation of cages should be avoided for the avascular disc space. Key takeaways, always consider spondyloid discitis in postoperative pain. Modic changes can be the clues in preoperative MRIs. Don't miss tuberculosis as a differential. Biopsy before blame. Risk stratify the patients with prior epidural steroid injections and comorbidities. These are my references. Thank you.
Yeah.
No.
I don't remember any paper, but I have seen a case when I went to Dr. Lim. He had a case of prior epidural steroid injection, and which turned out to be
that can cause, but you cannot blame approach. Problem was you do not send your disc material for every disc material should be sent for biopsy, whether it is simple disc herniation. And one more thing, you said that cage should not be put. I always put cage if in discitis, and if it's tubercular discitis, you should definitely put cage because you want to give anterior support. Usually there can be deformity.
Sir,
anterior.
that is true,
Yes.
but the biopsy, the confirmation of a granulomatous lesion I received on April 28th.
Even in hematogenous, if it is pyogenic spondylodiscitis post surgery, you can debride it completely and put the cage.
Yeah, I agree with the complete debridement part. That is why I have a less threshold for infection cases for open debridement. But for infection, I do not consider cages. Thank you.
Hello. My question is, on the basis of one case, you are suggesting to send all the tissues, all the microdiscectomy we do for the culture sensitivity and all the tests.
Yes.
Is it not too much?
No, it is not too much, because if you miss a diagnosis, so you are looking at a long-term complication for the patient. See, when we are discussing cases here, that time we will be discussing statistics. But when it comes to the patient, it will be all or none phenomenon. So instead of taking a complicated route, it is better to send and confirm negativity, because in our country, ruling out an infection costs less than $100. So it is always better to rule out infection than to retrospectively confirm and manage the complications. So that is why I am telling this.
Are you suggesting to send for histopathology as well?
Yes, yes, yes. So always consider. Initially, in our practice, we will have a lot of time, but once the patient grows, so we will miss a lot of basic principles. So whenever you extract a material from the patient body, always investigate for the pathology completely. That is always a better route.
But is it not better to risk stratify patient rather than sending so many samples
See,
for histopathology to increase the workload for the histopathologists?
No, even today, even in the advanced countries, histopathology will be the gold standard for all the diagnosis. The final diagnosis combines clinical, radiological as well as histopathology. Without histopathology, you will not be able to produce credible papers also. So it is always important to consider histopathological diagnosis. Yes.
Yes, there was my question. How much did the audience? Do everybody take? Yeah, you too. Hold it, all the audience, please. Do you send this material to histopathology?
Not before.
Who is sending?
I send every.
Okay.
I send every, because in India,
Okay.
tuberculosis is endemic.
Okay, yeah.
Not just
it's
India.
Because of your country, I guess.
No, 2021 in Korean paper also has come tuberculosis. So it's like, I'll tell you, advanced Western economies have been facing problem of drug abuse also. There are becoming immunocompromised. The infective things are actually recurring. So it is better to send and get a negative report than to deal with a complication. So this is my complication that I am presenting, because I want everybody to understand the complications are always worse than getting a negative report in an HPE. Thank you.
Thank you. And the last speaker, I would like Dr. Bradzinski from United Arab Emirates.
Thank you so much. I think everybody are very right now tired, so I would like to be fast with my presentation. I want to present transforaminal epiduroscopic laser annuloplasty. It's a very easy technique, and I hope it will make your life very easy in the clinic, because majority of the patients we have with discogenic back pain, this is the name of the hospital I'm practicing recently in Dubai. This is the pathology of discogenic low back pain. As you can see, there is usually formation of this granulation which makes inflammation inside spinal canal between the dural sac and the posterior annulus, and also we have the receptors in the posterolateral annulus. This is why the sinovertebral nerve are also irritated. If we do discogram, it's usually those patients are grades 3, 5 for the discogenic low back pain who had to be treated interventionally. And this is what we can see on MRI. We can see this high intense on this granulation tissue in the posterior annulus and the dural sac, causing severe inflammation inside spinal canal. We refer those patients for physio, chiro, caudal block, lumbar epidural, combination, all of it. But unfortunately, usually are nice people with this discogenic low back pain. And as we know, the response for those kind of treatment is not very satisfying for them. We spoke also before about the modic changes presented for infection, but also remember we have to differentiate those people with ischemogenic low back pain with vertebrogenic back pain when the end plate is this rupture, and usually sometimes we need to do both procedure, this annuloplasty and this basivertebral nerve ablation, which we do transpedicularly if you have patient with suspected vertebrogenic back pain and annulogenic back pain. So I'll be talking about percutaneous endoscopic assisted extradiscal annuloplasty. This is a very easy technique. All of you are very well trained for transforaminal approach, but we can also perform this procedure transforaminally, interlaminary for epidural, for transsacral as a flexible lumbar endoscopy, but 90% cases we are performing by transforaminal approach. As you know, anatomically, sometimes to reach the intervertebral neuroforamen is not so easy, and for this procedure, I'll show you the instruments which we are using, making very easy access to anterior epidural space, because usually this granulation tissue, as we can see on the MRI, located in the posterior annulus. So if we use the curved endoscope, and I'll show you the construct of this endoscope, we can very easily reach completely, totally anterior epidural space. And this technique allows us to perform epiduroplasty, it performs us to perform nucleoplasty, annuloplasty. If you have herniated disc, you can also remove. So all of the pathology we can address, including annuloplasty, nucleoplasty for contained, not contained disc with ischemogenic low back pain. And this is ultra minimally invasive technique you can perform even as an outpatient clinic, IV sedation. Sometimes because of the insurance issue, we have to keep the patient one night if we need to do it in general anesthesia, always using for the legal issue intraoperative neuromonitoring. So this is the approach when we are using the rigid endoscope, and you can see how nicely we can approach anterior epidural space if we are using the curved endoscope. And as I said, you can do everything, all of the procedures by this technique: foraminoplasty, foraminotomy, discectomy, annuloplasty. So everything is in your hand by ultra minimally invasive approach and ultra minimally invasive in terms of the anesthesia technique. If you compare the conventional endoscope with this minimally invasive, you can see the diameter is less than 4 millimeters. So the really it's ultra minimally invasive. The surgical trauma is very minimum. For some patients, you can even do with maybe not local anesthesia. If you have patients with high risk, you cannot do sedation, but very light IV sedation is only needed. So comparing again the conventional endoscope and this Lutronic Korean endoscope for annuloplasty, you can see the difference. There is a very small diameter, making very minimum surgical trauma. We started this technique in 2016. I was trained by my colleague in the US and South Korea, where this procedure, I believe, is very popular for patients with annulogenic ischemogenic back pain. This is the endoscope before the surgery, but during the procedure, we are making curvation. So every endoscope, we adjust to the patient anatomy. There is not like a one using for everybody. Each patient has different anatomy. This is why we are making this curvation of the tip of the endoscope related to the patient's anatomy. Try to adjust for anterior epidural space to reach anterior epidural space. This is how we are approaching anterior epidural space by this endoscope. You can see it's curved in the end. This is why using the transforaminal rigid technique, you cannot approach so nicely anterior epidural space like using this curved endoscope, which is very minimum diameter. The setup is very easy. It's only a few elements, as you can see, and you can perform this technique absolutely like an outpatient in IV sedation. The skin incision is very typical, like for any transforaminal approach. If you utilize Maxmore, Joy Max, specifically we are using Sebastian Rutten approach, which is like Richard Wolf. We are more far lateral to reach epidural space as much as possible to place the endoscope in the anterior epidural space. The step-by-step technique is very easy. It's absolutely same like for transforaminal endoscopy. We place the needle, we place key wire, we place the TOFI needle based on guide wire, and in the end we place the endoscope. We are running out of time, so this is why I will not describe the technique, but this is absolutely same what we are doing for transforaminal approach, maybe more Richard Wolf technique than JMAX, because no need to drill the superior articular process, SAP. And in the end we introduce the endoscope through dilatator. We do epidurography, we make annulus also irritation. This is a step-by-step, as you can see. This is typical transforaminal approach. The only one difference is that endoscope is curved and the diameter of endoscope is very small. This is why the surgical trauma is very minimum. So I'll show you right now some cases. We can perform a typical annuloplasty, we can perform discectomy, we can perform for the contained herniated disc only nucleoplasty. This is what we can see using the endoscope with the minimal laser penetration to the sinovertebral nerve in the annulus. So the vision is very similar like for the traditional transforaminal endoscopy. As you can see here, I presented some cases with discectomy, annuloplasty, nucleoplasty. So all of the techniques you want to utilize, you can perform starting from annuloplasty. Even if you have the herniated disc inside spinal canal, you can remove like by traditional transforaminal interlaminar approach. Here you can see some cases patients did before I did this intradiscal electrothermal therapy with persistent back pain with its Stella, and from VAS 8, visual analog scale pain 8, he reduced pain after 12 weeks to 1.5. Before we did also caudal block lumbar epidural, he didn't respond for long-term chiro treatment and physiotherapy. Another case with the Tela plus annulotomy, and also patient decreased from VAS 7 to 2 within a month. There is a case with contained herniation, so we did additionally to Tela nucleoplasty. As you can see from VAS almost 7, the response were 0.8. You can also perform this procedure for patients with truly herniated discs. As here you can see there is some upward migrated nucleus, so you can perform annuloplasty after performing discectomy, transforaminal discectomy, and you can perform this annuloplasty. We spoke about closing the annular defect. We were using barricade before. Honestly speaking, the results are not very promising, but using this laser annuloplasty, I'm observing that the healing the annulus after this procedure and the patient's clinical response is much better than using barricade. Another case you can see it's a DDD with herniated disc, some started modic changes. We did annuloplasty and we did additionally removal of the disc transforaminal at the level L4-5 on the right side. The response of the patient was very promising after 6 weeks. There is another case also. We perform this transforaminal epiduroscopic laser annuloplasty and the discectomy, endoscopic discectomy. So you can see the combination of this technique performing both same time is absolutely possible, but the surgical trauma again is very minimum. Another case, we performed Tela annulotomy at the level 4-5. The VAS score was from 8 to 3 within 2 weeks. So the quality of life of those patients improved dramatically. You know, this is usually the young people, as you can see, they don't want to stay at the hospital a long time. They would like to come back to the physical activity as soon as possible. Another case with the chronic back pain and left-sided leg pain, it was also adherolysis. It was the discal pseudocyst with adhesis. We spoke about arachnoiditis. So also for those kind of patients, if you don't want to do flexible lumbar endoscopy, epiduroscopy, if the herniation, if the pathology is at the high level, you can also perform instead of epiduroscopy. And there is another patient with we performed adherolysis. It was 1 year after nucleoplasty. The result was quite promising. The patient improved. It took a little bit longer time because it was failed back surgery syndrome, but we decided to do this one instead of epiduroscopy. You can utilize also this technique not only transforaminal, you can perform interlaminar, especially at the level of 5S1, where do we have the wide interlaminar window. This is the case, L5S1, as you can see. At the level 5S1 herniated disc on the right side, so you can perform normal interlaminar approach for discectomy and annuloplasty same time. In summary, I want to say that this is a very easy technique, especially for the surgeons who are experienced and familiar with the transforaminal interlaminar approach. You can very easily adapt this technique. Surgical trauma is minimum. You can perform for the patients only in IV sedation if there is any cardiological issue. So in the end, I think it's very promising. Probably needs a little bit more literature because except South Korea, in the US, I'm not sure if in other places this technique is popular. And in the end, I would like to thank you, my colleague, Dr. Lee, who trained me for this technique. And thank you so much once again for inviting me and giving me a chance to be with you today. Спасибо большое. Thank you.
Thank you. Any question? Very nice talk because annular artery is very common. And do you do an epidural injection or all annular artery do you do is annuloplasty?
You know, in the place where I work, we are running FDA policy, so we have to do. We do depends on the pathology of the schizophrenic back pain, interlaminar or caudal block. Before making this procedure, always we try to do this lumbar epidural, like interlaminar approach or caudal block. We do steroid injection before, non-crystallic steroids, dexamethasone mainly.
Okay, second question. Do you do annuloplasty one time or re-annuloplasty also have you done?
Usually, you know, for those cases, if you perform proper annuloplasty and this laser penetration is less than 1 millimeter, honestly speaking, you make a very nice denervation, the sinovertebral nerve. 85–90% of cases only one time, if it's done properly. If you performing this procedure use proper time, you're not in a hurry, then only one time it's absolutely enough. This is my observation. But of course, in terms of the patient selection, and I observe right now that this technique seems to be very effective for non-smokers. As you know, the smoking making disaster in the blood vessels in the end plate, the disc is avascular. Yes, so I'm observing that more than 90% patients, non-smoker, they respond very well for this technique. Unfortunately, for smokers, it will take some longer time, and like 25–30% of the patients are not responding so good like for non-smokers.
Okay, thank you. Any question?
Is your endoscope optic-based or electronic-based? It's a digital endoscope or optic endoscope, since you can bend. And it's a single use, or if you reuse it?
It's a single use. We use the Lutronic, the South Korean endoscope. It's a single use, and you can use it. We adjust to the patient anatomy, so it's only single use.
Okay.
Okay, thank you. Nice talk.
Thank you.
And we are closing last session. For closing talk, I would like to invite Dr. Lim of the day. Dr. Lim, come.
Okay, thank you so much. The good presentation, the lecture. It was the most of the speakers are very excellent. So very informative for us teaching and learning each other is very important. The role in the conference. Okay, let's wrap up today, and we'll move to dinner.
Yeah.
Yes.
Dinner is ready. Car is
You must be
also
hungry,
ready.
maybe, right?
Waiting us.
And tomorrow.
Tomorrow we have also the many topics. Same time, we have to start 8:30 tomorrow morning. Okay, so for second day.
Okay. Let's wrap up today, and thank you so much.
Thank you so much, for all speakers.